He was there in the original program, I think.
We are live, please.
Good morning, everybody. I would like to introduce you to the 6th International Ophthalmic Conclave. The session for today is Cataract Surgery, Complications Unfiltered, What Went Wrong and What
We are live, please.
Good morning, everybody. I would like to introduce you to the 6th International Ophthalmic Conclave. The session for today is Cataract Surgery, Complications Unfiltered, What Went Wrong and What
We are live, please.
So, good morning, everybody. I would like to introduce you to the 6th International Ophthalmic Conclave. The session for today is Cataract Surgery, Complications Unfiltered, What Went Wrong and What
We are live, please.
Good morning, everybody. I would like to introduce you to the 6th International Ophthalmic Conclave. The session for today is
Sunil, whoever is there, can you please take care of what's happening?
Went wrong and what
We are live, please.
it is just going. Meeting everybody. I would like to introduce you to the 6th International Ophthalmic Conclave.
Sunil, no, that's support.
For today is
Sunil from the support, may I request you to take a look at what's happening? There's a loop going on.
It is just going. It's in a loop. I would like to introduce you to the 6th International Ophthalmic Conclave.
Confusion here.
Sunil from the support, may I request you to take a look at what's happening? There's a loop going on.
It is just. It's in a loop. I would like to introduce you.
Nandini, can you unshare your screen?
Okay. Yes, I'll just do that.
Is that stopped now, sir?
Yeah.
Okay, perfect, sir. So, Vincent, over to you, sir, for the session.
Yeah. Good morning, everybody. Hope you're enjoying your Sunday morning, and we will take off on a lovely and exciting session over here. It's my privilege to chair this session and moderate this session, as my good friend Dr. Partho is caught up with certain important commitments. So let's start off with the introductions over here. Dr. Partho Biswas is not here, but he's the immediate past present, and we all know he's a towering figure in All India Ophthalmological Society. And we'll speak first about Professor Boris Mulligan, who's going to deliver a keynote lecture on cataract surgery in small pupils. Professor Boris is an acclaimed ophthalmic surgeon renowned for his innovations in cataract surgery and invention of the widely used Mulligan ring. He is globally recognized for his expertise in complex anterior segment surgery, and right now he is based out of UCLA. So Dr. Susan Jacob is an internationally celebrated ophthalmologist, innovator, and educator, serving as the director and chief of Dr. Agarwal's Cataract, Refractive and Cornea Foundation, Chennai. She is globally recognized for her pioneering surgical techniques in cataract, cornea, and complex anterior segment surgery. She does travel a lot, teaching and educating colleagues. Dr. Bilal Hussain is a distinguished vitreoretinal surgeon from Bangladesh, associated with the Combined Military Hospital in Dhaka. I think he is also with the Bangladesh Eye Hospital. He has extensive experience in retina, cataract, and ROP management, and is known for his academic contributions. The other panelists, and Dr. Himani Chatterjee is another speaker who's a respected ophthalmologist known for her clinical expertise, academic involvements, contributions to advancing eye care services. She has been actively engaged in patient care, surgical ophthalmology, and professional education. The other panelists who are joining us today are Dr. Haripriya Arvind. As you know, she leads the Aravind Eye Care System in Chennai with a very vast experience. She has immense contribution to ophthalmology in different aspects of cataract surgery, and some of her work in endophthalmitis has been actually the kind of sheet anchor for treatment for a lot of us. Dr. Prakash Chaudhary is also from Bangladesh and from the Bangladesh Eye Hospital. He has a lot of contribution in cataract and anterior segment surgery, and we will hear from him by way of his rich comments. Dr. Sri Ganesh, as you know, is the CMD of Netra Dhama at Bangalore. And he is an innovative skill surgery, cornea, cataract, refractive surgery. He does a lot, and we look forward to his priceless comments. And wonder if Professor Namrata Sharma is joining us. But if she joins us and chips in, we'll be very happy.
She's here,
Over
sir.
to you.
Dr. Namrata ma'am is here, sir.
Oh, great, great. So over to you, Rolika or Dr. Tanushree, who would like to proceed with the next steps. Shall we have Professor Boris Mulligan give his keynote address?
Right, sir. We can proceed with Dr. Boris's keynote lecture. Over to you, Dr. Boris. So Dr. Boris Mulligan will be giving the lecture on cataract surgery in small pupils. Over to you, sir.
Good morning. It's my pleasure to be here with you, and I would like to thank you for a kind invitation to All India Ophthalmology Society organizing committee, and I will be talking about small pupils. And we know that small pupils make great surgeons good and good ones miserable, and for many reasons. Not only the size of the pupil matters here, but also the underlying comorbidity that are leading to the small pupil, such as inflammation, glaucoma, increased permeability of the blood aqueous barrier, all these factors that contribute to challenges in these patients. There are several techniques being proposed, such as this one, using different combinations of viscoelastics in a sandwich technique when adaptive, viscoadaptive, and viscodispersive viscoelastic are combined together to stabilize the pupil. Iris hooks, obviously, the one of the most popular devices that come to us from the seminal paper of Jean de Joanne, who is interestingly was a vitreoretinal surgeon, and in 1979 he published the letter in the American Journal of Ophthalmology saying that it's a good idea to use these hooks, flexible iris hooks, to expand and hold the pupil in the open position. And there were many pupil expansion devices over the years. Most of them were based on the groove principle. The groove principle is that the devices are having this groove in the outer portion in order designed to catch and hold the pupillary margin. Sometimes these grooves were not being smooth but serrated or interrupted, but the kind of the principle was more or less the same. Some more interesting device like Federman Cook ring was hydrophilic acrylic, and when you're injected into the eye, after hydration, the expander opens up and engages with the pupil. So there were a lot of interesting ideas around that. So our idea was to use the elements, the curled elements, to hold and fix the device to the pupil. And this idea worked very well. And in spite of the square device, the pupil was round and very stable. And these are the advantages of this device that I designed quite a while ago, including flexibility, injectability, and very low profile. Currently, there are many pupil expansion rings are on the market, made of different materials: nylon, polypropylene, silicone, nitinol. It's kind of most of them are quite useful, and depending on the market, they are more or less available in different parts of the world. So basically, we are now using the classic version and the second generation of the Malugin ring, which is thinner, having larger scroll gap and having greater flexibility, and we can use it through smaller incisions. Like in that particular case, this is a patient with previously operated glaucoma. We can see that the pupil was not very small at the very beginning, and that's why in that case I decided to use the 7 mm ring, which is the bigger one, as I was anticipating the pupil to be constricting during the procedure. And basically, the ring technique of implantation and engaging with the iris is quite straightforward. For the 7 mm ring, I like to use bimanual technique of engaging large scrolls, as it is very useful in at least in my hands, helping me not to overstretch the iris tissue. And as soon as the pupil is expanded, the procedure became more or less routine with capsulorhexis, fecal emulsification, cortical material removal, and IOL implantation. So the critical step here would be to remove the device at the end of the procedure, and there are many ways to do that. I do prefer disengaging the distal scroll first, following by proximal scroll, which is located nearby the main incision, and I'm using the same pupil insertion device to remove it from the eye. And you can appreciate how floppy the iris is during the removal of the viscoelastic. Pupil constricts, and that's kind of the end of the case. So basically, with two sizes, we are pretty much covering all different clinical scenarios. I like the smaller device for very small fibrotic pupils, and bigger device for intraoperative floppy iris syndrome. And my preference is to work with different devices depending on the condition. So this is an interesting case. I'm happy to share with you. This was a femtosecond laser-assisted cataract surgery, and the pupil was quite well dilated at the beginning. However, as we sometimes see after femtosecond laser was being applied, it's becoming smaller, and implanting the ring in the setting of the open anterior capsule is a bit more challenging. So you have to be quite careful not to catch the anterior capsulorhexis edge by one of the scrolls, which happens not infrequently, which is not really a problem. You have to recognize that issue in order to disengage the scroll and engage it once again. As far as in this case, the procedure become more or less routine, and this is a smaller ring, 6¼ which is, as I mentioned, my preference in most of the cases. About 80 to 85% of cases, I do like smaller ring. So this is a light adjustable lens. We know that light adjustable lenses are silicone, and these devices are a bit tricky to implant because silicone unfolds very quickly and sometimes not very predictably. As you can see here, when I'm injecting, so the unfolding was quite unpredictable, and the lens ended up in the upside down position, as you can appreciate by the haptic position, trailing haptic. So we need to to flip the lens. And interestingly, at that point, I realized that the ring was not perfectly fixated to the pupil because the pupil was expanded. So that was a kind of a delayed pupil dilation in that case. So anyway, we were being successful in managing that case and implanting this light adjustable lens properly. We know that on the back of side of that lens there is a blue shield, and there is no way you can adjust that lens if you're flipping it upside down. So that's basically this end of that particular case. And what was interesting here is that we started up with a small pupil that was constricted after femto laser. Then it was more or less okay after implantation of the ring. But when you can look at the third picture, this is just before implantation of the CTR, there was a kind of delayed dilation of the pupil, and we ended up with the ring being too small for this pupil. And I think that sometimes it's to be recognized earlier, and what I would be doing differently in that case, I will probably remove the ring in that case before implanting the IOL and then proceed with implantation. But again, what was interesting here was delayed dilation that was occurring during the course of the procedure. That is quite unusual. Again, in many publications, it was shown that pupil expansion rings, different designs, are more friendly to the iris tissue than the iris hooks. And I would probably recommend using any of the pupil expander as they are more friendly to the iris tissue. And I'd like this preventive approach and proactive strategy, saying that if you think that you need to use a ring, you don't need to hesitate. You have to use this technology, as the complications that may occur significantly outweighing the cost of the device used. And I thank you very much for your kind attention.
Thank you very much, Professor Boris Malugin, for that very enlightening lecture. And of course, the whole ophthalmic community is thankful to you for bringing us the Malugin ring. And wonderful case. And this does happen sometimes when you do put in a ring and then later the pupil dilates and then you're in a mess. You don't know which one to deal with first. And you had an added problem of the lens being upside down. Very well managed, and thank you for sharing that with us. I'd now invite the panelists. Anybody would like to put a question or a comment? Would the panelists, Dr. C. Ganesh, are you here? Yes, Sri.
Yeah,
You're muted.
Yeah, in that case, at the beginning of the procedure, as I do usually in all my cases, I inject epinephrine into the anterior chamber. So interestingly, in my experience, epinephrine is not working very well after femtosecond laser as it is working in the regular cases. So we know that prostaglandin release is engaged in that procedure that makes pupil myotic. So probably this was, in that case, there was a kind of delayed effect of epinephrine that was injected early at the beginning of the procedure, and then it starts working for whatever reason, 10-15 minutes or whatever late, and that sometimes may happen.
Thank you. If you could kindly stop sharing your screen, and Dr. C. Ganesh, you were making a comment. We can't hear you, Dr. Sri. Yeah.
Turn on the sound.
Yeah, you're not showing us. Yeah, now you're mute.
No, it's not muted.
I think he's
Still
gone now.
no sound.
Sir is unmuted, but his
Yeah.
Voice sounds new.
If maybe while Dr. Sri Ganesh comes online
Yes,
again,
Susan.
if I can ask a question, I know this is probably a question aimed to both Dr. Malujan and yourself, Suven. The last ring, the last one, the insertion of that, what are the tips to get that easily in? I mean, if you could both go one by one, that'd be really.
Uh, the bigger ring is a bit more challenging to engage. So that's why I think when I was showing my first video, I showed that I was using bimanual engagement of the proximal scroll, the scroll that is located closer to the incision. There is no difference in engaging with the injector, in injecting the ring, engaging the distal scrolls, but it's more challenging to engage the proximal one. So I like to keep the scroll and then use the hook, like Lester hook or something similar, to engage the iris with the ring rather than to push the ring forward. So I think that's more appropriate and more friendly to the iris tissue.
Yeah, a lovely question, Susan. Actually, if we have an open capsular access, the entire dynamics change. So, my first step is when you choose a ring after ring, iris hooks or whatever, is to inject a little bit of viscoelastic over the capsular access rim to lift off the iris so that we create space. Whether we're using a Mulligan ring or iris hooks or a B-hex, whatever we use, we need space over there so that we do not engage the capsular access. Like Boris said, it doesn't happen very infrequently with the Mulligan ring, less frequently with the B-hex because of the way the flanges are engaged. With the Mulligan ring, probably the control at the engagement of the helical coils is more remote because of the injector. So you cannot control exactly by lifting off the eye pupil margin. With the B-hex, because you're using the flanges and the control is at the site, you can engage the flanges under the notches and lift up the flange a little anteriorly, and you have an immediate confirmation whether you have engaged the capsular access or not. With flax cases, though now it is claimed that the strength of the capsular access is as good as a manual capsular access, but that fear probably always remains that there could be an issue. So it's just that we need to create space and be mindful. And like Dr. Boris said, that it's not a big deal if you do engage. It's more important to recognize and disengage the capsular access margin. That is more important. And be mindful that yes, this may happen after a capsular access.
I think they
Anything
should
else you'd like to add, Susan?
probably become very important if you've got a half a capsular access made and then suddenly you decide you want to use the pupil expander after all. And then, you might really need to be very careful about this fact.
Dr.
Yeah.
Boris, may I have a question? In case of, I'm Dr. Prakash from Bangladesh. So in case of a small fibrotic pupillary membrane to achieve the optimal dilatation, what is your approach, a stepwise approach?
I think that's not very logical to go with the pupil expander at the very beginning. So usually in small fibrotic pupils, you would like to check the pupil for posterior synechia, and if exists, you may lyse this synechia with a side port instrument. The second step would be to identify if there is a pupillary membrane is present, because sometimes just removing of this pupillary membrane will help you to expand the pupil. And as the third step, you make the decision on whether or not you will go with any pupil expansion device or hooks after that procedure. So basically, in most of the cases, you may consider doing that. However, if you are missing these first two steps and going directly, the pupil could be very small, like 3 millimeter, and you will be struggling with engaging the especially pupil expansion ring. So in this case, maybe stretching of the pupil would be a good idea to get it to the decent size.
Hello,
So that's
can
good
you
idea
hear me now?
actually. In my clinical practice, what I do
Hello.
follow,
Sir, you're
the
audible, sir.
two-handed membranectomy. So in one hand, I use the microaxis forceps through the side ports. In the other hands, I use the Y hook to support the iris so that there's less stress on the pupil. And then very gently I do touch the pupil, then use the pupil expression. That is my clinical practice that I share with all.
Hello.
I think removing the membrane is a
And
good idea.
sometimes when you remove the pupillary membrane, after then if I use the cohesive OBD, that's sometimes quite good enough to achieve the optimum size of the pupil. But the main key challenge is not only the achieve the optimum size of the pupil, the stable surgical fit, so that there is no iris prolapse to the side ports. And
Yes.
to achieve that, we have that the most important thing we have to keep in mind the pressure gradient below and above the iris. Always
Thank
we
you.
have to keep in mind the pressure gradient above the iris should be more than behind the iris.
Thank you for your wonderful inputs, Dr. Prakash.
Hello.
I think we will move on with the case presentations. Dr. Tanushree, are we good with that? I think we are good with the timing right now. Otherwise, we'll run short of time.
No,
So,
no. But, yeah.
could we invite the
Hello.
first case presentation? Yeah, Sri, we will just come back to you.
Sure, sure. I just wanted to know if I'm audible.
Yeah, now you're audible. You're good. You're good. Audible and visible.
Good.
You're looking almost like a saint now. Okay. So, the first case presentation will be by Dr. Bilal Hussain. This is Dr. Susan Jacob. Yeah, sorry, Susan. You're going first. So, can we please have your wonderful challenging case?
Is my screen visible?
Yes, there is something as CARES Prop 10 tips coming up on screen.
Oh, really? Why?
Yeah.
You should be seeing the 5F technique. Are you not seeing that?
No. We're seeing a red band in between. It says CARES Top 10 tips.
Okay, I am sorry about that.
Yeah, now we can see you.
Okay, just give me a minute, please. I will just do that.
Should we take on the next presentation and then you can come back, or you're good?
Just tell me if you're seeing it
Yeah,
properly.
yeah, you're
Now
good.
it's fine?
Yes,
Yeah, you're good.
Okay, now also it's fine, right?
Absolutely.
Okay, so I'm going to be talking about this new technique, the 5F intrascleral haptic fixation, which I had started some time back. It's probably a few of you might have heard of it, a few of you might not have heard of it. But what it aims to do is an intrascleral haptic fixation, which is flangeless, flapless, fibrin glue-less, and it also gives you fully covered and a fully tugged haptic fixation. So I have no financial interest relevant to this talk. And just to start off, let's see what are the problems that most intrascleral haptic fixations do face. You know, have you for infinity. Or if you just like to answer, because these are some of the problems that happen with
5F technique.
So the 5F technique basically helps you get rid of these issues. So let's just see what is done in this. I hope I'm audible. This is a patient with aphakia, and if you see what I've done is I've made two marks across and done a small conjunctival peritomy. These conjunctival peritomies are L-shaped, so it's very easy to fix the conjunctiva back without glue. And now if you see, I made two vertical cuts, and then I'm making a pocket to either side. And then from the pocket to the other side of the pocket, you have the chariot tunnel created with a 26 gauge needle. So this is basically the construction, the geometry of the construction. It's very, very simple, extremely simple to do. And you can see that the sclerotomy comes within the pocket. Now, what I'm doing is inserting an anterior chamber maintainer and then intravitreal triamcinolone acetonide. The usual principles of vitrectomy: do a good vitrectomy. If you're behind the pupil, you can get all the vitreous from the back without causing anterior prolapse of the vitreous. But also, if you don't want to do that, you could just put in two trocars and do a posterior pars plana vitrectomy as well. So what you've done here is put the IOL in, and then this needle bending is important. If you see, the needle is bent with the bevel being slightly visible, so it's temporal and it's a little superior so that the surgeon can see it easily. And this bend is applicable for both sides. So the same needle can be used for both sides. So you can see now what I'm doing here is the same needle, I transfer it to the other hand, and you can see both of them can be the single same needle which is used on either side for haptic externalization. Now you already have the haptic there. You could do a leading haptic first or a trailing haptic first technique. In this video, I'm going to show trailing haptic first. what you do is you go in through the pocket. So the sclerotomy is well covered by the pocket, and you go in and you just insert that haptic into that 26 gauge needle. You could also use a thin walled TSK needle, 30 gauge. But because its availability is little limited in some countries, you can use a 26 gauge needle also. So as you saw here, as soon as I brought that haptic out after railroading it into the 26 gauge needle, what I do is I put a silicone stopper there so that that haptic does not fall back into the vitreous while you're externalizing the other side haptic. The same thing is done. The handshake technique is used. The other haptic is grasped, and you go into the pocket, and then you go intravitreally through the sclera, base of the sclera, and then you make your bevel visible. And that is how that helps that the bevel becomes visible to the surgeon. It's facing to the side of the haptic as well as is visible to the surgeon, and that really helps you insert it. So both the flange, that stopper is taken out then, and the interscleral chariot tunnel was already prepared by us earlier, and you just tuck the haptic in and the case is over. So basically you don't need to create a flap here, and also you don't need to flange because flanging itself is associated with some problems, and these issues can be taken care of. Here you see the post-operative single vertical cut, the anti-segment OCT showing the well-placed sclerotomies which are hidden by the tunnel. So just a quick animation. What you do is just basically get that in, out, and then sequentially. And if you notice, unlike the Yamane technique where you have two needles within the eye at the same time, and one of the needles can be, a little uncontrolled while it's left unattended while you're attending to the other haptic, here it's a single needle externalization at each time. You can also use this technique for iododialysis repair. As seen here, there's an old glued IOL flap there. But you can see again, I've taken a Prolene suture, Prolene 60 suture, threaded it through the needle that's passed in through that similar tunnel construction. And then what you do is just flange the other end, not the end that's going to be tugged. So the flanging is, the role of the flanging for intrascleral haptic fixation is completely removed. You have just the intrascleral chariot tunnel, so no flange. And also the construction of the geometry of the cut gives you a completely flapless and a fibrin glueless technique. And so it really makes your surgery easier. I'm just going to show you the next modification that I've made to this technique, which is basically it's also pocketless now. So what I do now, which I have modified it a bit more, is this case you can see here. Similar, let's just skip through this. But what I'm doing here is just making only the vertical cuts alone. And then I have made intrascleral chariot tunnel. This tunnel is of course to the direction that the haptics are going to be externalized to. And then on the other side, there is going to be a small tunnel that got skipped in the editing. But what you can watch is I did not make the pocket. So the difference is that there is no pocket here. And instead of the pocket, there's a very small tunnel created there. So you can see the tunnel, the small tunnel being created. And that tunnel is intralamellar, intrascleral. So again, the point at which the sclerotomy enters the eye is well within, it's away from that vertical cut. So the sclerotomy is again well hidden within the scleral layers. The rest of the surgery is the same. You can see that this is put so that while externalizing the other haptic, this doesn't fall in. Also, another tip is to not push this silicone stopper too much down, because if it's too much down, it doesn't give you enough mobility of the haptic to come out through the other side. So you have to keep the stopper somewhere to the edge. And then again railroaded in and then brought out. And once both of them are out, it's tucked in. And then you simply just cauterize the conjunctiva together. So this video, actually, this is the last video, and I will stop with that. In fact, I'm going to run through it. This shows you the pocketless modification. I'll just show you that part alone. So again, just look at that, the vertical cuts, intrascleral chariot tunnel. And then what I want to show you here is the opposite side. It's just that much. That's all that's required. You have to create some tunnel, the vertical cut. You're not wondering where you made that tunnel or where you should enter from. You have that small pre-prepared entry for your 26 gauge needle, and then you can just go in from there. And you can see that really, really easy to get it out. Am I visible now also?
Your video is visible.
So this is a patient. Okay, this is a patient with the limited corneal visibility. You can see that, but still it's really easy to bring it out. The first one has been externalized, and then the second haptic is being, and then now the second haptic is also being transferred from hand to hand using the handshake technique. Remember, you've got a small bevel length of funnel on the side that the sclerotomy is going to be made. So that is the modification instead of the pocket. And on my side, the video is hanging a bit, so I don't know what's happening there.
It is hanging
And
over here
basically,
also.
right? Okay, so that's basically it. I think that was what I wanted to show, and my time also must be up. I'll come to the end of my presentation. Thank you.
Thank you, Dr. Susan, for that wonderful 5F. I'm waiting for the day it's going to be with AI and robotics, it's going to be surgeonless also. Yeah, so Dr. Sri, if you could offer, I know you've done some work on scleral fixation and the dumbbell technique and things like that. Dr. Sri, if you're still with us, yes, can we have a comment from you?
Nice video, Susan, and always some new innovations coming from you. Yeah, I think basically with the glued IOLs also, the glue was kind of, you always had to make a tunnel, and the glue was just to give that additional kind of surety that the haptic is not going to slip through. So if you have the correct length of the tunnel, then I think the lens should be quite stable without glue also. And of course, the only thing is you have to reflect the conjunctiva here. I still do the four flange technique. PMMA lenses, or even I have a foldable lens with a swivel where you can use a foldable lens to do the um, scleral fixation with the four flange technique. And the thing with the four flanges, when you flange the outer aspect, it should be quite tight. So the mistake that surgeons do is that if there is some play and if it's a little loose, that's when the conjunctival erosion happens. But I've done hundreds of these, and then I've not had that problem as long as it's very tight and flush with the sclera and it's not loose. You don't get conjunctival erosion. So you don't have to reflect the conjunctiva.
Thank you. Dr. Haripriya, would you like to add a quick comment or a question?
Yeah, a great surgery. Yeah, I don't do a lot of the flanged technique or the scleral fixation. I do more iris fixation. But what happens in case you have any issues with the haptic? If there is, the haptic, because of the maneuvering, there's some damage to the haptic. How does one proceed?
Yeah. So basically, there are certain tips to avoid that from happening. You have to do a handshake technique. You have to catch the haptic about 3 millimeters from the tip of the haptic, so that it's not too long a length of haptic, which can then, change its shape when you're trying to railroad it. It should be a tight bit of 3 mm, which can easily go straight into the bevel. The bevel should be visible. So that's why I said the bevel bending is important. The needle bending is important. It should be laterally. It should be to the facing the haptic, the entry angle of entry of the haptic, as well as in a way that is slightly upwards towards you as well, so that you can easily see the bevel. You're not having to sort of look over and hunt for the bevel. So I think those things really help it. The advantage, of course, is that you don't have a flange and all the other associated problems, such as, exposure, flagpole syndrome, rotisserie, and all these things. And also, as compared to the glue dial, you don't have to have the problem of flap creation and availability of glue. So these are the issues for people who are already doing intrascleral haptic fixation, and especially for those who are doing Yamane. I think it's a very easy way to transition over into a flangeless technique, because the people who are doing Yamane are already very used to actually railroading that needle into that haptic into the needle. So for them, they can stop and get rid of all the problems that can be associated with flanges just by opting for this. And the incision construction is really simple. So it's just vertical, one intrascleral shatter tunnel, and a very small, just the entry of the tip of the 26 gauge into the other side. And that also you do just so that you know where you're supposed to go, because you don't want to be holding the haptic with one hand and then trying to find out what is the measurement you have to go for. So if you just may mark that with a pen, then you know exactly where you should be entering with the other hand, and everything is like absolutely centered and absolutely without any tilt or say decentration.
I think, thank you, Dr. Susan. I think Dr. Haripriya was more trying to address what if the haptic breaks or bends beyond repair.
Breaks or bends, then you have to do what you would do in any other intrascleral haptic fixation, which is take it out and explant it, reimplant another lens.
I guess that's why she's not fond of it.
But that could happen with any technique.
Like me too. So anyway, thank you so much, Dr. Susan, for that very interesting topic and case. If we can move on with the next presentation, I'd like to invite Dr. Bilal Hussain from Bangladesh. He's got a very interesting background. He's a vitreoretinal surgeon, cataract surgeon. So let's see what he has in store for us. Dr. Bilal, can you please share your screen?
So am I visible and audible to everyone?
Absolutely, yes.
So hello. So I'm very much grateful to All India Ophthalmological Society to invite me to share our experiences regarding in this session. So I will share a case with cataract, definitely from what went wrong and what we have learned from here. So this is a case of a dense cataract with iridofontal coloboma.
Can you please go on to full screen?
Yeah, it is full screen probably.
Yeah, the play mode.
Now it's okay, sir?
The slideshow. No, we're not getting the slideshow. We are getting the whole slide panel on the left.
Sorry.
You have to go to the slideshow.
I think the slide is not moving as well.
It's
You have to
just
go to the slideshow.
You
Can
may
you
have
go to the slideshow from the bottom? Yeah, what you can do. No, we come to
think
the
now
next
it's okay.
slide. So, Dr. Bilal, what I would like you to do is stop the screen share. Open the same panel on your laptop and then start the screen share and then go to the slideshow.
Right. Thank you so much for giving me 1 minute time. So I will stop share. Now I think it's okay.
Yes, I think we have come to, we can see your whole full slide. Yeah, that's fine.
Thank you so much. So this is a case of dense cataract with iridofontal coloboma. So there was a posterior synechia. So after releasing the synechia, we have used 2 iris hook. And here you can see while starting the capsulorhexis, we can see also few phacodonosis. So there is a few zonular dehiscence also. So as it was a one-head case, so I was a bit extra cautious to do a capsulorhexis so that it may not go went or extension to the periphery. And there is also it was a microcornea. The horizontal diameter was only 9 millimeter. So we have used the cystotome to use less space while doing the capsulorhexis. But ultimately, we have done a considerable capsulorhexis. So as there was a phacodonosis also, so we have created space before inserting a capsular tension ring. So we use both viscodispersive and coercive to use a soft shell technique. So we use guard at the spatula so that it does not go at the sulcus. And ultimately, the CTR ring was inserted successfully. And there was a full rotation of the nuclear matter within the capsular bag also. So after started the phacoemulsification, so the lens fiber was sticky and leathery, so it was very difficult to separate. But while removing the cortical matter, I found there was an iris prolapse and there was a posterior capsular tear. So after anterior vitrectomy, while I was trying to bring the nuclear matter with the, so after anterior vitrectomy, I was supposed to bring the nuclear matter with the help of irrigating visco, but ultimately it was gone more down and ultimately there was nucleus drop. So for this instance, we have converted the case to the persplanar vitrectomy. So doing the vitrectomy and completing the whole vitreous, then we have removed the nuclear matter. As the nucleus was a bit hard, so it was not a wise decision for me to use the phragmatome. So through the suction mode, we have taken it from the vitreous cavity at the anterior chamber area, and subsequently with irrigating vectis, we have tried to exteriorize the nuclear material. At this moment, we have used the spatula to protect any inadvertent trauma to the corneal endothelium. While removing the nuclear matter, you see that still it was attached one piece to the another piece. So it was confirmed that posterior plate was not separated properly. So ultimately, whole the nucleus matter was removed, and there was a still unseparated posterior capsular plate. So after completing the whole vitrectomy, along with we have removed the capsular tension ring also. Then after repositioning the iris, the wound was constructed a bit for a stable anterior chamber. Then we completed the vitrectomy and also endo laser for protection at the colobomatous margin. Then we have decided to implant a scleral fixation IOL. So after forming the anterior chamber with ear, the window was stitched and AC was well formed. Then at the post-op there was a bit corneal edema with formed anterior chamber. But after 3 days, corneal edema was a bit cleared and there is a comparatively good vision.
Thank you, Professor Bilal, for that wonderful case. And of course, your VR background helped in manage all that difficult situation. So are you going to speak more on this?
No, actually, this was my case. Now this is the from discussion that what actually was wrong in this surgical procedure and how we have managed it. Thank you so much.
Thank you again. So, Dr. Haripriya, you have a vast experience with subluxated cataracts, rings, and all sorts of things. Would you like to make a comment?
Yeah, thank you. Can you please stop sharing, Dr. Hussain? I think I should,
Sure.
that this is a very challenging case, and congratulations on sharing this case. A lot of points to learn. I'm sure ultimately the patient saw well, having seen through that black lens earlier. I mean, there's no one way to approach these cases. The one aspect is that in coloboma eyes, especially in these kind of very advanced cataracts, I find the chance of having a rhexis tear at the site of coloboma is very high. This happens later during the phaco. Even if the rhexis was intact initially, this tear can happen even later, especially if a CTR is being placed during the CTR insertion or even later. So this is one situation of subluxation where I try to avoid placing a capsule tension ring. I know there was all the reason to place it because of the phacodonosis, a very advanced cataract, but I would, as much as possible, try avoiding that because the capsule can split at any time during phaco. And second thing is in these lenses, because of the absence of zonules and once it's a capsule tear, again, once that is identified, converting immediately like you did is the best possible solution. And a bimanual approach can help. But of course, beyond all our best efforts, there can be the situation where the nucleus dislocates into the vitreous cavity. I also find in these eyes, like this, especially this combination of microcornea and coloboma, who have a very high chance of DM detachment. I mean, not a full DM detachment, but a high chance of a DM strip, which can progress into a detachment if not taken care of earlier. So I did not go too much into the cornea while making the entry for the wound, for the tunnel. I mean, try to make it a little more sclerocorneal if possible to avoid this progressing to a DM detachment. Yeah, some of my thoughts.
Wonderful tips, wonderful tips. And actually, this cataract was very, very hard. And as we could see with the microcornea, and the risk of the capsule tearing and the nucleus dropping was very high. And since the surgeon is a VR surgeon, it was a really comfortable situation for him. He was well prepared. But any of us who are pure anterior segment surgeons should probably have a definite VR backup immediately available because these have a high propensity of going down. Anybody else would like to add a comment or ask a question?
So when I think in
Yeah.
the patients who have got microcornea and a very hard cataract, I might just go in for an extracapsular cataract extraction to start with, so that the lens is out, and then you can decide about how you want to fixate the lens post that. You can either put into the back, but because the lens may also be small, you might have some crowding of the haptics within it. So another option to do is just go in for a glued intraocular lens. Or in, now that I do more of 5F and not glued, I would probably do a 5F technique. So that is one way of looking at these patients, because the cornea is small, there's not much space, hard brown cataract. Phaco is definitely going to take a toll on the endothelium as well without space. So that's one way of managing it. We can't hear you, Suven. At least I can't hear you.
Yeah, I'm sorry, I was muted. So thank you very much, Dr. Susan. And I think we've got a similar case coming up next, so we will have more discussion on this. So next, it's my privilege to invite Dr. Himani Chatterjee to present her case, and let's hear how she spices it up. Dr. Himani.
Yes, sir. Very good morning, everyone. Respected chairpersons, am I audible?
Yes, you're audible, and we can see your main screen. Whenever you
Yes.
go to slideshow, we will see the whole. Yeah, that's better.
A very good morning, everyone. Respected chairpersons, distinguished faculty, seniors, and colleagues. At the outset, I would like to thank AIOC and Dr. Parthu Bishwa, sir, for giving me this opportunity. So today I would like to present a similar case as Dr. Bilal sir had presented. So it is a challenging case. It was a one-eyed patient with microcornea and coloboma. So this case taught me a very valuable lesson in preoperative planning, intraoperative adaptability, and complication management. So this was a case of a 45-year-old female with chief complaints of progressive blurring of vision in both the eyes since childhood. So on examination, her right eye had a vision of finger counting 1 feet with microcornea of 8 mm, NS3 grade nucleus, iris coloboma, and a corresponding choroidal coloboma, Wiedemann type 1, involving the fovea. And the left eye had undergone a cataract surgery 3 years back, mostly probably an ECC, and the patient was left aphakic. She had a vision of PL plus PR inaccurate in the other eye and had a cloudy cornea, which did not allow us the posterior segment visualization. So challenges in this case was a small complex anatomy with nystagmus, poor visualization, the IOL calculation, and added to that the zonular weakness. So let us start the case. So after staining the capsule and filling the anterior chamber with OVD, I started the capsulorhexis using the cystitome away from the zonular dehiscent area. But then I noticed that the zonular laxity was not allowing me to proceed with the cystitome. So I completed the microrhexis with the microrhexis forceps. So after hydrodissection, I placed a CTR in the back to stabilize it. Secured the iris with the iris hook, and also used the same iris hooks to stabilize the bag as well. Since the eye was small and it had a very small anterior chamber, it was very difficult to maneuver the phaco probe inside. So with very low phaco parameters, I proceeded with the phaco emulsification without maneuvering too much. As Dr. Haripriya ma'am said, these cases have a very high tendency to get a PC rent. So I had a similar experience with this. Despite all the precautions taken, as I was filling the chamber with OVD, I realized there was a tiny PCR exactly near the zonular deficient area. So I immediately plugged it with the high molecular weight viscoelastic and proceeded with multi-piece IOL implantation in the sulcus. Stained it with tricot and did the viscoelastic. So learnings through this case was that a thorough preoperative assessment is very important in this, and timely recognition of the zonular weakness as well. Slow and controlled phacoemulsification with low phaco parameters, and an early recognition of PCR and its management to avoid vitreous loss. Take-home message would be, in a complex eye like this, the goal is not to avoid every complication, it is to anticipate the challenges, manage the complications effectively, and safely rehabilitate the vision. Thank you once again. It's an honor to speak amongst all the stalwarts of ophthalmology. Thank you.
Thank you, Dr. Himani. A very interesting case, and today we saw the spectrum, the whole spectrum, from a softer cataract to a really hard one. Thank you for actually having giving us an opportunity to discuss this. Is Dr. Boris still with us? I don't see him over here on the panel now. If Dr. Boris is not here, I would like to invite anybody. Dr. Prakash, would you like to make a comment?
Yeah, that's a very educated video. And before putting the CTR, I would like to put the capsular hook to give the support of the, if there is any general dialysis, and I inject the cohesive OVD underneath the capsules to lift it up to create a space. Then I will proceed for the phaco, and if I think there is some journal for equatorial support, then I'll go for the CTRing, not at the beginning. And once PCR occurs, then I will not take out the iris hook, because my plan is to implant the IOL in the sulcus for optic captures. And that is one, because if I remove the iris hook, the visibility will be more compromised. So in that case, I prefer not to remove the iris hook, place the IOL into the sulcus and do the optic captures. That's
Wonderful.
all.
Thank you. Dr. Sri, are you still here or you left?
Yeah, I'm here. I'm very much here.
Yeah. Dr. Sri, would you like to make a comment? Or...
Yeah, congratulations on managing this difficult case. I have a question. Why would you put a three-piece lens in the sulcus when there is a coloboma and a zonular weakness? Because if the zonules are weak, if there is no zonular support, then over a period of time, this three-piece lens can kind of dislocate into the vitreous. So that is my whole concern. So if you have a PCR, if you have zonular weakness, then probably it's better to remove that bag. It's not going to kind of help keeping that bag there, because it's going to contract, it's going to go for PCO, again, difficult to manage, and then do a scleral fixation.
I think I can take that question, Sri, on behalf of the speakers. I think the zonular weakness over here is a segmental. It's a segmental zonular weakness. The rest of the zonules are okay. So it is okay to keep the sulcus fixated lens, because the rest, it's like a traumatic cataract where the zonules are only in a segment that it is weak. It's not a global zonular weakness. Like
what I've seen is, over a period of time, there's a tendency for the lens to kind of rotate. That can happen.
Okay.
And it migrates, and then the haptic finds its way at the area where the zonules are weak, and then starts dislocating. I have found that, I mean, after a few years, this can happen. So looking at the long-term outcomes, probably, and that bag anyways is not functional. It's not holding your lens. It's going to go in for a PCO. It's going to contract. There's going to be phimosis. And all those things when you have zonular weakness. So it's probably better to remove the redundant bag and do a scleral fixation.
So, Dr. Himani, you know what to look out for now.
Yes.
And anything you would like to add, Dr. Himani or Dr. Haripriya?
Actually, I would do what Dr. Himani did. I would place it in the sulcus and do an optic capture in the rexus margin if it is matching, if the size of the rexus is slightly smaller, and align the haptics horizontally like she has done. And we find that that actually works quite fine in the long run, is what I have seen. But I think it depends from patient to patient, and each surgeon's experience also varies. So I think it's important to follow up the patient. That I think is a given, to see how stable the IOL is. That's critical.
Thank you very much, Dr. Haripriya. So we know what to look out for. We know how to manage these. And right now we are right at the end of the time of the session. I'll hand over the session to Dr. Tanushree to thank all the speakers and close the session.
Thank you so much, sir, for handling the session and moderating. We had such beautiful surgeries which were so precise and so many things to learn from what we have faced from the other things. Thank you so much for this enriching session. Thank you, everybody, for joining.
Thank you, Dr. Arnav and Dr. Tanushree, for your wonderful contribution, and all the panelists and speakers. Look forward to seeing you sometime soon.
Thank you.
Thank you.
Yeah.
Thank you so much.
Thank you.
Thanks to all the speakers.
Bye-bye.
Thank you, sir.
Do
Thank
we
you,
have any
Tanushree.
session coordinating session?
Yes, Arnav, I think we have some time before the next session begins. So that's okay.
11:30.
The session, like the hall, will remain still live and active. Can you hear me, Arnav?
Probably there is the part to take a group picture in the instruction. So we can take a picture
Yes.
also.
Yes, I guess, Dr. Bilal, everybody has logged out, but what we can do is we can
Okay,
go
whatever
and
we had. Yeah,
go
yeah,
back
yeah.
in and take a screenshot. Dr.
I-
Arnav, can you do that, please?
Yes, I've done shared it on the group as well.
Yeah,
The
yeah.
session
You can
coordinator.
share as
I'll
a
share with you.
on the chat box here if for people to take, so that Dr. Hussain
Yeah.
can also save it on his system. So we are still live. So the session remains live, and I think we have a gap. At 11:30, the next session begins over here. So the portal is live, and whenever the next session speakers join, they can check their screen and go from there.
Share the picture.
Arnab, I'm switching off the screen. I'm hopping on to the next session. Okay. So, I mean, just send the screenshot to us. I'll forward it to Mr. Bilal, Dr. Bilal. So, can you please send it to me? Hi, Pranesh.
Hello.
Hi, Dr. Pranesh. Dr. Pranesh, the link is going to remain live, and so I mean, because we cannot stop streaming, so you can continue with the session as they join. Like, you can actually take their screen share and check their slides as per their choice.
Okay.
I think nobody has joined yet. You have joined early, but you have the session open for you already.
Oh wow, great. No, actually, I didn't get the link. Actually, I thought the earlier mail which they had sent, I thought the link was it. Then I called up Kripal and asked him. It was I was really kind enough for him to send it for me. So I just wanted
Yeah,
to check.
I've put it on the group as well. It's on the group of session coordinators, hall 123.
Yeah, yeah, I know that, but there's so many links I couldn't. So hi, okay, money. Okay, fine. Yes,
Sorry for that.
no, not a problem. It's not. That's perfectly fine. I think you're
Okay.
doing a humongous task. Thinking about what you're doing. No, I'm getting a mini epilepsy. I'm not joking.
Nothing like that.
You're doing a much bigger job. So this is nothing compared to that.
No. Thank you so much. And you have your PPT for the rise of lens-based refractive surgery, right?
Hey, PPT. What do you? I'll do it. I'll make it now. What PPT do you want me to make?
No, I'll send it to you on your chat. I understand that there are too many messages on your chat box. I will send it to you on your chat. 2 minutes.
No, Shastolika. I'm sorry. I'll just look into it.
I'll just send it. Okay.
Oh, you see. Let's. I should start now. End of the month is best of all. Rolika, I got it.
Yeah, I
got it.
messaged you as well, so
Yeah, I
it's
got
there
it.
with you. Okay. I'll just be back.
So, yeah. Okay. Okay. I have to change my.
Finish your background.
Yeah. I'm working on it. I am working on it. I'm changing it. We don't care. Yeah. Good. Change Rolika. Mine same as yours. Rolika, I've got the presentation. So how do we roll?
Sorry?
How do we roll? So like after each talk, should I go on to the next, or like should we give the panelists comment to speak upon? Is there an order of
I would wait for Dr. Anshika because she's the moderator for the session, right? So once Anshika joins, just ask her once about how she would like the flow. But how usually everybody is doing, they're just like the presentation that you have, just share that initially for everyone to see and introduce the session and open the session and hand it over to the moderator.
Okay, that's it, right? Do I have to do
Yeah.
anything else apart?
And then please maintain the time for the session. I'll call you up, Pranish, because we're already live. I'll call you up on the phone and I'll tell you.
Okay.
Pranish?
Yeah,
Pranish,
Rolika,
can
yeah.
you share the slide over here?
Yeah, I'll share.
Can you put it up so that we know that they're around?
Hey, hands down, 100%.
The session slide.
Hello, hello. Hi, madam. I'm Dr. Pranesh. Rolika, I just spoke to. Hello, am I audible?
Hello.
Can you put it on full screen, Pranish?
You're not able to see my screen share, is it? Just 1 second.
Yeah, like screen share to full screen.
Right, float meeting controls. Slideshow from beginning. Perfect. Rolika, I spoke to
Yeah,
madam. So she's saying that Anshika ma'am told that we'll have discussion in between talk for say every
sure.
after every talk.
As per the moderator, that's absolutely fine.
Yeah. Fine.
Okay, I'll just be back.
Hello.
Hi, Milan.
Hi, Alan. How are you?
Hello.
My
Hi.
pal?
I'm,
Hi,
I'm
Milan.
fine, and you?
I'm very well, thank you. Who's on support today? I just want to check whether the slides move correctly for me.
You can check, sir. I'm there, so you can.
Okay, so let me share this. Say someone else is sharing.
Just 1 second, sir. Yeah, you can share, sir. The floor is yours.
Okay. So let's, here we go. What happened? It's not, okay, share again. Say screen sharing is paused for some reason.
Oh, you have started sharing, sir. I think I can see that Dr. Milind Pandey started sharing the screen.
No, it's not doing it.
Respected all, I've shared the background image on the chat bot. You can use it if you want.
Let me try again. Share window. Oh, hold on. It's the wrong window I'm clicking on. Bear with me.
You can share the entire screen if you want, sir. That would be easier.
Okay, let's just go entire screen. Okay.
Yeah, that's it, sir. Perfect.
Hold on. We still need to work out.
You need to do it full screen.
Yeah. There you go. Is that better?
Yes, sir. Better.
Now, yeah.
Now, let me just check. Will it change? Is the slide changing?
Yes.
Yeah?
Yes, sir.
Perfect. Good. So that's working. Good. So I can stop sharing now?
Yes, sir.
Perfect. और मेरे पास क्या हाल चाल?
बस आप बताओ.
बस अभी I've just landed in Gurgaon.
अच्छा. I
Just
thought
here.
you were in Goa.
Huh?
I thought you were in Goa.
गोवा है? नहीं शर्ट तेरे लिए शर्ट पहनी है ऐसी आज.
हाँ, उसीलिए मैं बोल रहा हूँ.
नहीं I've been here for I've been in Bangalore.
Okay.
We started the first pilot for custom lens.
Okay.
So that is what I had come for.
Okay.
That's good. All well?
Bus. Good.
Good morning, sir. I am Dr. Anshika. I'll be moderating this session today, sir.
Good morning, Dr. Anshika. I'm very well, thank you.
How are you,
Good.
Anshika? मैंने गौरव को
morning.
भेज दी है. He had asked for a slide.
हाँ जी, sir.
उससे ले लो. I just sent it to him.
ठीक है. Sir, I was asking that we will be going live. Dr. Pranishan, how long will we be going live?
I think it's already
Starts at 11:30, ma'am. So
All right.
we should
So,
go live, I suppose.
all right. So, sir, then I would be inviting you for the welcome address in the beginning, and I would introduce you then and there, sir. And
Okay.
then your talk would be second last, sir. And so after your introduction, I would follow up with all the faculty.
Mera to I just showing some clinical cases, one or two. That's it. Yeah.
Hanji.
So whenever you
So I'll introduce you in the beginning itself then.
So did you get it? The slide.
So not yet.
Gaurav?
In a minute, I will be
Good
getting
morning,
it and then
everyone.
we
Good
can
evening.
start.
Gaurav, you can send the intro slide.
Yes, I'll do it.
Yeah, you can show it, whatever. Chalo.
Hi, Alin, and hi, Milit sir.
Hello.
Hi. So
Good
can
to
we
have you.
start?
Thank you for sparing time for us.
It's a pleasure. It's an honor. Thank you for you.
Dr. Pranesh, we can start the
You
session.
can start. I'll share the slides. Yeah. Rodika, is my slide visible?
Yes, they're seen. Perfect.
Hi, dear all. I'm Dr. Pranesh Ravi. A very good afternoon and warm welcome to all the senior consultants and mentors here. So, for this session, the rise of lens-based refractive surgery, in this Sunday afternoon, we have program directors, very stalwarts, Dr. Gaurav Luthra and Dr. Mahipal Sachdev sir, presiding this session as chairpersons, and we have Dr. Anshika ma'am as the moderator. We have Ashwina Agrawal sir, Titiyal sir, Kumar Dr. sir, Partha Biswa sir, Rajesh Sinha sir, and Ritin Goyal sir as panelists, and Dr. Alan Said from France, Dr. Gaurav Luthra sir, Dr. Milind sir, Dr. Raja sir, and Sonu sir as speakers, where we'll be talking about ASOCT in ICL sizing, RLE when and when not, ICL Guru for perfect sizing, phakic lens complications, and sizing dilemma. And we'll have a discussion in between. So let's move ahead and have a welcome address from Dr. Mahipal sir.
Good morning and good morning, I think, to everybody. Welcome to this session, which is going to talk about lens-based refractive procedures. As we all know that refractive procedures are something which are one of the most commonly performed procedures on the eye. And the accuracy, the predictability, and the outcomes with these refractive procedures are really fantastic. And over the years, only one thing has happened, and that is a refinement in the outcomes of these procedures. So essentially, as things stand today, the refractive procedures are either cornea-based or they are lens-based. And within the lens-based, you could have either a lens replacement procedure or a lens additive procedure that is there. Or you have what is known as combination. So within the cornea, you have other procedures like you have the intacs or the cares along with the TCAT. There are several procedures that are there. So there could be combinations which could either be put as bioptics or trioptics. But over the last couple of years, I think the lens-based procedures are increasing both in numbers and in accuracy, as also the spread in which we can do these lens-based procedures. So we would be discussing the lens-based procedure, whether they are the additive lens-based procedure or the subtractive or the exchange lens-based procedures in this particular session. And I have with me Dr. Gaurav Luthra, who will be co-chairing the session, and Anshika, who will be moderating. We have speakers, and I wish to thank them for joining in. Dr. Alain Sad from France and Milind Pandey from England, and Zaldivar would be joining us, and we'll be talking about the finer nuances of getting the good outcomes which are there. So without much ado, we can start on the session, and Anshika, I'll just hand it over to you to take the session through after the introduction of the esteemed faculty. And then we can have the talks. In between, we'll have discussions. So we have about 4 or 5 talks and discussions in between. So I welcome all of you for this particular session, and I hope that all of you go back enriched with a lot of these, because the speakers here have done extensive work in how to improve the outcomes of the various procedures, how to select the various procedures, what would be the patients who would be wanting to get these procedures done and the outcomes that would come out of it. So over to you, Dr. Anshika.
Good morning and good evening and good afternoon to everyone who is with us today. And I welcome all of you to this session of Rise of Lens-Based Refractive Surgery held by AIS International Ophthalmology Congress 2026. So let me start by introducing our first speaker for this session. So our first speaker for the session is, it is my privilege to introduce Dr. Alan Saad, who will be speaking on ASOCT-based ICL sizing and vault prediction. He is an internationally acclaimed cornea, cataract, and refractive surgeon whose work has significantly shaped modern refractive surgery. Based at the Rothschild Foundation Hospital in Paris, Dr. Saad is widely recognized for his pioneering contributions in corneal tomography, biomechanics, keratoconus detection, artificial intelligence-based refractive screening, and advanced corneal transplantation techniques. With more than 75 peer-reviewed publications, multiple international awards, and key innovations such as the score analyzer and contributions to the Pearl IOL formula, he continues to influence clinical practice and research worldwide. Please join me in welcoming Dr. Alan Saad.
Hello, everyone. And thank you for the invitation. Should I share my slides now?
Yes, sir, you can start.
Okay, thank you. So, screen. So can you see my screen?
Yes, Alan, we can see it. Yes.
Excellent. So thank you again for the invitation. It's an honor for me to be joining this meeting, even if it's an early morning in Paris. Here are my financial disclosure, and I would like to thank the team at the Rothschild Foundation who helped me to work on this project. So I will be talking about how we select our ICL size today and what we can do to improve this. So we know that ICL surgery, it's well recognized now as a very effective surgery with very rare complications, and most of the complications are related to a problem in the vault. So what can we do, and why is that? Problem in vault is rare, that's correct, between 0.21 and 2%. However, when it occurs, you have to do something, go again, perhaps make an exchange. So almost all of us, to do the calculation now, we go online on the software proposed by the manufacturer, which is Stella, and we enter some specific parameters, which are biometric parameters, the white to white, as measured by a different way, the anterior chamber depth, and some other parameters. However, it's known that it's a very high variation in those measurements depending on how you're gonna obtain them. If you obtain them with a caliper, it's not the same as if you obtain them with a Lenstar or with IOL Master or with a Pentacam. And you have to adapt those measurements by reducing them by 0.1 millimeter, 0.2 millimeter, etc., depending on how you're gonna get them. And those correspondence are like described by the manufacturer. However, I mean, we're in 2026 and we're still applying a methodology that is not really precise in order to calculate the size of a lens that we're going to put in our patient's eyes and that we want it to remain for as long as possible. So different studies explored the different available nomograms used to better calculate the size. And you can find this online. Basically, almost all of them rely on biometric parameters measured either with optical biometry, with corneal topography, with anterior segment OCT, or with UBM. You have online, you can find around 14 different formulas. Again, almost all of them based on those different parameters. We described and published a few months ago a new algorithm based only on anterior segment images, not using any biometric parameters, not using any number, just the OCT image. How did we validate it? We validated that on 863 operated eyes that an external center, two external centers basically from Dr. Nurhan in Munich and Dr. Tobias Dunker, who sent us OCT images of patients that were implanted with ICL. They sent us the pre-op images. We run our nomograms and send them back the evaluation of our nomogram, and they compared the results of what was saying our nomograms to the true results obtained with those patients. And this nomogram is now available online. You can go not on the Stella or on the OCOS platform. You can go on SafeVaultICL.com, which is available for free for anyone, and upload the OCT, anterior segment OCT. It works now with the anterior OCT from Heidelberg, but it's being adapted to other OCT. For now, it should be used only with the anterior OCT. So you just upload the image. It's anonymized. There is nothing that remains online. You add the ametropia, sphere, and cylinder, and you run the calculation, and then you will obtain for each ICL size what is the predicted volt by the formula and what is the percentage of chance to be within this size. So for that example, if you put a 12.1 size lens, you have an 83% chance to have a 615 microns of volt. So you would select that lens because this is the highest percentage of chance to have it. So this is now available online, as I said, with the anterior OCT, and it's being validated on other. So what was the result with this software? You can see this is the SMI, suggested size by our algorithm, minus the implanted size. And those are the results on the 863 eyes that were included. Each time we had, it was retrospective. So each time the ICL size was very high, which is within the right size of the screen, of the dashes, so with a volt above 800 microns, our algorithm was suggesting a one size or two size smaller ICL. This is the right down green squares that you can see on the screen. And each time the obtained volt was low, below 200 microns, well, in fact, our algorithm was suggesting a one size or two size a bigger lens. So it was working quite well. And in those cases, 22 eyes underwent an ICL exchange. In fact, 18 of those 22 would have been avoided if our algorithm was used. In that 863 patients, there was 26% that were outside the 250 and 750 microns volt, which means that they represented a quite difficult group because the classical formula were not able to suggest a correct size. And despite that, the algorithm worked well. So we said to ourselves, well, the most complex cases are the cases that are undergoing and they're having an exchange. So let's try to select patients who had an exchange and to retrospectively evaluate what our algorithm or other algorithm would have said. So we selected 43 operated eyes of 31 patients who required an ICL exchange due to sizing issues. So those are the complex cases that are not easy to estimate. And I thank again Dr. Tobias Dunker, Dr. Nohan, and also Dr. Bader Hayat, who shared those cases with the cases that we had. This is the volt after first implantation on those cases. So you can see most of the implanted cases were above, have a volt above 750 or below 200 microns volt. Only 3 of them had a volt between 250 and 750, but they had rotation, which means that the ICL was probably too small. And so we ran 5 formula. We retrospectively compared 5 formula: the Kim formula, Nakamura, EPB formula, SafeVault, and the HATA formula. And here are the results. We found that there was a match between the implanted size and the formula recommendation. So which means that the formula was recommended, not the correct ICL, because obviously the volt was too high or too small. When, well, for safe volt, in only 17% of the cases, safe volt was recommended the size of the form of the ICL that was implanted. HATA, it was 21%, and you can see that for Kim, Nakamura, or EBP, it was much higher. So they were recommended almost the same size that was implanted, but that was not a good size because the patient had to underwent an exchange. And here you can see the match between the implanted size after exchange. So they wanted for an exchange for a bigger lens or a smaller lens. While safe volt was in 57% of the cases recommended the size that was implanted second time, 53% for HATA, and a bit lower for the other formula. You can see here the same graph that I showed you previously. So it's a suggested size minus implanted size for each formula. So it's good when the green square have a lot of points. If it has a lot of points, it means that the formula is recommending a better size as compared to the implanted one. You can see that safe volt and the HATA that has the best prediction here. Even so, in most of the formula, when the volt was too low, below 200 micron, none of the formula were recommended a larger ICL except safe volt. But here you can see that, well, after the exchange, the volt was much better. In orange, you can see that after the exchange, most of the cases, above 80% of the cases, had a volt within 250 and 750 microns, which is the objective. And the absolute error of each formula is described here. You can see that safe volt has a lower absolute error as compared to other formula. Safe volt is not the only formula that is exploring the ability to analyze only images. There are some other papers out there using OCT image, at least. There are some other papers here that are also describing this. Here are those papers. And I show you one or two examples to finish. This is a 33 years old patient who had implantation of 13.2 ICL. And while this is the volt, obtained 300 microns of volt, the safe volt was recommended not a 13.2, but a 12.1 lens. That patient underwent an exchange, and after exchange, you can see that the volt was much better. 504 micron volt was obtained. This is a second case. Another case with a very high volt was obtained with a 13.2 lens. It was 1,400 micron. Usually when you have such a high volt, you would go for two size smaller lens, because we say that usually with each, which is when you decrease by one size, you decrease the volt between 300 and 450 microns volt. So you would go for a two size smaller. However, safe volt was recommending only one size smaller, and he was saying that you would have 89% of chance to get 400 microns volt. So we went with only one size and obtained a nice volt. Probably if we went for two size, it would have been a too small volt. And finally, I want to thank Dr. Mohamed Eid, who just posted a few weeks ago this case that he had with an implantation of a 12.6 millimeter ICL size, minus 13, and he used safe volt basically, and safe volt was saying that with a 12.6 he would get 528 microns volt, and he shared online his results because he implanted effectively a 12.6 lens, and his post-operative volt measured with the anterior was exactly 526 microns. So it was funny to see this. It's not always exactly the exact same number, but it's nice to see that. And I would like to thank all the team at the Rothschild Foundation, and I thank you for your attention.
Thank you so much, sir. That was a very brilliant and enlightening presentation. I would like to open the hall for discussion. Dr. Mahipal, sir.
Yeah, excellent presentation, Dr. Allen. Just wanted to ask you, you were saying that as of now, this is available only with the Anterion. Any thoughts or any ideas as to how long it will take for it to kind of be available with other OCTs? Because not many people have the Anterion.
Yeah. Well, we're trying to adapt it. The limitation is that we need to have very good anterior segment images with some visualization behind the iris, which not all the OCT are able to provide that. So we're trying to adapt it to other OCT image. We're working on the MF39 now. Now we're working on the Dream OCT. It's working quite well with the Dream OCT. So hopefully in the next few weeks, perhaps we'll have it on the Dream OCT also. For other OCT, we need to gather images and analyze them. So if any of you have a number of patients with other OCT and would like to share those images, it's quite easy to adapt, but we need images for that.
Okay. One more question, basis this you compared as to the ICL that was implanted. I don't know what was the methodology that was used by the surgeons earlier when you compared on the scattergram?
In most of the cases, it was the manufacturer nomogram that was used, the Stella.
Okay, so my question is that patients in whom you have used ICL sizing based only on the Anterion. Okay, what is the skew as regards low and high vault? How tight is the outcome? Is it better than what the...
This is an excellent question. Personally, we're now undergoing the prospective study analyzing the ICL vault obtained only by following purely safe vault. However, Dr. Tobias Danker presented in the last ICL EVO meeting on his result, and he showed that he significantly improved his postoperative vault by using purely safe vault as compared to the manufacturer nomogram.
Okay. Good.
So, Michael, sir, can I chip in as well? So, I've been lucky to work with Alain over the last 2-3 years. We provided him some 30-40 eyes of our data, and we came back with the similar findings that, those of ours which were outliers. And, they were predicted. Had we gone with safe vault, which we weren't using at the time, right in the beginning, we were using the Anterion, but we were not using safe vault to begin with. Even before it was released, I think Alain had done a study, and there were almost like 7 or 8 eyes where we would have got the perfect size if we had followed safe vault, and that's how we started off. And it's worked really well for us. We've been using it for about 2.5 years now. And I mean, with the online one only for the last 6 months or a year since the calculator became available. Before that, Alan's team was, kind enough to give us the calculations for our thing. So it's working really well. I had a question, Alan. We have the Dream OCT as well, and we've been measuring our patients on the Dream OCT also. So I would be happy to share that data with you if you tell us how to do that. And I think all of us actually in India, wherever I go speak on this safe vault ICL, they all ask if we can get it on the other OCT. So I'm sure everybody's like my pulsar said that, he has centers across India, and, he would have various OCTs at different places. He would probably be able to gather a lot of data and share that. One third question, Alan, how does this compare? Has anybody done a study? Because we've recently started using the UBM as well, the ICL Guru UBM. And I'm not sure, we have only done about maybe 15-20 cases where we have done both. And frankly, I'll be showing one case today where both of them looked really good in one of our difficult sizing cases. So actually, ICL Guru and Safe Vault both came on top as far as their mean prediction error was concerned. So they're looking both very nice. Yet, what is your impression, if you have any initial impression on how UBM compares with any of the UBMs, like what Dan was doing or what Roger is doing? How does it compare to what we are doing? There are two different ways of doing the same thing.
Yeah, thank you, Dr. Graf, for first for the invitation and for all the collaboration. I mean, the cases you shared to us also helped us a lot in first thinking how to improve the nomogram. So thanks a lot. As for the question regarding the comparison with UBM, yes, we conducted a study comparing UBM measurement with anterior OCT measurement as for the biometric measurements. First, not the full result, but just the measurement. And what we noticed is that it's not really comparable because UBM is highly dependent on the person who is making the measurement, and we found that there was a lot of differences in the obtained measurement. This is when you're using not the automated UBMs that Dr. Reinstein described, because we don't have it. So our first finding was, if you want to use anterior segment OCT or the regular UBM, not the automated one, I would definitely recommend to use anterior segment OCT, because for me it's more reliable and reproducible. As for the comparison with the automated one, we didn't do it yet because we don't have it. But if you have those cases, it would be very, very interesting to share those results.
Sure, I'll do that. And one quick question. I'm sorry, I know we are running a little late now, but it's very important. I was wondering that where does SafeVault, like in your thousands of cases that you would have data on now, which are those patients where we use SafeVault and anterior sizing, where we should be extra careful that it could possibly, is it like the high lens vault or the low lens vault, or which are those cases where we should be more cautious using sizing based on the anterior and SafeVault?
Well, the cases where you have to be very cautious is when the percentage, SafeVault will provide you for each size an estimated vault and also a percentage of chance to reach that vault. And in some very cases, rare cases, but they exist, you would see that percentage of chance to reach the obtained vault is low. Whatever the size you would use, whether it's 12.1 or 13.7, the percentage of chance to reach an acceptable vault is very low. In those cases, you have to be very careful because perhaps there is no good size for them, or it's a bit tricky.
Another question I'm asked is that if the AC step, I'm sorry, sir, can I just, Maipal sir, you wanted to ask something, then I'll ask my question.
No, you can go ahead. Or I was just asking, what is the acceptable safe vault nowadays? Because it's been pretty forgiving, the ICL. So what is an acceptable safe vault?
Well, in my opinion, it's quite, the recommendation are between 250 and 750. However, I would say it depends a little bit also on the age of the patient and on the anterior chamber depth. For example, if you have a young patient, like a 23, 24 years old patient, a 200 microns vault would not be really acceptable because you know that after a few years, that vault will be almost nothing and you have to exchange it. At the opposite, if you have a 45 or 50 years old patient with a 200 micron vault, that might be acceptable because he will have like 7, 10 years, 15 years, and then you would exchange it and it's fine. So it's a bit, you have to take it by case and adapt it to each patient.
Okay, good.
And my last question, which I'm asked wherever I present, that is it now okay to exclude AC depth from the whole calculation? For example, there are patients who have 2.6 or 2.7, and previously with the STAR calculator, you don't even get a calculation for anything less than 2.8. But I've seen that with SafeVault, we do get measurements for some of these patients where, even with the ICL Guru, you would get some of these because they don't consider AC depth so important. So what's your experience with those eyes where, how does SafeVault perform when AC depth is like, small, or in keratoconus size where, the AC depth may be falsely high? How does it go and when to depend upon it?
Right, it works very well, and it's also a very important question. I discussed a lot with Zaldivar team on that because they were the first to use the ICL, and I was asking basically, do you use ICL with a smaller vault and how is it? And they were very positive, so this is why I started. And basically, in those cases where the AC is small, the difficulty with regular nomogram is that they were not trained basically on those shallow AC to do the calculation. Or with SafeVault, because you're taking the whole image and not measurement, you can get good results because basically it's estimating, the number based on the shape and the aspect of the anterior segment. So yes, the results are nice. And now I'm putting ICL, and not hyperopic one, but myopic one, until 2.5. I've put ICL with nice results.
Great, thank you. I think we should move on. Milind sir is also waiting, and thanks,
Sure.
Alan. And we'll request you to stay on. We have some 2-3 interesting cases after the two talks. Maipal sir is sharing couple, and I'm sharing couple based on sizing itself. So we would love to have your comments on those as well. And in
Sure,
between, all, yeah,
I'll be here.
thanks. Anshika, you can go ahead.
All right, thank you so much. So moving on to our next talk for this session, I would like to introduce the speaker, Mr. Dr. Milind Pandey. He's a consultant ophthalmic surgeon, founder and medical director, Vision Surgery and Research Center, Hull, founder and CEO of Custom Lens AI, trustee and past president, United Kingdom and Ireland Society of Cataract and Refractive Surgeons. He's a senior cataract and corneal refractive surgeon with over 40 years of clinical experience, spanning over 3 continents, having participated in over 350 invited lectures, panels, and chat sessions, and the recipient of UK ISRS Lifetime Achievement Award. He will be speaking today on refractive lens exchange, when to and when not to. We welcome you, sir.
Sir, we can't hear you, Milind sir, and thank you so much for joining. Milind sir is my senior from Maulana Azad Medical College as well. So,
Thank you. So, yeah, that'll be the best way to do that. Okay. And now switch to this. Okay. Can you see my slides?
yes, sir, we can.
Yes.
Great. Thank you. Well, it's a great pleasure to be part of this wonderful international ophthalmic symposium, which technology enables us to do. I've been in India for the last couple of weeks, and it's very nice to connect at a sensible time. So what I've been tasked to do is to talk about refractive lens exchange, and really when to do and when not to do it is how it's been set up. That's the task that we've got to. So really, to begin with, refractive lens exchange surgery is not cataract surgery done early. That's a very key thing. Usually refractive lens exchange surgery is considered purely to get rid of patients' glasses, so the best corrected vision is 20/20 or better usually. It is elective refractive surgery, we all know that. And hence, it's very important that the indication for surgery must be stronger than just the use of technology or, well, we'll do it because we think it's a cataract as such. So just a bit of basic optics. The eye has 2 optical elements. It has a fixed focus lens, which is the cornea, and it has a zoom lens, which is the accommodative crystalline lens. And it's a combination of these 2 that gets the human eye the most amazing capacity to shift focus from distance to near in a continuous manner. So whenever there is useful accommodation, and you want to correct the total ocular refraction, it's a fixed focus problem. So you wouldn't attack the lens here because it's the lens is still working very well. To correct fixed focus issues, we use spectacles, contacts, laser, faking IOLs, wherever appropriate. The key thing here is to remember that if there is useful accommodation, we do not remove a working zoom lens. It doesn't make sense to do that. Before we consider refractive lens exchange, we have to consider all the alternative options: spectacles, contact lens monovision, Presby LASIK, Presby on, faking IOLs. There's a whole range of these, and you have to be familiar and comfortable in treating and using all these modalities. Otherwise, if you only do one thing, you only have a hammer, everything looks like a nail. The right treatment option is the best trade-off. It is not the newest option, or it's not the latest fashion. A key thing to remember with refractive lens exchange is refractive lens exchange is not a full restoration of accommodation. It is a compromise, it's a substitution. A normal crystalline lens gives perfect zoom, fast, very smooth, continuous range of vision without any dysphotopsia or hardly any dysphotopsia. Currently, there's no intraocular lens which matches that functionality. It cannot replace full normal accommodation. What we have are really optical tricks, optical designs which simulate accommodation. And that's something we have to keep in mind. The universal objective is spectacle freedom for patients. That's a reason to think about refractive lens exchange. Patients want practical freedom from driving, from computer screens, reading, work, really doing all the things that are important to them in their life. And the honest goal for them is the best achievable range of spectacle independence and not a guarantee. And this is an important aspect when we come to define what patients actually are counseled. They're setting their expectation. And when we think of this, an important concept to think about is you have to think vision. You don't think intraocular lenses. The common thing, what's your favorite lens for this? What's this? No, you have to think in terms of vision, because we have to first assess the visual needs of the patient. What does the patient live like? What kind of activities they do? What is important to them? And then we choose an intraocular lens strategy which will fulfill those visual needs, not the other way around. So when do we determine that the zoom function in the crystalline lens has failed enough? Because refractive lens exchange surgery becomes viable when the natural lens has lost useful accommodative value. The decision must weigh the risks, benefits, alternate treatment options, potential complications, and the duration of benefit of any type of surgery. So the two common ones to think of as determinants of accommodation are age and the presbyopia add in anyone's refractive spectacle. Age is a good indicator in general terms, but presbyopia onset is not uniform and there is huge variation. It also depends on what the underlying latent refractive error an eye has. And plus, the effect of the presbyopia on an individual patient depends on their quality of life and what kind of functional burden of vision they have. Someone who's indulging or is working on screens all the time has a very different need and will trigger problems with presbyopia much earlier than someone who's basically an outdoor farmer and doesn't read too much. A good indicator of the severity of this is a 1.5 diopter add in the spectacle plane in order to get good vision at 40 centimeters. It's a good indicator. It means the presbyopia is established, but it's not really a surgical indicator. You can't rely on it all the time. And this is where I think a critical thing to do is to think of a panfocal vision profile, which is what is the uncorrected distance vision of the patient across various distances and levels of illumination. So the important thing to do is to do uncorrected distance, intermediate, near photopic, and near mesopic visual acuities. This, I think, is really what maps out the whole thing. And then we ask ourselves and the patient, which of these uncorrected visual acuities can be really improved and by how much? Once we do this, we have a good idea as to what the benefit would be. And then we can decide from this kind of measurement to the decision as to whether improvement is meaningful in the patient's real life. Does it improve their quality of life? And whether the gain must be significant to justify surgery with its inevitable small but significant complications. So the framework is very important. One important thing to think about is spectacle freedom is built binocularly. I said about think vision. The outcome we aim for is good binocular visual function, not one perfect monocular lens results. It just doesn't make sense. There are three ways, there's three schools of thought in terms of when we think of binocularly. The first is to stick same lens in both eyes. The other is to think of complementary optics. So this will be the mix and match approach. And then we have binocular customization, which is the ultimate in personalization and customizations. So let's look at some of these. Same lens in both eyes doesn't mean the same vision in both eyes. Take any patient, whether they're bilateral monofocals or multifocals, they'll all tell you that one eye is slightly better than the other. And that's because each individual eye has its own small variations in refractive outcome, in the anatomy, and hence Doesn't matter whether you stick the same lens in both eyes, they will see slightly different. And that is how natural vision works. The same lens in both eyes doesn't mean the same dysphotopsia in both eyes, because those dysphotopsia associated with the lens will be modified by the residual effect of astigmatism, spherical equivalent, dryness, and individual anatomy. So again, the same lens doesn't mean the same dysphotopsia. However, it is simple, it is predictable, it's formulaic, but it's less flexible and doesn't allow for customization. The next approach is this mix and match strategy. Now, I define mix and match as when the intraocular lens combination is predetermined before you do the first eye. So you decide, in this eye, I'm going to stick this lens, in the non-dominant eye, I'm going to stick this lens. So complementary lens designs, which can balance the range, the contrast, and the dysphotopsia. It is a predetermined combination, which is partial but not full binocular customization. The most sophisticated way of doing this is binocular customization of vision. So the goal here is to achieve the highest possible binocular contrast, the widest range of vision, and minimal dysphotopsia. And we do this by customizing not just the intraocular lens choice in each eye, but also the refractive target for each eye. So, and we determine the second eye strategy by what has been actually achieved with surgery on the first eye. You identify the gaps and strategize to fill them. And this is why something like custom lens AI, which we've been working on for the last 2.5, 3 years, could really help with making the custom lens, the whole process, much more easier to do, much more error-free, and overall, it gives good results. We've just started the pilot in Bangalore, so it's promising. Another important thing to think about is hyperopes and myopes. They're two different decisions. Presbyopic hyperopes don't see very well at almost any distance. So it's a win-win for them, right from near to distance. Myopes, on the other hand, gain distance and intermediate, but may lose good unaided near vision. And that's a very important and critical aspect to think about. The retinal detachment risk is another critical appraisal. In myopes, the retinal detachment risk is influenced by age, sex, axial length, and the degree of myopia. So it makes sense to think about this only in older myopes, which may be reasonable candidates. Younger high myopes really are not suitable for refractive lens exchange in this particular perspective. So just to summarize, when do we do refractive lens exchange? When does it make sense? It makes sense when the accommodation of the zoom function is significantly compromised in the eye. We don't do it if the zoom function is still useful. We do it when the panfocal visual acuity gain is meaningful, in the sense that the range of vision advantage improvement is significant and is improved. If it's poorly defined or we're not sure about it, we don't do refractive lens exchange. We do it when the trade-offs are optimal. What we mean by trade-offs, which is if you have a myope, they may have slightly worse near vision, uncorrected near vision after surgery, but the gain on the distance and intermediate vision, and if they're happy to take those trade-offs, it makes sense to think of this. It makes sense to do it when the retinal detachment risk is acceptable, not when the risk is high. It is a long-term solution. In a way, it's preventing cataract surgery, if one thinks of it in a very simplistic way. And do not do this if the expectations are unrealistic. So really, refractive lens exchange is right when the patient's quality of life is improved. Refractive lens exchange is not just better unaided vision on a chart, and it's that quality of life improvement focus, which is the key thing, is what I would always recommend to think about. Thank you.
Fantastic, Milind sir.
Thank you, sir, for sharing your expertise so generously. I think that has a lot of things that all of us can apply immediately to our practices. Dr. Gaurav, sir, what are your thoughts on the talk?
As usual, he speaks so much sense and so, kind of delivers it so well. I think everything was so relevant. He's just put it in such a nice, presentable way for people to understand easily. I have a question. With the advent of these new, especially because you're working on this field, the advent of the new EDOF and continuous range of vision IOLs and all these lenses which are now in use and in use very regularly. What about these extreme of axial lens where we are doing a refractive lens exchange like the high hyperopes? And there are these lenses which are now becoming available in some of the powers which are closer to these extreme refractive errors. How well do they work, and how should we be careful when using them when promising patients some kind of what these lenses are usually supposed to deliver? For example, the EDOF for a very high myope or a very high hyperope, and similarly for the trifocals or the CRV lenses.
So that's a pretty simplistic way of framing that question. Hyperope or a myope may have different anatomy of the anterior chamber. Okay, so a good way of determining so the real question is the intraocular lens power add in the intraocular lens plane significant enough in the spectacle plane for any eye? Okay, you may have a myope with a normal AC, in which case it won't make a difference. So a good way of determining this is just a simple calculation. You work out what the intraocular lens power is for emmetropia and what the intraocular lens power is for a target of minus 2.5 diopters in the spectacle plane. The difference between the two will give you the intraocular lens power add in the intraocular lens plane. And if your lens doesn't have that amount of power add, then that lens is not going to do the same as you would expect. So it's not hyperopia, myopia, whatever. It's doing this calculation, which just completely negates the whole thing. Now, remember, the other thing that comes about here is if you have ended up with half diopter of hyperopia with an EDOF, effectively, you're reducing the range of vision on that lens by half diopter. If you go the other way at minus 0.5, the same thing happens. And the degradation of even small amounts of astigmatism, especially with multifocal lenses, makes a big difference. So it's thinking about it from that perspective, and it's a very easy calculation to do. I do it for every eye of every patient that I would do. It's very simply work out what the difference is in terms of the target for emmetropia, the target for minus 2.5. If it's a 4 diopter difference, if your lens only has a 3.5 diopter add, you can't expect it to get the full range of vision.
Excellent.
Milind, how important is DLI nowadays in routine practice?
DLI, I don't believe in that objective kind of a thing, because what matters is what patients perceive as vision. That is what matters. So whether it's a DLI of this or that, I think those are systems which help us in assessing whether the problems of the patient can be related to what the lens is.
Yeah.
The key determinant is the actual framework of the vision profile per se. And the correlation between DLI and visual function is not the best, but it helps. It's one of a number of things that work. But this concept that if you have a DLI of this, the patient has a dysfunctional whatever syndrome you call it, and then you go into surgery, I think if you want to believe in it, you can. But
no, my question is, the patient comes to you with visual problems. Patient is not seeing well, say, while driving, and has a lot of photic phenomena and things like that. And you put the patient and the DLI is bad. So would that encourage you to go ahead and do maybe you won't call it a RLE as per your definition, but does this help in making the decision a little easier for you if the patient has come with you with vision problems, range of vision?
I've never used the DLI because I didn't think it was much of an advantage in the whole decision-making process.
Okay.
So Maipal sir, I have used the DLI extensively, and in fact, there are two. It's good and it's not good. I mean, what Milind sir said was absolutely right. We have to just use it as one of the things. There has been a patient where who came in for a phakic lens minus 18 or 19, not improving beyond 636. We did the aberrometry and the eye trace, and we found that the corneal aberrations were almost negligible, and it was full of lenticular aberrations. DLI is like 1 or something. And fellow eye is like emmetropic, 6.6, and with -7 or -8 improving to 6.6. So we were wondering whether to do an ICL. Patient came for an ICL. We decided not to do an ICL because BCVA was not going beyond 636 and retina looked absolutely healthy. And there it came into play and it worked well. And post-op patients, obviously DLI is 10, patient improved to 612 or something unaided. Now, on the other hand, there have been situations where we have had a patient come in for an ICL. Patient is reading 6.9 with glasses, best corrected vision. DLI is poor, it's like 3. Yet we decided never to go with the refractive lens exchange because, with the ICL patient is getting and happy with that quality vision. And third, last input here is we've had a couple of patients where DLI was very bad with high refractive errors like -16 or 17, maybe just about 2. Post ICL, the DLI improved to 8. Now that cannot happen. If it was truly bad, so there, you have to take it with a pinch of salt. But yes, in many patients where it works well. So you have to kind of correlate it with clinical judgment and actually what the patient sees, I think, as what Milind sir said.
Okay. Maybe we can move on to the
Yes.
next talk. Yeah.
Yes, sir. So those were some very interesting insights. And now moving on to our next speaker, we have Dr. Rogers Aldevar. So our next speaker represents the perfect blend of legacy, innovation, and modern refractive surgery. Dr. Rogers Aldevar is a renowned cataract and refractive surgeon from the prestigious Institutes Aldevar in Mendoza, Argentina, where he serves as CEO and co-director of the Cataract and Refractive Surgery Fellowship Program. A globally recognized educator, researcher, and innovator, he has delivered more than 200 international scientific presentations and authored numerous peer-reviewed publications and book chapters. Carrying forward the extraordinary legacy of the Zaldivar family, he has combined clinical excellence with entrepreneurship and innovation, holding multiple utility patents in IOL design and leading advancements in digital health and AI in ophthalmology, including the ICL Guru. And please join me in welcoming one of the leading voices of the next generation of refractive surgery, Dr. Rogers Aldevar. So you can share such slide, please.
He's
Okay.
not there.
I think
You have to play
towards the
slide.
I believe he's not logged in right now.
Yeah, so can you go ahead and play his
Yes.
recording? Because he said he'll join in at the time because it's like 3 a.m. or something at.
All right. So Dr. Pranish can help us with that. Would you have his recorded?
Yes, that is Dr. Anshita.
Do you have his recording?
No, ma'am. No, I'll get it
I think we'll
sorted.
go ahead with Dr. Maipal's presentation and I'll.
Yes, I'll get it sorted in the
Sure,
interim.
no problem. So, Anshika, can you introduce Dr. Maipal?
Absolutely. Just 1 second. So Dr. Mahipal sir needs no introduction. He is recipient of the Padma Shri Award and Lifetime Achievement Award in Ophthalmology. He is chairman and medical director, Center for Sight for and a cataract, refractive, and corneal surgeon. Just a second. Yes. So he has introduced LASIK, phakic IOLs, and femtosecond laser technology and pioneered phacoemulsification and LASIK surgery in India. He has steered the All India Ophthalmological Society during COVID-19 as president and pioneered in silk surgery in the world in 2020. He is recognized globally with multiple fellowships and awards and holds an honorary doctorate at the Amity University as well. He is also an APS-ARS Certified Educator Award winner at APS-ARS 2023 Singapore. We welcome you, sir.
Thank you. I'll just be showing a couple of videos. So this is basically, are my slides visible?
Not yet, sir.
Still? They're not visible?
No, sir, not yet.
One sec.
My sir, can you
Okay.
tell me where you're having trouble, sir? I'll help you out.
1 second. Maybe Gaurav, you can. I'll just.
All right, so moving ahead and introducing our last speaker. While we sort this out. So Dr. Gaurav Luthra is director and head of Drishti Eye Institute, Dehradun. He takes a special interest in refractive surgery, challenging adult and pediatric cataract surgery, as well as keratoconus. He is current president, North Zone Ophthalmic Society, and chairman, academic and past president, IRSI. He is also co-founder and honorary fellow of the World College of Refractive Surgery. He was awarded honorary FICO in cataract and refractive surgery by the All India Collegium of Ophthalmology and holds over 300 live surgery demonstrations, 7 orations, and 5 named national awards. We welcome you, sir.
The voice is not audible.
Sir, you are not audible or visible.
So I was unable to unmute, but let me now share again if slides have gone off. This has become a...
Slides are there.
Yes. Is it visible now?
Yeah.
Yes.
Okay, great. So I just wanted to share one interesting case where, the newer methods of ICL sizing became very useful for us. And this was a 24-year-old lady who presented with stable correction for almost 5-6 years and using glasses for 10 years with a correction of about -6.5 with -1 in the right eye at 180, 6.25 at 2.75 at 180, improving to 6.6 almost in both eyes. The cornea was thin in both eyes. Otherwise, cornea had symmetric both eyes and astigmatism. And the pachymetry, central pachymetry was 419, white to white was there. And the Belling's map was obviously showing slightly suspicious because of the thin cornea. Fellow eye had almost very similar findings. And we had obviously decided to take this patient up for a phakic lens. We went to the STAR calculator and it was suggesting a size of 12.6. There was a small difference in the white to white sizing based on the digital calipers and what we were getting on the Pentacam. But then, of course, all the devices usually have small differences, and I'll come to that. When we started doing this, we measured it on 4 various devices. Initially when SafeVault was not available, we had started using the KIMS formula almost 4 years back. Now that was predicting that we should probably be using about a 13.2. We did the Almaster Lasso, which is not one of the best because the Lasso works better with the OCT based formulas. So yet, we did that as well, which showed again that optimal size would have been 13.2. Now this was different from the 12.6 being suggested by the STAR calculator. And the SafeVault ICL was again predicting maybe a 13.2 or even a bigger size. For an optimal vault, I would have probably gone with something like this, the 13.7. I'm actually very wary of using the 13.7 in most cases. We also sometimes nowadays try to delve with the ICLcalc.com, which takes in the white to white and gives an adjusted white to white and adjusted AC depth. Now, this is very basic because it's not using any of these objective data from any of the devices. but it also uses calculations from the ILMaster 700, the iTrace, and several other things. As you can see over here, it also gave out outputs, which I'll just share with you. So on the Pentacam HR, the ICL calc was showing that we should probably go for 13.2. And on the ILMaster 700, it was predicting that we should go with the 12.6 size for the optimal vault. And on the manual calculation, which means digital calipers, it was 12.6. And again, on the Lenstar, it was showing about this. Now, we did the ICL Guru, which we acquired only a couple of months back. And ICL Guru was showing that a 12.1, of course, is totally out. And the 12.6 would be borderline. 13.2 might be good, but with suspect stability. And it obviously gives you the percentage of getting that calculation as well. Again, predicting that you could use a 13.7, which is what the Safe Vault ICL was also suggesting. In the fellow eye, it looked slightly different, and there we were getting optimal sizing with 13.2 and 13.7. Now, we shared all this with the STAR calculator, and they went back and did lots of calculations, and then the STAR team came back that they would still want us to use the 12.6 in spite of all the data that we shared with them. And we went ahead with the first eye using a 12.6 based on the STAR recommendation. This was a few months back, 2 months back, that we did this case, and you can see what happened. We got a post-op vault of just about 175 as the objective measurement devices. Both the Antirion-based Safe Vault ICL and the ICL Guru were both suggesting the same. Obviously, for the second eye, we immediately decided to change the size and went with the 13.2, which should have given closer to 500, and it actually gave close to about 500 microns on day one post-op. Now, these vaults actually settled down over time, and this became just about 60 microns in the right eye and is now planned for an ICL exchange. Second eye has stabilized at about 317, and we are okay with it because that hasn't shown any rotation or other problems. But again, as Alan said, that in younger patients, you would want something like 500 to 600 at least for a safe ICL. Now, if we look at the comparison of all the various ways that you did, and you can see that the mean prediction error was highest with our manual measurements, which means what we got on the digital calipers, which was repeated 2-3 times by different consultants at our place. And usually what we get with our digital calipers corresponds very closely to what we get on the Pentacam, with it off being just by about 0.1 to 0.2. So we've actually had a wonderful run with the Pentacam and with our digital calipers for the last 15 odd years. But this time there was a difference between the two devices, between the Pentacam and what we were getting with the digital calipers. So if you look at how this case shows that, going with more and more objective measurements helps, look at the bottom here. For the right eye, the lowest predicted error was with the Safe Vault ICL and the ICL Guru. So they came closest to predicting what would be a Safe Vault and with vault prediction. And for the left eye as well, it was the Safe Vault ICL which was most accurate, and ICL Guru which came a pretty close second. And all the other ways would be not as good. Again, Pentacam comes fairly high, and the ILMaster 700, if you look at the lasso using the 700, also came closer than the others. But the best were basically the UBM based and the Safe Vault ICL. So this is how we came out on this case. I do have another interesting case, but I'll do it after my pulsar, and we still have time left, and I would love to have any discussions on this with all of you.
Okay, thank you, sir. That was a very interesting case, highlighting the importance of consulting all of these different things that we have available in our armamentarium before we decide what to go ahead with. Dr. Mahipal, sir, can we start with your presentation, or if there's any discussion that you would like to have?
If Alan is still here, I can see that he is. Maybe he can comment on how, what he thinks about.
Yes, I'm here. Well, it's very, very interesting, basically, and it confirm what we thought on the possibility of like having excellent result with the UBM or with the Antirion. I don't have anything to add. I had one thing. I had one thing on the importance of the measurement of the vault at distance, not only at 7 days, as you showed, because it changed, and this was one of the things that perhaps sometimes make us made error in creating our algorithm, etc. Because if we take patients that do not have the vault measured at the same time, well, you have lot of modification specifically between 1 week and 1 month, and specifically if you use myocol or anything to restrict the pupil, then the obtained volt is not always the same. One thing, and the second thing is, I mean, in my opinion, the importance of the UBM or the additional value of the UBM is the ability to detect the presence of iris cyst when they are present, and this might be an advantage as compared to anterior. What we are trying to show now is that when, as I said previously, when the percentage that is given by safe volt is very low in all cases, it probably means that there is something in the anatomy, in the image that is being shown, that give the algorithm clues that perhaps a UBM is needed. So that would be the idea. The idea would be not to do UBM for all patients, but to restrict the UBM to perhaps 1% of the cases in which it might be more difficult to estimate the volt.
Alan, I think we'll take some comments from Maypal sir and Milind sir if they were watching the case as well. But I had a question, like, for the first time, which I'm going to do an IC.
1 second, Gaurav, is my video?
Yes, we can see your slides, sir.
Okay, fine.
We
No
can see your
worries.
slides, yes.
Yeah.
Alan and Milind sir and Maypal sir, in the right eye, do you think we should go with a 13.2 exchange or a 13.7, considering that the volt is almost 50 microns? Because increasing by one size would probably give me just about another 100, 150 microns. Do you think I should go with the 13.7 in the second eye? I've been very reluctant to use 13.7 sizes.
Well, honestly, in that case now, in those cases, I'm following the algorithm now. So yes, and she's young, she's 20 something, right?
Yes, 24.
24, yeah, so I would go for 13.7, yes.
Sure.
Can I make a comment here?
Yes,
what
sir.
is the legal status of this? If you're using a formula or a system of measuring and sizing, which is different to what the star manufacturer says, and then you run into problems, essentially Star would turn around and say, well, you used it in a way different to what we recommended, which is why I guess when you send all that stuff back to Star, they're not going to come back with anything different to what they actually manufacture will recommend. So it's quite interesting to, I don't know, I mean, how do you handle that?
I have had this problem once, and basically, and at the end of the day, this patient had an IOL redialing and an exchange, not IOL, I mean ICL. And this guy communicated with ICL directly, the patient, and the patient, they said that no, this is what it was supposed to be, and this is what was put. While we sent again, and they said that no, this is, so there was a difference between what they communicated to the patient and what they communicated to me. Finally, I did win the case, but there was a problem. They disowned.
Alan, what can you say here? Because you are doing this all the time.
Yeah, this is one of the reasons why we published basically this. So now what we can say is that, I mean, the results are published and validated externally and showing a better precision as compared to the manufacturer algorithm. So we have scientific proof that those algorithms are better. And then, yeah, we have to, I mean, I didn't have any problem with the company, honestly, when we're having not the right size and we need exchanges, even so it's rare now, they are accepting the exchange.
Right.
So, Gaurav, this is just to highlight what you were saying. This is basically this is an ICL patient. So the only thing is that the ICL comes in 0.5, and the Indian version, which is the IPCL, that comes in 0.25. So, and the range is also there from 11 to 14. So this was a case where the volt was a problem in the case of an ICL. And this is given by Dr. Ramamurthy. So he went ahead and actually replaced it in a size which was intermediate and 0.25 more than the maximum size that is available with the ICL. So this is just to show you this, that the flexibility as regards the range of the phakic lens which is there can at times help you in such situations. So this was just an exchange of an ICL with an IPCL with a 0.25 because it's coming in 0.25 and it goes up to 14. 11 to 14 is what I think is what you have in the IPCL. So the range is much higher. So there are actually, if you look at 0.25 steps, I think there are 14 such measurements that you can get out of the patient, out of the company.
Absolutely.
This is basically a case where, again, you can see that the IPCL has been used. You have a case in which IOL has been done much earlier in a child, and you can see that just getting the lens out, which is pretty stable, would be difficult. So where you have a high ametropia that is there in a patient, you can go ahead and use, because the IPCL or the ICL is supposed to be put in the sulcus itself. So this is the use of a phakic implant that you can go ahead and put in the sulcus, just clean up the synechiae if there are any, and you can use it for high ametropias which are there. So these are two special situations that I wanted to show. And then we can have a small discussion, time permitting, on this particular case, which is a case of keratoconus with an intact.
Sure, sir. So I was, in fact, very nice point highlighted by you, because even I had one patient where the white to white was smaller than what STAR allows to use below it. And, IPCL was able to customize a lens for that size, and we were able to implant successfully and got a very good outcome with a good vault. My other question was that for the second case that you showed, where you have put a piggyback IPCL, I wanted to understand that in your experience, what is the difference in the results between when using a piggyback IPCL versus a piggyback, they have that special Sulcofix or and
But Sulcoflex, that's what I said, it's high ametropia. The range of Sulcoflex is pretty limited.
It's beyond that range.
Yeah, and today you don't get Sulcoflex in India because it's not registered in India anymore.
Right.
So like we don't get the anaridic lenses from Morcher because they're not registered, because each lens is now a medical device and that has to be registered in India. So that's a problem that is there.
Okay. So maybe we can have Roger Zaldivar's presentation if they've been able to download that from which.
Yeah, ask him if they have. Otherwise, this is just a question that I'll wish to ask maybe Alan.
Maybe you can go ahead and ask, but backend team, do you have the presentation which Dr. Zaldivar has shared? Dr. Pranesh? Were you able to download it?
He's muted. Pranesh, you are muted. We can't hear you.
Sorry, I've downloaded it, sir. It's done. It's done.
If you want, you can play that, and then we'll come back for Maipal sir's interesting.
Perfect, sir. No problem at all. Just one second.
Okay.
Sir, Maipal sir, you can stop.
Yeah, I did. Okay.
Is the voice audible, sir?
Yes.
Hi, I'm Roger.
Okay.
Zaldivar, and it's a real pleasure to be sharing our experience today regarding ICL sizing, specifically using our tool ICL Guru. I want to thank Dr. Luthra and Maipal for this nice invitation. These are my financial disclosures. So when we think about the ICL back in the old days, because we have been doing this for more than 33, 34 years, we know that the ICL has a unique material, which is extremely forgiving, very biocompatible. Patients are really, really ecstatic after phakic IOL procedure in general, and the quality of vision is, without any discussion, quite unique. It's really, really good. We always struggle with the concept of lens selection or sizing, since it has always been like the Achilles heel in this procedure. So when we analyze a little bit the jump that it has been done from the old version without the central circulation to the new version, we can clearly see a much improved safety profile without requiring iridotomy or iridectomy, with very little or no pupillary block disclosed. We've seen a couple, but in thousands and thousands of cases, with very low cataract formations and much higher volt tolerance due to the fact that we have a central circulation which is making it much more stable during time, the loss of space between the lens and the crystalline lens. So what can we improve with this improved safety profile lens as has been described priorly? We can definitely keep pushing the limits on this bell distribution in relationship to the lenses that are in the outbounds, that are with too high volt or with too little volt. We should always aim to have more and more lenses in this ideal range of sizing of volt. If we think about what has been used today as the main method, we are speaking about the white-to-white. It's not truly so solid from a scientific point of view because it assumes that the internal structures are constant, so which means that the cornea has a constant relationship to internal structure where the ICL is actually sitting, and we know that the correlation is very modest or low. It's around 0.3. So it's putting as an analogy is like fitting shoes by measuring the head. We are proposing a different methodology that is AI-powered UVM. Why AI-powered UVM? Because we consider that UVM has the possibility and the potential to get us to another level of analysis of the structures in order to determine which is the best lens to fit in that structure. So we are truly measuring where the ICL actually sits. If we think about the anatomy of the eye, we have been measuring a lot about this, and in these 334 eyes, we realize that if you have patients that have large inside and outside, and we have eyes that have large inside and small outside, and the opposite, but there is always some piece of these different groups that are outside the correlation. So in every eye, in every groups of eye, you have at least a 20, a 28, 18, or a 31 that you can tell that is outside that group, which means that you will always find something outside. And this is basically what's happening in the normal days. If we analyze the different data, and I'm going to move my head a little bit, you have at least 1/3 of the cases using white-to-white that it is outside the 250 and 750 microns of range. So there's always 1/3, or telling it in another way. In different papers, you have 70% of the cases that are inside this. You will always have some piece outside because you are inferring that there is a constant value from here to where the ICL is sitting, and you are assuming different things. So UVM has changed completely the way we used to do it. It's now AI-driven, it's now automatized, it's performed in order to be more technician independent and to rely on the quality of the images rather than in the skills technician. So today we are only getting the best of the best, and we are guided in order to get those great aligned and well-centered images. Then we are processing through our AI algorithm. We are processing the best of the best once they have already been approved. We are discarding the bad things. We are processing through our algorithm in order to be able to determine which is the predicted central volt, the predicted peripheral volt, the predicted angle, and the probabilities to finish in the different lenses in that ideal range. What is the ideal range? We're going to discuss more about.
Am I audible, Dr. Pranish?
Yeah. Would you want me to continue, doctor?
Dr. Gaurav?
Yeah.
Yeah, we have till 1, right?
So the session timing was 11:30 to 12:45.
Oh, okay.
As per Dr. Pranish, is that right?
Yeah, that's right. We still have 5-6 minutes of the video left. So
Yeah. So
Dr. Pranesh and Dr. Rolika, they can decide if they want to give us 1 or 2 minutes. Otherwise, we can, I didn't realize. I thought it was till 1 o'clock.
Even I thought it was till 1 o'clock.
Do you want to give us just 1 or 2 minutes more and then?
Yeah, yes, sir. Shall I close the video, sir, or?
No. Well, If we need time, then you have to continue with the video. Otherwise, if you are not giving time, then we can close the video.
Right.
So maybe we can have a discussion to
We don't need to
wrap
have any
up the
discussion, but if we
We
can have
don't
1 or
need
2
to
more
have any
minutes
discussion.
video, that would be great.
Okay, sir. Fine, sir.
Just
Then
2 more minutes and then we close. Yeah.
All
yes,
right, so
I
we'll
think
see the video then, Dr.
That's what
Pranesh.
we need actually, not the
Yeah.
discussion right now.
So Pranesh, you can do the video and maybe just skip it a little bit and come towards the last.
But basically,
okay,
Just
okay,
move
sir.
it a little forward. More.
because good
Yeah.
safety and confidence to the doctor in order to understand what is the complexity of each eye. We consider that less than 50 microns has a cataractogenous risk, not only from the central part, but in the peripheral part. If you have a high negative meniscus, like in a high myop, you will have a big difference between central and periphery. So it's not only what you need central volt, but be sure that you are assessing peripheral volt. Ideal range is between 150 to 150 today with an angle over 20. And of course, we want always to avoid the hypervolt. So for example, in this case, we have a 2.6 millimeter anterior chamber and there is no ideal scenario for this eye. You can definitely do a 12.6, but you know that you have high chances to finish with a volt over 15 and less than 20 degrees, 24% of chances to have an ideal volt, and some chances to finish in the low side too. So there is not such an ideal placement for this eye. That's why we are not selecting in a square blue any recommendation. We published with some friends, including Asian eyes, and our worst result in those hundreds plus cases was 416. But the most important message is that there weren't significant inter-sentence differences, which was very important for us. This is a cloud-based solution that you have to add only the video that has been exported automatically from the different UVMs, basically Sonomed, and you can upload and automatically will fill all the information. In not what happened procedures, which is really interesting. We are increasing our ICL numbers every single, which is really doing better things than what is already approved by FDA. Discussion, we should take the best from it, doing the best sizing that we can. Thank you for your attention, and hopefully I can be there tomorrow for discussion if I can wake up at 3 a.m. in my country. Thank you, my friends.
Thank you. Yeah, Gaurav, I think Anshika, we can sum it up and close
We can
it.
summarize, yes.
All right, so just a vote of thanks to our chairpersons, Dr. Mahipal Sachdev and Dr. Gaurav Luthra, for this amazing session, as well as our speakers, Dr. Alan Saad and Dr. Roger Zaldevar, for extending their expertise on the matter. And
Milind sir and Alain,
And
Dr. is still there. If they want to say a goodbye
Yes.
to us.
Okay, I think they're not there.
He's there.
Milind,
Sir is
okay.
there.
Yeah.
Alain will be there because we'll have to close.
Well,
it.
it's been great participating in the session. It's always wonderful to be part of this family, and thank you for the invite.
Thank you everyone. Gaurav.
A lot everyone for joining, and thanks Mahipal sir for allowing this session, and Santosh sir and Rolita.
Thank you.
for your help
Thank
and
you.
Ganesh.
Bye.
Thank you.
Thanks, Alan. Thanks.
Bye-bye.
Bye.
I'll share the opening screen for the session. Rolika ma'am.
Yeah, Mika, over to you.
Yeah, I'll share the screen.
Sure, Mika. Mika, you will handle the session here and help with the timer as well, okay? So, I mean, just display the timer with every chat, with every, sorry for that, with every presentation, and it's in the apps at the bottom. Okay?
I'll just take 1 second.
You here, I'll handle the others, okay?
Okay. Dr. Deepanjali, is the screen okay?
I can see your
Dr.
screen.
Deepanjali?
Dr. Megha, yeah.
Yeah.
So we have to wait for the timer, right?
Yeah, that's,
Can you
I'll
see
just
the
look for
timer?
it.
Can you, yeah.
Can you go just have a word with the others who are in the session to join if they haven't already?
Sure. Just let me check that.
Meanwhile, the other faculty members who have joined, they can share their screen and check their slides. I'll just unshare my screen. This is Dr. Aparna. Yeah.
Is my screen visible?
Yeah, it's all good. It's visible.
Thank you.
If you have any videos, you can just check those as well.
Okay. I hope
You're
the
working
videos
fine.
are playing. Yeah.
Aparna, you're done?
Yeah, I'm done.
Okay, can I just check mine?
Dr. Shamant?
Yes, yeah.
Yeah, please go ahead.
Is it coming?
Yeah, the slide's visible. Can you please go on slide screen? Slideshow?
Is it like moving now?
It's moving. Any videos in your presentation?
No, I don't have any videos.
All right.
Okay, no.
Dr. Pooja is here. Even she can check her slides.
I think I'm fine with it. Thank you.
Dr. Sachin, do you have any videos?
Ma'am, am I actually visible on video because I'm not able to see myself?
Dr. Shamant Shetty, we cannot see you, your video. And we can only see the virtual background for Dr. Shamant Shetty. Dr. Sachin's video is fine. Dr. Sachin, do you have any videos in your presentation?
I
Yeah.
think I'll just relog it.
Megha,
Yes, sir.
I could
Yes,
not
sir.
able to put my this one virtual background.
Okay.
I was so busy just now. I finished my stage program. I'm
Should
just
I send it to
logging
you?
in for. Yeah, if you can say you send
Sure.
me, you WhatsApp me the
Sure.
virtual background. I'm going to put
Sure.
it, but let us start first, okay? Because it's
Yeah.
1 o'clock sharp. So
Sure.
let us start first.
So while Dr. Megha is opening our
So,
session, sir, I'll
good
just
afternoon,
forward you
everybody.
the background.
You
Yeah.
forward me
Dr.
WhatsApp
Deepanjali,
me.
you can send it and I'll just start the session.
You
Is
WhatsApp
the
me.
time,
You WhatsApp
is
me.
the timer visible?
Yeah. So,
Sure,
good
sir, I'm
Sir,
doing
afternoon.
that.
Dr. Deepanjali.
Good afternoon, everybody. I'm Dr. Krishna Prasad Kudlu, Editor Proceeding of All India Ophthalmological Society. We're very happy to be part of this All India Ophthalmological Society International Conclave, which is which will like it is the initiative of our secretary doctors for involving us to make this presbyopia session. Before starting, I think I welcome Dr. Rohit Shetty, who is going to be chairing this session. Along with panelists, I think I welcome Dr. Pooja. I could able to see Dr. Pooja. I welcome Dr. Pooja Kamar and Dr. Shruti Bhatt, Dr. Shaman Shetty, Sachin Shetty. I think, can you hear me, Megha? Can you hear me?
Yes,
Yes,
sir,
sir, we can hear you.
yes, sir, you're audible.
Yeah. So this is our panelist and the speaker. To start with, I think Dr. Aparna Nayak, she is the cornea consultant, cornea refractive consultant from Prasad Netralaya, Udupi. She's been quite doing a lot of research work and also great trainer for SMILE. I think she'll be talking about preoperative evaluation of presbyopia. Over to you, Aparna.
Dr. Panna, you can share your screen.
Yeah. I hope my slides are visible.
Yeah, they are visible, ma'am. Please go ahead.
So, good afternoon, everyone. I'll be talking on pre-op evaluation of presbyopia. So, presbyopia comes from the Greek word, means old eye. Presbys means old and ops is eye. So, it's a physiological progressive loss of accommodation affecting individuals in their middle age, regardless of the underlying refractive error, causing difficulty in sharply focusing for near vision. It affects around 1.8 billion people worldwide, and by 2030, it is expected to increase by 2.1 billion. And it happens early in people staying in equator because of the UV light exposure. And it is common in both males and females being affected a little earlier because of the hormonal changes and socioeconomic factors as well. And it occurs earlier in hyperopes compared to emmetropes than myopes. So it basically affects the quality of life. So a lifestyle evaluation has to be done in these people based on their reading habits, prolonged digital device use, occupational demands, and night driving requirements. So the ideal solution for presbyopia is not so easy because you have to help them with the distance, intermediate, and the near vision. So the principles to correct presbyopia are many. One of them is the monovision approach, the multifocality approach, the increased depth of focus approach, and the combined approaches. So in monovision approach, what we do is we correct the dominant eye for distance and the non-dominant eye for near. And in multifocal approach, we correct both the distance, near, and the intermediate. The pros and cons will be dealt with it later. Before that, we need to exclude any non-presbyopic factors that contribute to near vision loss. That is the macular and retinal diseases, accommodative insufficiency, especially in younger age groups, dry eyes, cataract, especially posterior subcapsular cataract, where the near vision affects in the brighter light, and any uncorrected refractive errors has to be ruled out, and also latent hyperopia has to be ruled out and corrected. In rare cases, even progressive supranuclear palsy and even other cranial nerve palsies can cause accommodation problems. So a thorough history taking is very important. So before we plan any correction for presbyopia, the patient should be motivated. They have to be motivated to get rid of their glasses. It is very important that you assess their personality type. If they are very apprehensive, they're not that good candidates for surgery. And also realistic expectation has to be explained to the patient. Pros and cons of each procedure has to be explained. So spend enough chair time before the procedure. So take a thorough history of their contact lens wear, history of any dry eyes, family history, medical history, history of any other medication, allergy, previous refraction, everything has to be taken into account. Do a thorough pre-op evaluation of their refractive error. Look for the stability of the refractive error, check for their old glasses and the old refraction, old reports as well. So you have to do a thorough torchlight examination, look for the pupillary reaction, ocular motility testing, cover-uncover test, field testing, and also a detailed slit lamp examination to look for the health of the anterior segment as well as the ocular surface. And then we do ocular dominance testing. So there are multiple ways to do a dominance testing. That is a preferred sighting of a camera, pointing at the source of light, shooting simulation, and also a viewfinder hole test. So most of the patients have clear preference for dominance. Some patients do not have a clear preference. So there is something called as alternate dominance. So everything has to be documented. So this is a video showing a pre-op evaluation where you counsel the patient, talk to them about the procedure, do a thorough torchlight and a slit lamp evaluation, including the motility testing, pupillary reactions, and the cover-uncover test. Once the ocular health is seen, the anterior segment is examined, we perform a thorough refraction. So we compare with the old glasses, we do the refraction in the right eye, the left eye, and then we refine the sphere and the cylinder. And once the refraction is completed, then we do a near vision testing, and we also do a duochrome balancing. Once that is done, we do the dominance testing. So for dominance testing, what we follow is we ask the patient to make a diamond with both the hands and then ask him to bring the hands closer to the face. The eye which he prefers is the dominant eye. And then after that, you can just put a cover-uncover test. You can cover and uncover, and the eye which is fixating the distance target of 660 is the dominant eye. And once that is confirmed, we give a full correction to the dominant eye, and then we add the near correction in the non-dominant eye. And then we see if he's reading comfortably both the distance and the near. If he is comfortable and is able to read without any cross blur, then he is a good candidate for any laser blended vision correction. Not to forget to do a corneal tomography to rule out any corneal pathologies, and also to do a aberrometry, that is the eye trace, to look for any corneal aberrations, and also to look for the dysfunctional lens index. So based on that, we can take a call whether to proceed or not. And also we have to do a vascular aberrometry to rule out any aberrations, and some aberrations are taken into consideration into the CRS master platform in case of presbyope surgery. Also, a thorough dry eye workup is important preoperatively. Check for the IOP, and most importantly, check for the infrared pupillometry measured at 3 different light levels. And then do a thorough dilated fundus examination to rule out any macular and retinal pathology. And once all the examination is done, give the best possible treatment option to the patient. So we have a non-surgical and surgical options. I'll be dealing just briefly. I won't be going in depth. So first is the spectacle correction. So you could give a monofocal spectacle for near. You could also give a bifocal spectacle correction, a progressive correction which covers both distance, intermediate, and near. And also there's something called the digressive correction, which is basically for computer users. It has a good wide middle area for computer usage. Then we have the contact lens. Contact lens comes in multifocal. So multifocal contact lens is also a good option provided they don't have a dry eyes. And also you can try the monovision in contact lens. But the only issue is there is little compromise in stereopsis and contrast. Coming to the pharmacological treatment. So this will be dealt in detail in the upcoming presentations. So we have the pilocarpine 1.25%, which acts like a pinhole and increase the depth of focus. And then we have the UNR 844 1.5% lipoic acid, which helps in increasing the flexibility of the crystalline lens. Then coming to the surgical approach. In surgical approach, we have the scleral procedures, the corneal procedures, and the lens-based procedures. The scleral procedures are not commonly done, it's not accepted widely. And in the corneal procedures, the conductive keratoplasty is also obsolete now. The other procedures I will be just telling in brief. In laser, we have the laser blended vision and the Presbymax. So Presbymax and supracore comes in one category, and the Presbyope and custom Q ablation comes in another category of laser blended vision. So the Presbymax has a multifocal approach. We make the cornea multifocal where we correct the center part for near or distance and the periphery vice versa. So these procedures are pupil dependent. That is the reason in preoperatively pupillometry is very important. We have to measure that. So the issues with this procedure is there is something called as neuroadaptation. So the neuroadaptation after the procedure takes time. It can take around 3 weeks to 4 months or even 6 months. So this has to be counseled to the patient preoperatively. So that is the reason realistic expectation has to be informed to the patients. Also, there is some compromise on stereopsis and contrast sensitivity as well. Coming to the inlays. So there are corneal inlays which is implanted in the non-dominant eye, which increases the depth of focus similar to that of a pinhole. It can be inserted in the stromal pockets under the flap similar to that of LASIK flaps, and these are reversible. The problem with these is there could be slight reduction in the distance vision in the non-dominant eye. There could be glare, compromise in contrast, or any centration issues or any haze or opacities. Coming to the intraocular lens. So intraocular lens, there are plenty of options. So in monofocal, you can do a monovision where you can correct the dominant for distance and non-dominant. You can make it slightly myopic. You can do that, or you can combine. You can do a combined approach where you can put a monofocal for distance and a multifocal for a non-dominant eye. So again, it's surgeon's preference. Not all would like to approach that way. Coming to the premium lenses, there are multiple premium lenses like the multifocal, trifocal, and the EDOF lenses with very good outcome. But the pros and cons of each lenses has to be explained to the patient. In this also, we have the combined approach where you can put EDOF in the dominant eye and multifocal in the non-dominant eye. Again, it's surgeon's preference. Then we have the accommodative lens. It also gives a good result with certain limitations. It has to be explained to the patient. So the take-home message would be there is no unique and ideal solution for presbyopia. So it depends on patient motivation and realistic expectation. So through careful patient selection and appropriate treatment, presbyopia correction can be done with good outcomes and enhanced quality of life. Thank you.
Thank you, Dr. Aparna. I think Dr. Pooja, any comments from your side? Dr. Rohit also, I welcome Dr. Rohit Shetty, probably the man who has done lot of the innovations and also research regarding this presbyopia. And also Dr. Rohit Shetty doesn't require introduction. He's a director of Narayan Nethralaya Group of Hospital, Bangalore. And also he has got experience with a different kind of laser platform as far as the presbyopia is concerned. But I need to take an opinion from Pooja. Any inputs from your side, Pooja?
I think a wonderful presentation. She's very nicely covered, how to choose a patient, what are the options we have, and what would be an ideal patient to, choose, not to choose, when to do, when not to do. So I think this covers a very nice, elaborate overview about the evaluation of presbyopia. So I think no comments, but one thing which we have to understand, as you also always keep saying, is that the pre-op evaluation is extremely important. There is no compromise when it comes to pre-op evaluation, when it comes to presbyopia and counseling. So I keep hearing to your talks all the time, and she also highlighted very nicely. So these two things, whatever said and done, should not be missed when it comes to pre-op evaluation of presbyopic patients, be it IOL surgeries or laser-based surgeries.
Yeah, thank you. I think now I'll be talking about addressing presbyopia. Aparna, can you stop share the... Yeah, thank you. I think I'll be sharing my screen. Yes. Can you see my presentation?
Yes, sir, the slides are visible.
Yeah, just a minute. I am trying to... But 1 second, how to minimize this? Okay. So I think most of the topics what I wanted to cover, I think everything has been covered by Dr. Aparna. So this is my financial consultant. I think she had already explained what are the principles used to correct presbyopia. Either you can do monovision in one eye, and the other vision, other eye you have to do the something called micromonovision, or you can even opt for multifocality, or you can even opt for increased depth of focus in different approaches. So these are the total surgical option for presbyopia. You can tackle the sclera by putting scleral implants or laser procedure, or you can tackle the cornea either, as I already said, by doing monovision or by creating a multifocal treatment in the cornea, or you can put a corneal inlays. Once upon a time, it was more popular presbyopic surgeries, or still a lot of my friends still they practice contact lens presbyopia practice. And of course, now a lot of intraocular lens has been coming to the market, which gives a fairly good results about the presbyopia. This is one or two word about the multifocal contact lens. Of course, I think basically these lenses, something called aspheric design lenses and monthly disposable. But again, you need to talk to the patient pros and cons of contact lenses, and you need to have to be that perfect with these lenses. So pharmacological eye drop already Aparna been mentioning. I think Dr. Sachin is going to talk about this particular product, Presview. Now, a lot of other companies also come with this particular drop. Basically, it is a parasympathetic mimetic drug which induces the meiosis and increased depth of focus. So multifocal lens, I think we started with the multifocal lens. Then we come with the trifocal. The advantage is normally patient will have a additional of intermediate vision also. Now you do have got a advanced monofocal. I think I'm going to stress upon most of that on advanced monofocal, because this is very, very important. Nowadays, we have been, those who are doing the premium surgery, we are all converting them to advanced monofocal, because these lenses will have a something called a good intermediate vision. So also the advantage is fewer visual disturbance, like no glare and halos. So these are the one of the newer IOLs I've been started using, especially this is a Galaxy from Renner, no financial interest. Basically, it is a non-refractive spiral optic, which is like with a very minimal dysphotopsia. What they claim that 100% of the light is used with a no loss of transmitted length, and it also acts as a trifocal intraocular lens. This is the one more lens I just started using, like 4 or 5 lenses in my femto setup. Basically, you need to have femto setup with you. Normally, it is a Rexis fixated lens. It has got a 4 additional clip for stable position, which is in the bag. And they claim that aberration neutral. Again, you need to look at the price also. So these are the earlier EDOPs still we started using, but because of it has got a rings on the optic size, patient will normally will have a glare and halos. So these are the one or two words about the ciliary complex modification. One of my friend from Spain, he is one of the, he has done thousands of patients. What he does, 4 PMS segments which are implanted in the sclera by making 4 incision. What they say that sclera is supposed to be lifted to create a more space between the ciliary muscles and the crystalline lens also. So about the laser procedure, I think one of my friend from Taiwan, he has done 1,000+ patients, especially with this laser procedure. What they do, the help of the YAG laser, which ablate around 600 micron laser spots on the sclera, which are presumed to free from the scleral muscle to contract. Normally will have an effect of near vision of around 1.5 diopter. Of course, Presby-LASIK, I think the Rohit started with this Presby-LASIK. Basically, this is it's a multifocal LASIK treatment, biaspheric treatment that induces the spherical aberration. So there are like a different type of Presby-LASIK also. They started with the central Presby-LASIK. Then Presby Max has come into the market. Basically, again, it's a biaspheric multifocal ablation with something called a micromonovision. The dominant eye is focused slightly more for distance and non-dominant eye is slightly more for the near. Then AMO come with something called unique technology for presbyopia, that is especially for hyperopic patients, from the Vizix platform that steepens the central zone for near vision, and also it leaves a periphery for distance vision. Basically, it is for the hyperopic patient. These are the problems you have been faced with the Presby-LASIK also. Initially compromise on the distance vision, blurred distance vision till 3 months, adaptation problem and the night vision problem in the initial state. Now then comes the supracore, Basically, it's a LASIK-based procedure performed on the Technolas 2-1 examiner laser system from Bosch and Lomb. Basically, here in supracore, you need to you have to correct both the eye for distance and you need to correct both the eye for the near vision. Basically, the elevation is surrounded by an aspheric optimized area which smooth transition creates the intermediate vision zone, while the distance vision is positioned in the periphery. Basically, it's a pupil dependent procedure. So normally what they say that patient will have a good distance, intermediate and near vision. Then again, there was one more procedure from the Bosch and Lomb. Intracore has come into the market, which is performed in the Stroman flap, which is a flapless procedure which deepen the cornea approximately by 1 diopter. Then today I am not talking about any of the corneal inlays because corneal inlays has been like a moved out of our market. But today I am talking about the Presbyon. Basically, what we do in Presbyon, it is a we make the dominant eye immetropic, make the non-dominant eye myopic by 1.5 diopter. Also by creating a control aberration in both the cornea. By doing that, what will happen? As I already said that dominant eye, we have to make it immetropic, non-dominant eye myopic by 1.5 diopters with a blend zone where the vision both from dominant and the non-dominant eye meets up. So why we pick this technology? Because brain tend to suppress certain blur from one eye to the other eye. So they get adapted so fast. So basically, I think all my patients, those are undergoing this particular treatment, I do the cycloplegic refraction. And these are the things I think already Aparna has been highlighted. My chair time with the patient, especially for laser refractive surgery or presbyopic surgery, is 20 minutes. I spend 20 minutes with the patient. I explain about, I ask all their history. Then I myself do the refraction, then make sure that there will not be any other problem. Then also I do the refraction, make sure that I know the dominant eye also. So once you know the dominant eye, then you have to do something called micromonovision testing. Aparna already told about this. I am not going to explain about this particular video. So our aim to know the dominant particular, make the non-dominant eye myopic by 1.5 diopter. If the patient doesn't have any cross flare, then I think these are the patients do well after the treatment. There are some percentage of the patient, they say that I am having a blurred vision when I am doing the micromonovision testing. Repeat for a couple of times. Still, if they say that I am having a cross blur for the distance, even for the near, I think these are the patient I am not going to pick them for this Presbyon treatment. Of course, as I said that detailed retinal examination is also very, very important. These are the different type of ocular, how to know for your ocular dominance. Most of the patient will have a very clear-cut ocular dominance. Some of the patient may have a alternate dominance. That is a bit tricky. I think you need to do the documentation. Then, of course, all other investigation, pentacam, topography, you have to do that. I think I'm not going to. Basically, this procedure will be done with the help of a CRS master special computer, which is provided by the company. The data from the CRS master, it will be transferred to the examiner system. This one particular test I always do eye trace. Always you look into the dysfunctional lens index. Always, if it is DLI is less, then I think you should not pick them for this particular treatment. Of course, with the followed by the VASC analyzer to enter the bridge. So procedure is very simple. Always do with the femto platform. First do the femto flaps. So we could able to see some amount of OBLs while doing this procedure, while doing this treatment. Once done, I think the patient will be shifted under the examiner table. So as simple as that, how you do the any of the LASIK procedure. Then you go ahead with the treatment, lift the flap, then any of the treatment has been transferred from the CRS master to the Milady LASIK machine, then it will do the treatment for both dominant and non-dominant. I'll be taking a half a second. So 97% of the patient will tolerate this treatment. Basically, it's a laser blended vision, is a non-dominant pupil size. You can do wide range of power of hypermetropy up to 5 diopters, myopia up to 8.5 diopter. All patients will have a good intermediate and near vision and adaptability of 97%. So in the end, which is the best treatment? I think if you compare multifocal lens, corneal inlays, presbyLASIK, supracore, Presbyon, As far as the distance vision, intermediate vision, near vision, night driving problem, pupil adaptation and reversibility, definitely Presbyopia will have a edge over all these treatment provided patient doesn't have cataract. I thank again All India Ophthalmological Society for the opportunity. Thank you one and all. I think now our third speaker is Dr. Sachin Shedole. He'll be talking about what's my idea on the presbyopia with the pharmacological medication, the pharmacological eye drops. Over to you, Sachin. I think Dr. Rohit is here. I think I need a comments from Rohit. I think you're also started doing Presbyon. Any inputs from your side? Dr. Rohit is here. Or Pooja, you can answer behalf of Dr. Rohit.
So I think again, Presbyond is a very wonderful treatment, and I think we'll be covering over the next two talks when I present that how it has become a game changer when it comes to correcting presbyopic error. And also sometimes we have a lot of patients who don't want to undergo an IOL-based surgery, and they because they think I've not developed cataract, why should I undergo a cataract surgery? Still, we are in India, so there's always this myth. So presbyopia laser surgery becomes a boon for those kind of patients. And if, as you suggested, if the patient is chosen very wisely and after appropriate workup, they are very happy with those kind of treatments. They are spectacle free after some amount of neuroadaptation, which is around few months. They are also able to read for distance, intermediate, near, and their quality of life improves significantly. Especially patients who have very high refractive error, hyperopic patients who have reading glasses. Those are the patients who are extremely happy when they undergo Presbyon treatment. So the results have been wonderful.
Yeah, thank you, Pooja. I think over to you, Sachin. Sachin, unmute.
You're not audible, Dr. Sachin, yet.
You're not audible.
Are you connected to another mic or earphone?
Okay, am I audible now?
Yeah.
Okay.
You share the screen.
Yes. Okay. Good afternoon, everyone. Today I'll be talking about the emerging horizons, especially the pharmacotherapy in the presbyopia. So basically, if we talk about presbyopia prevalence, currently 1.8 billion people are presbyopic, and it is estimated that this number might increase to 2 billion or 2.2 billion by 2050. When it comes to presbyopia, it always affects the quality of life. So it is whether it is the inconvenience of the glasses, whether it's the economic cost of the glasses or contact lenses or the surgeries. When it comes to the increased usage of mobile phones these days, reading, writing, and many other things. So the uncorrected presbyopia is estimated to be around 35% globally. This is linked to the economical burdens as well. So when coming to pharmacological treatment, there are various pharmacological treatment which are still in research and everything. But currently the FDA approved treatments are basically pilocarpine 1.25%, which is the Presbyo drops. Other agents which are currently in phase 2 and phase 3 are combination of carbachol and brimonidine, whether it is pilocarpine with various other agents and even the newer medications. So basically, we have done a certain clinical trial or a short research where we have used the drops pilocarpine 1.25 for a OD dosage. This was Presbyo drops. So basically, pilocarpine is a naturally occurring alkaloid which acts on the M3 muscarinic acetylcholine agonist, and it was used in other systemic diseases, but in ophthal, it is currently used as an anti-glaucoma measure, plus recently it has been started in the treatment of presbyopia. So the indication is for anyone who is above 40 and may range up to 50 or 55 age. The recommended doses is currently either OD dose or a twice daily dose. The second dose can be either after 3 hours or 6 hours, depending on the agent. So the mechanism of action is basically dual mode, which acts on the muscarinic receptor of iris sphincter and the receptors at the ciliary muscle. So basically it reduces the pupil size, increases the depth of focus, and it also has some effect on the amplitude of the accommodation. So there are various clinical studies on pilocarpine. Initially, I'll be talking about the study which was done in our center. So basically, it is a Indian phase 3 clinical study. So the study involved 234 subjects in various centers. So they were followed up for 30 days and they were using the drops for OD dosage, basically for the both eyes. And the age group was 45 to 50. The conclusion of the study was pilocarpine 1.25% was having superior efficacy compared to the placebo. So basically, more than 30% of the candidates were having gain in 3 or more lines in mesopic conditions, and corrected near vision was better compared to the Gemini study. The efficacy result here, we are talking about, we have various measurements at various times after using the drop, which is 15 minutes, 30 minutes, and so on. So there was a significant gain of 3 or more lines in binocular vision correction. So photopic as well, there is improvement in 65% of the patient. And when it comes to safety results, the most common side effect or complaint was headache or brow ache in approximately 10% of patients. Rarely there were other insignificant side effects such as eye pain, hyperemia, or mild blurring. There were no serious side effects and there was no patient who opted out of the study. So the basic outcome is that it has a good tolerability profile and virtually negligible side effects. The other studies which are quite significant in this area, this is Gemini 1 study. This also preferably says the OD dosage of the pilocarpine drops, and the efficacy was also almost similar to what we have achieved in our studies, which is 30%, gaining more than 3 lines. So the common side effects were similar, headache and hyperemia. There is also a Gemini 1 and 2, the further study, where once OD dose was again tested, and this was here the patients were included post LASIK or without LASIK also. The efficacy again similar, and 35% in the mesopic pupil, 40% in the photopic pupil, and the intermediate vision was quite significant. So basically, Gemini study 1 and 2 proves that pilocarpine can effectively be a very good treatment for near and intermediate vision without compromising on the distance vision, even regardless of the patients who have undergone refractive surgery. There is another study which is called Virgo study, which was basically testing the twice BD dose. So here it was used 6 hours apart, and this study was done for 14 days. So here also around 35 to 36% of the patients, they had improvement of 3 or more vision lines. The efficacy results are pretty much same. So towards the end, I would say that the ideal patients for eye drops are patients who are early presbyopes, who are yet to use glasses, and the patients who have emetropic presbyopia, patients who don't want to use glasses or who are not ready for any surgery. We can also try this on the patients who do not tolerate monovision or who have a history of PRK or LASIK. I would suggest that these drops will have greater impact on patients with monofocal and EDOF who are not happy with their intermediate or near vision. So where can we fit this? We can offer it as a cosmetic and aesthetic solution for presbyopia for candidates who don't want the surgery or are not fit for surgery. and post-surgical or post-refractive or post-IOL patients. So the take-home message is presbyopia drops basically it act as like it is a significant improvement and it has negligible visual side effects, and some patients they can always have a second drop after 3 to 6 hours to improve the duration of the action. Thank you.
Thank you, Dr. Sachin. I think this is one eye-opener for most of us. But some of the patients, I started this drop, but they tend to complain of occasional headache. And also long-term people say that there is a, I think probably 0.1% incident retinal detachment. I really don't know regarding this. I think, do you have idea?
Hello, sir.
Hello?
Yes, sir.
Pooja, can you hear?
I think, is it?
Can you hear me? Yeah, can you hear me?
Now we can hear you.
Problem.
Now we can hear you, sir. Hello?
Yeah. Just, yeah, Pooja, I want
sir.
your inputs for this particular. I want your inputs.
So I think, sir, what you pointed out is very right. And those were my questions also to Sachin, that he said that none of the patients had any significant complaints. But we do have seen reports of headaches when we start using pilocarpine drops, especially for presbyopic patients, and also occasional impact for retinal detachment. So I think I also have this questions because headaches are something which I have heard my colleagues also saying that, patients do complain of headaches, especially in first 1 to 3 months.
I think we even had, say, 10% of patients complaining about the headache. And because it was a short-term study, I think further studies will have more information regarding this, or maybe a better version for different formulations or so.
But how long does the headache last?
Usually they complain.
Sachin, can I just put in a word here?
Yes, sir.
Hi. The thing what has happened here is I think the formulation what they've done here, invariably when we are taking up the patient, especially the immotropes, the early 40s, what even the company have told this, the patient selection, if you're taking people with a history of migraine or anything, this is going to exaggerate. For other people, you can expect a headache usually up to 5 days. Beyond that, if it is still going, it is better not to proceed with the study. That is what was the study protocol, which was to be told. So usually which patients we have taken up to 20, which was allocated to us. I think 3 people complained of pain. That was initially up till a week. That was the max. But after that, they were fine with that. So there was no patient in our study which extended after a week. Regarding the retinal detachment and all that, so those were the other studies before, which were got to us, which they have told since because of the formulation what they have done, you still need a very long term. For whatever the time duration they have done, you have now not actually taken myopes or you have only taken immotropes for the study. So that's the reason I think they've excluded those people also in the study with anyone with the retinal issue or mild to or severe myopes which were not taken. Early presbyopes who don't want to wear the glass all time if you're going for a function, all that things. Yes, I think we've got a good result up till 6 months to 1 year, which we have done a follow up. But how long can you use it? When do we start stop it? That's still we need to address on that. Even the company people are still trying to figure that out. But for the time being, for early 40 within 45 range, which you want to use, you can still use this. That's
Thank you, Dr. Shaman. There was very good points because everybody needs to know that, where is it most effective, how to use it, and why is it different? So thank you for highlighting.
Yeah, thank you, Pooja. I think now come to the main part of our presbyopia session. But the talk will be by Dr. Pooja Kamar. I think we all know that Pooja Kamar is the she is also not only ophthalmologist, she is the research ophthalmologist, also scientist who has done a lot of work on refractive surgery. Probably the superstar of Indian ophthalmology. I think I welcome Dr. Pooja Kamar, and she'll be talking about her very, very important subject, that is depth of focus, aberration engineering, functional vision in laser refractive surgery. And also she'll be covering Dr. Rohit Shetty's talk on understanding pupil dynamics, accommodation, and neural adaptation in laser blended vision. So what to you, Dr. Pooja?
Thank you, sir. Thank you once again. I would like to also thank you for giving me this opportunity to present in your always the best presbyopia session. And I would like to thank Rolika, Megha, and Dipanjali for coordinating this entire show. So without further ado, as sir said, we will be today discussing about something which is just beyond 2020, because in today's era in refractive surgery, it's not just about visual acuity, but it is about depth of focus and quality of vision. And modern patients, especially young professionals, demand functional vision across all distance and lighting conditions. So the question is no longer simply can they see 20/20, but rather how comfortably can they function in the real world. So patients today, as I said, live in a continuous visual transition: screens, phones, dashboards, presentations, and night driving. So they require rapid switching between distance, intermediate, and near tasks. And even small optical compromises become symptomatic in this population because their visual demand is extremely high. And we know these are the set of patients who keep complaining, keep nagging us. They are 20/20, all the tests look fine. The signs are okay, but the symptoms are still not okay. So as we move towards the Gen Z generation, I think we have to understand one more thing is that today's era is no longer about 20/20, and a patient may tolerate small refractive errors, but they do not tolerate visual fatigue, glare, halos, or any fluctuating clarity during prolonged digital work, especially after refractive surgery. So we all have to understand what is depth of focus. And depth of focus, because as I said, it's beyond 20/20, and when it comes to beyond 20/20, it's the transition. And transition is nothing but the depth of focus, the eye's ability to tolerate small amounts of blurs while still maintaining acceptable clarity across a range of distances. And good vision is not just one point sharply, it is how smoothly the visual system maintains clarity from distance to near. So we call something, we can call this just not the depth of focus, but a biology of focus as well, because clear vision is not just now created by optics alone. And I have my mentor, Dr. Rohit Shetty, who always keeps talking about that it's not just about the cornea, it's not just about your lasers, but it's about the biology behind the eye. And the biology starts from the tear film, then cornea, the pupil, the retina, and the visual cortex. So the depth of focus is therefore not purely optical. Even a perfect ablation can fail functionally if the ocular surface, the neural adaptation, or the retinal processing is unstable. So what is a spherical aberration? It occurs when the peripheral rays focus at a particular point, that central ray is altering how light spreads along the optical axis. A small amount of positive spherical aberration can increase the depth of focus, but this always comes with a trade-off. More range usually means reduced peak contrast and increased visual symptoms. And this slide just demonstrates the relationship between the spherical aberration and depth of focus. Why are we talking about spherical aberration? Because they're always interlinked. A controlled positive spherical aberration can elongate the focal region and improve intermediate or near tolerance, but extensive aberration increases the scatter, glare, and loss of mesopic quality, and which is why more depth of focus does not always mean better vision. So this is how your cornea looks like before surgery. The eye exists in a naturally balanced optical state, but we all know that, and it's an entire combination of cornea, crystal lens, the pupil size, and the net effect. But we all know that laser surgery always changes the shape of the cornea. It does not only remove the spectacle error, but it changes the optical architecture of the cornea. And by altering the corneal sphericity, the transition zones, and higher order aberration, surgery intentionally induces controlled optical imperfection to reshape the functional vision. And again, myopic laser treatments typically increase the positive spherical aberration because the cornea is now flattened, and it's more in the flattened more in the center than in the periphery. And this may improve the depth of focus and intermediate tolerance, but excessive spherical aberration reduces the contrast sensitivity and increases glare and halos. And this is an interaction of the myopic and hyperopic ablation, which changes the optics completely different. Myopic treatments tend to increase the positive spherical aberration, as I mentioned, and the hyperopic patients have often induce a negative spherical aberration, producing sharper peak focus but less tolerance to defocus. So traditionally, it was all about a wavefront optimized treatment where you just correct sphere and cylinder. But as we know that it no longer is about correcting the refractive error, it's about spherical aberration and a combination of other aberrations. We do have newer procedures like wavefront guided ablation, aspheric profiles, especially in lenticule procedures, topo guided treatments, and now also the ray tracing guided treatments. So this is what a patient wants. Even if a young patient can have an alteration when it comes to after refractive surgery, they want a good vision when it comes to distance, intermediate, and near. So we've done this study where we have tried to look at the depth of focus, where we are trying to see what is the quality of vision, the sphere, the cylinder, and aberrations for all the for all the distances, be it your distance which is 20 feet, be it your intermediate which is 60 centimeter, or be it your near which is 40 centimeter. And this is the work which was published few years back in JRS, where we compared the normal emetropic eyes with SMILE, LASIK, and PRK. And what we observed was that all the patients were doing equally well, but when it came to SMILE, there was a little bit more induction of defocus compared to that of emetropes, and SMILE and LASIK were similar, which does give us a good hope that LASIK contour treatments are the gold standard, and SMILE is doing equally well here when it comes to the depth of focus. Even when it comes to visual acuity, the patients post-refractive surgery did not lose any depth of focus after LASIK or SMILE procedures, as they would, as we traditionally intend. So then this just tells us the newer laser platforms are just becoming smarter and smarter, which is not making these patients lose the depth of focus. And this is just a representation with the ISRS also. For distance patient is emetrop, 0.5 is nothing, but it helps them to focus. As it comes to intermediate and near, the patients do accommodate well after refractive surgery, and that's why the spherical and the cylindrical error is changing. And this is the cylindrical error as well, which is changing for distance, intermediate, and near. For all the procedures post-operatively. When it comes to change of aberrations also do play a very important role. As the defocus increases from distance to intermediate to near, higher order aberrations also increase as well. And this is the mechanism through which some procedure create extended depth of focus vision for these patients. So when it comes to why some LASIK patients read better, it's not, as I said, it's not just about the laser, it's not just about how the laser delivery was done or the depth of focus, but there is also a role of epithelial remodeling and neural adaptation, which I'll cover in the next talk, which also makes this patient see better. So sometimes it's not just about your aberrations or the optical system, but we also have to look at the patient's ocular surface with epithelial remodeling and neural adaptation. Some patients may land up in more depth of focus, and they do have complaints of glare, halos, night vision problems, especially after refractive surgery. And these are the patients who do have a non-strabismus binocular vision anomaly, which is an orthoptic anomaly. And you can do an evaluation for these patients using one of these platforms. And once you have done that, you can give them exercises with Brock string, cat card, negative lens therapy, and they do well after this therapy. So if the patients do have complaint of glare, halos, look at the binoculars, single vision anomaly, the accommodation related anomalies, and if they have one of that, then please do treat them with orthoptic exercises, and they do treat better. The future is about the combination of artificial intelligence, the adaptive optics, and the digital twin eye model, and we do have to keep that in mind as well. So to conclude, depth of focus is one of the most powerful and the new evaluation tool beyond Snell's chart, beyond 2020. Small control changes in aberration does help us in improving the enhanced or functional vision, and the future lies in balancing the optics, the biology, the neuroadaptation by improving the depth of focus for this patient. patients. Thank you.
Thank you, Pooja. I think it was a really phenomenal talk because I was just looking at your lot of points I am grasping. You said that in SMILE, definitely one of the good procedure as far as the depth of focus is concerned. So, see, if the patient undergone SMILE, so age of 40, will they get the, in what age you expect them to have a presbyopia, or can they continue to have a very good presbyopic effect after SMILE for another 10 more years?
Sir, it would not be probably 10 more years. It may be maybe around 3 to 4 years. Usually now we are in an era, traditionally the presbyopia starts at 42 or later. But if you see in today's OPD, a lot of patients start complaining about reading error at 38 also. So we call it the pre-presbyopic age group, and probably in future it's going to be the new presbyopia definition, where it started probably at 38 and 40. And it's not because of some other changes, but it's because of the digital screens, the accommodation related anomalies. So SMILE definitely helps a lot for this kind of patients. Until 42 or 44 also, they are able to stretch a lot, at least till the intermediate vision for sure. And some patients may do very well with the near vision. And it also has a lot to do with pupil reflexes, so which I will cover in the next talk. So if the patient has to read very well beyond 42 or 44, it's not just about your laser profile, but it's also about the pupil dynamics and how the brain neuro adapts.
And I think epithelial remodeling, I think it will not count, especially in SMILE. Correct, no? Epithelial remodeling really won't have that effect in as far as the SMILE is concerned.
So what you said, sir, is absolutely right. And that is why I said why some patients don't see better, because 90% of the patients have a very good epithelial remodeling, but there are 10% of the patients who have a pre-existing subclinical ocular surface changes. Those patients will have. So again, I will show some cases where if the pre-existing ocular surface abnormalities are missed, those are the patients who will be unhappy post surgery for these patients, but not 90% of the patients.
Thank you, Pooja. I think Pooja will be also covering Dr. Rohit's topic, because Rohit is in his hometown. He has got a the connectivity is not that great. Still, he is. I welcome Dr. Rohit Shetty. I think Rohit, you have to be there till Pooja finishes your talk. We need your valuable suggestion as far as this presbyopia treatment is concerned. So Pooja will be talking about the keynote lecture of Dr. Rohit Shetty, that is understanding the pupil dynamics, accommodation and neural adaptation in laser blended vision. Over to you, Pooja.
Thank you, sir, once again. And I would like to also thank Rohit, sir, for again allowing me to cover for his talk, because it's always very difficult to do justice to what he's going to talk. So please don't even try to compare Dr. Rohit, sir, with myself. And at the outset, I have no financial interest, but a lot of things I have learned during my time at Narayan Netralaya. So when it comes to presbyopia correction today, we do have lens-based surgeries such as refractive lens exchange and premium IOLs. I think my next speaker is going to cover that, which do remain the most established procedures. However, a lot of younger presbyopes are still not comfortable, as I said in my previous talk, with the idea of cataract surgery. They still feel that we have not developed cataract. Why should I get a cataract surgery done? So they don't want something which is not a completely invasive procedure, but something to do with a partially invasive procedure. And that's where the option of presbyopic LASIK comes. We do have a lot of options, Presby LASIK, Presbeyond, Supracore, and now we do have options with drops as well. So that's why this becomes very a viable option, because it offers a corneal-based, less invasive solution that attempts to improve the functional near vision while preserving the natural lens and also maintaining the distance vision as much as possible. So what would be, Aparna has covered this, so I'm not going to go with this, but the most ideal candidates for any presbyopia laser surgery is the early presbyopes. The hyperopic presbyopia patients do very well when they undergo laser-based refractive surgery for presbyopia. These are the the happiest patient compared to the others. Patients with latent hyperopia and also patients where they have an early accommodation decline, which also I will be covering in the next talk. So before we go into the the main part of the talk, we always have to understand that it's a 3 bi-directional link. Always the pupil accommodation and the neuroadaptation are always linked with each other. And even though a true accommodation reduces in presbyopia, the near trial reflex still partially survives, especially pupil constriction and convergence. And near-induced
Excuse me,
myopia.
Dr. Pooja, I'm so sorry to interrupt. Your screen is split. This is not coming as this is not covering the entire screen. Your screen, can you share your screen again?
Okay, just give me a second. I don't know what happened.
No, we could able to see your face and the screen half off. So if you can put us into the
Okay, just
slideshow.
I think it's there in the Zoom. Sometimes it happens sometimes. So is my slide visible now?
No, but again,
Yeah, it's
same only.
visible. I'll just check the settings once again. Yeah, it's.
I think you are sharing the screen, I think.
No.
Okay,
Dr.
I'll just
Dipanshree,
try.
your screen is shared.
Yeah.
Yeah,
I
I'll
hit
just
the
try
button.
to share again.
I was trying to search for the. Can you try again, ma'am?
Now?
Yes.
Yeah, now I think it's
This
going.
is
Yes,
perfect.
this is
Please go ahead.
Okay, so
Sorry
I
for
think
the interruption.
Perfect, Pooja. Perfect.
Perfect. Sorry for that. I don't know what happened, but again, I think I'll start with this slide, which tries to explain the physiological basis of the laser blinded vision, which is the presbyopic laser treatment. And we have to understand that whenever we are doing a presbyopic laser surgery, it's always a combination of 3 links here: the pupil, the accommodation, and the neuroadaptation, what you see here. And even though the true accommodation reduces in presbyopia, the near triad reflex still partially survives, especially with pupil constriction and convergence. And a lot of Indian patients have smaller pupils, so that's actually to our advantage, which we can use. And near-induced miosis, which is the same, increases the depth of focus and helps compensate for lost accommodation for this kind of patient, especially in Indians. And at the same time, the brain learns to balance 2 different optical inputs, one optimized for distance and the other optimized for reading, which is for the near. And that is what we call as the neural adaptation. So over time, the cortical adaptation improves this image selection process, making vision even feel more natural and effortless. So the laser blinded vision, which is the presbyopic laser treatment, works through the combination interaction of residual near reflexes, the optical design, and the neuroadaptation, what we see for this patients. And my previous speakers have covered up about the presbyopia laser surgeries. So I'm just going to delve into why some patients are unhappy post presbyopia laser surgery. So before we dwell into it, as I mentioned, it's a combination of 3 things: the pupil, the accommodation, and the neuroadaptation. So first thing, let's understand the accommodation. So whenever a patient is Okay, sorry. Yes. So this is what a normal, I think something is wrong with the screening, but yes, this is how a normal accommodation would look like. Whenever you give a stimulus, first the accommodative reflex, this is from the OSIRIS, it will turn green. That means the accommodation is normal. When the patient tries to read for reading, the eye turns, the accommodation turns red. So if it's a combination of green and red 1 by 1, that means the accommodation is on the normal side. And this happens when you're giving a stimulus to the patient. So this is how the normal accommodation looks like. But when you give a stimulus, if the patient's accommodative state, you can see it's just in green. If you keep looking at the video, it doesn't transition from green to yellow to red. So that means the patient is not able to accommodate from distance, intermediate, and reading. And that is what you call a poor accommodative response, which you traditionally see in a presbyopic patient. And this is what you see here. But sometimes, even in a very old patient or very early patient, they do have excessive accommodation. So when you give stimulus, it's not a transition from green to yellow to red. It's just continuous red, and this is what an excessive accommodative response is. So you have to understand the types of accommodation even in a presbyopic age group, because a 50-year-old can have this kind of accommodation, and even a 35-year-old can have a completely poor accommodation. So it's not just that one size fits all. It's like a fingerprint. Every patient, be it presbyopic or a younger patient, has a different type of accommodation, and this is just a summary of all of it, of how different types of accommodation are seen in practice, and we need to understand. Now, accommodation obviously rises from aberrations, and aberrations are not just internal or at the cornea. It's present in the entire eye, and that's why they are called as the Dr. Rohit mentions this as the commensals in the eye. And are they good or bad? They are both, and the balance of aberrations is extremely important. So how wonderful it would be that how we measure the refractive error with a phoropter or our trial frames, if we could measure the aberrations also with a phoropter to see what best aberrations with the patient, and with that we can choose whether to do a presbyopic laser surgery or not, because presbyopic laser surgery, as mentioned in my previous presentation, changes the entire spherical aberration. So if we could measure the spherical aberration with a phoropter kind of a thing, it would tell us what patient to operate, what patient not to operate. And we do now have a technology which is called as the visual adaptive optics, which is an aberrometer and a simulator. It is an Hartmann-Shack aberrometer and also a special light modulation technology to simulate the aberrations, where we can measure how the patient is going to do with certain aberrations if we correct it or if we induce it. So this is just a representative diagram of how it looks like, and this is what a patient sees with the aberrations. We tell the patient after switching on some aberrations, you can see, please read the alphabets on the board, and the moment where it becomes unclear is where the patient is not accepting the aberrations or patient is not happy with that certain aberration. So we do have a technology now where we can use this phoropter to simulate certain aberrations to see whether the patient is doing right or wrong. And this is just a small video. With the interest of time, because we lost while sharing the presentation, I will kind of fast forward it. And you can see that we are not only switching on and switching off the aberrations, but we are changing, increasing and decreasing the aberrations, and asking the patients if they can see the letters clearly. And also you can see it for different sizes, which is the logmar. And that is what we can do with this assessment. So how do we use it in our clinics? Let's look at the presbyopic laser patients. These are two patients who want to undergo presbyopic LASIK, but one patient is extremely happy with the surgery and one patient is unhappy. So why did that really happen? So this is a patient who tolerates 1.5 diopters for reading and has come for presbyopia laser surgery. These are the corneal and the internal aberrations. On eye trace, it looks relatively fine, nothing to worry. So traditionally, you would go and do a surgery for this patient. But we decided to do adaptive optics for this patient. And we started changing the spherical aberration. With patient's own spherical aberration, patient was reading 20 for distance and N8 for reading. But when we started inducing the spherical aberration for this patient, the vision started worsening, both for distance and reading. So we knew that even though the patient is 42-year-old, tolerating 1.5, good corneal and internal aberrations, but when we induce a spherical aberration, the patient was not very happy, and that's why this was not a very good candidate for a presbyopia laser surgery, and we avoided a laser-based procedure for this patient and gave a lens-based option for this patient. Now, this is a 50-year-old gentleman. Traditionally, you are scared to touch this kind of patients. Again, similar profile, we did the adaptive optics for this patient, and to our surprise, this patient was actually doing better when we started inducing the spherical aberration for reading. So we knew that this patient is going to be happy after a presbyopia laser vision correction. correction. And that's why option of presbyopia laser vision correction was given for this patient and not a lens-based solution. Lens was absolutely clear, so we could go ahead with the with this kind of surgery for this patient, and patient was extremely fine and unhappy. So this is how we can select patients when it comes to future. However, you do have to understand that there is something like a neuroadaptation also, and neuroadaptation is nothing which happens overnight. It is a process over time, over months, and it starts at as early as 1 to 2 weeks, and it goes up till 3 months, and in some patients it may go up till 6 months as well. And that is one of the key reasons why a laser blended vision surgery, a presbyopic laser surgery may have a successful result or an unsuccessful result, because after surgery the brain needs time to learn how to process two different optical images simultaneously, where one eye is corrected for distance, one eye is corrected for reading, and that's why we have to understand the same for this patient. And as I was mentioning, that for elderly patients, a lot of times their ocular surface is compromised. And when we do a laser-based refractive surgery for this patient, if preoperatively they have vitamin D deficiency, a meibomian gland dysfunction, or a contact lens intolerance, even though the accommodation is fine, even though the neuroadaptation is fine, but the epithelial remodeling may be uneven, it may be erratic, and that's why they have a marked epithelial hyperplasia, and that's why they have a poor quality of vision, not because your surgery has gone wrong, but because of the epithelial profile. So taking care of the ocular surface is very important for these patients. And this is just a new software where we are trying to, this is the NEED software, where we can see how the health of the tear film is, how the epithelial health is, and how the combination of it is. If you see here, the tear film is extremely healthy. The epithelium also looks relatively normal. And if you see the accommodative response for these patients, it's also relatively on the normal side. But if here you can see the tear film is unhealthy, extremely irregular, the epithelium is also irregular, and if you see, this is impacting the accommodation of the patient. So it's not just your laser surgery, but sometimes your epithelium and tear film can also impact the accommodation of this patient. And you can see that this patient is in an excessive accommodation, and he or she is unhappy, not because of your laser or skills, but because of the tear film abnormality and the ocular surface changes. So to summarize, yes, we are moving towards a more controlled outcome where we can give it to our patients. So, but it's not just about your lasers or skills. Presbyopic LASIK success depends on neuroadaptation, not refraction alone. Spherical aberration can improve or degrade vision depending on the patient tolerance. So in future, if we could have a visual adaptive optics in our clinics, we could cater more and more laser-based surgery for the patients. It also helps us to predict happy and unhappy patients. Accommodation and pupil dynamics vary between individuals, but all can also affect outcomes. So it's very important for us to study that. And nonetheless, if a patient has an ocular surface issue, we also have to treat it, because that can also impact the outcomes of the procedure. Thank you.
Thank you, Dr. Pooja. I think you covered a entire gadget of how Presband work. I think it was even eye-opener for me. Just we are short of time. We'll have a discussion in the end, because I need to ask you a couple of questions. Just before, I think we'll go to Dr. Shaman Shetty. He'll be talking about newer presbyopia correcting IOL. Why I wanted Shaman to speak now, because some of the IOLs also again working on this aberration control IOL. So we'll have a collective decision in the end of the talk. Over to you, Dr. Shamant.
Yeah, am I audible?
Yeah, you're audible, Shaman.
Yeah, good afternoon. I thank Dr. KP sir and the AOS for giving me this platform to talk about this. So after this full talk about presbyopia, I'll just come to the IOL part. Our main goal is to restore a broad range of vision. So basically improve your quality of life by minimizing your spectacle dependence. So we've seen our natural crystalline lens, like, what all does it do? Accommodating, giving us distance in for distance, intermediate, and for a near. Our contrast is preserved, and there is no much aberrations. Even we have seen like how we have seen like an IOL getting evolved, like from a plain PMMA to an aspheric one right now. But even the other ones have also, like, we have seen the evolution of like multifocals, trifocals, or the EDOFs. Basically, like, a modern shift towards like creating good IOL which we can reduce glare and give like a complete presbyopic effect. But main thing which we should not forget before we consider directly going into an IOL is you get your evaluation right for your dry eye, MGD, corneal assessment for any scars or dystrophy, get your pupil measurement, eye trace, mainly important like highlighting on your angle kappa and angle alpha, because that basically determines like what kind of IOLs do you want to go ahead with. Okay, so what do you attribute for an ideal presbyopic IOL? So it has to give you a clear optical quality, covers you for your distance, intermediate and near, compensate for your spherical aberration, easy to implant, decrease your PCO and the rest of the stuff. So main questions will again come down which is better, hydrophilic, hydrophobic, what are the different types of IOL which is there here, and what is its advantages. Hydrophilic, basically when you have a body, it gives you a lesser inflammation, is easy to implant and no glistening. When there is a hydrophobic surface, it gives you a decreased PCO protection. So let's just dwell directly into what are the different models available right now. When you come to the multifocals right now, among all these companies here which I've highlighted, it's usually most of them have like a hydrophobic acrylic surface with the UV block one, or which we are only seeing right now is Zeiss being highlighted like having a hydrophilic and a hydrophobic surface. Coming to the trifocals, as again Zeiss here having a hydrophilic acrylic with a hydrophobic surface, the rest of the two main have again hydrophobic ones. Coming to the extended range diffractive ones, this is like again more of again hydrophobic with UV block. Again which like Zeiss 80 Lara having a hydrophilic with a hydrophobic surface. So keeping that in mind, when you're talking about mainly again like a monofocal, right now the concept is like you try to give like a something safer to presbyopia initially, like an add-on monofocals. You can talk about consider like about the Johnson and Johnson, which have like introduced their eye-hands. So this is basically like an add-on monofocals which you can use it, which gives you basically around 20 to 30% of more better of intermediate, and you need to use a little bit about like glasses for your near vision work, but you are not compromising on your quality for distance, but you are preventing them for like any this thing of multifocals or trifocals which you can think of for those patients. Basically what happens here is they slightly extend the depth of focus without behaving like the multifocals. So this basically splits the lights into multiple focal points, so which creates a smoother extended form. Coming to the next, which like right now is there, is like the CT Lucia. This which actually we are just doing a study right now about this, which we had actually think it was just like a monofocal. We have done some studies in this patient, which they are actually giving us a little bit of intermediate vision also. Basically, I think that is again because of their patented Zeiss optic concept, which they've used it, which slightly gives you an extended range of vision, and that gives you basically like an add-on monofocal effect for this. Coming to the new like non-diffractive EDOF, one is mainly you can consider as like your VVT1 Alcon from Alcon, which is based on your wave shaping X wave technology. Again, which has a modified IOL haptics to to give a good stable surface, and it's comes with preloaded versions, which gives you a better control stuff. So it basically has two smooth surfaces, like one surface which has around 1 micrometer in the center, which gives you a stretching wavefront modulation, and the second one which you can extend like your focus, which stretches and extends the light, so that preserves you a better contrast for that. Coming to next is from Biotech, which it contains a unique bond called chromophore. So this basically again is a non-diffractive extended depth of lenses. These come with again like 5 zones here. So basically what happens here is like it is gives you a continuous range of vision from distance to intermediate. It is 2.2 mm compatible, again designed for faster neural adaptation and with very minimal glares and halos. Coming to another one which you can use it like a mini monovision strategy is the Rainer EMV, which is a preloaded non-diffractive IOL, again done with Dr. Graham Barrett. So this is basically preserves your monofocal quality again by improving your intermediate range. This basically induces your positive spherical aberration, not like your rest of the other lenses which considers like the negative spherical aberration or a zero spherical aberration. The design and is basically made aspheric, as I said. The center has the controlled positive spherical aberration, and it reduces your longitudinal spherical aberration to maintain your visual acuity and decreases your dysphotopsia. The newer one, like what Dr. KP highlighted, was the Galaxy, which is again comes in your non-diffractive spiral design. So this mainly, since it has decreases your eliminates the dead zone, so decreases your focal point, so that gives you a extended range of vision here. And since like the spiral modulation of your this thing is there, so this gives you a smoother transition between the focal ranges, and it allows you to get a continuous depth of focus here. The another one which is there is like your smaller aperture from your AccuFocus, which like your camera again is like made into like an IOL, which filters out your only the 20% of light is which is allowed to get in, which gives you a better extended depth of focus into that. I have no experience in this, but this is there in the market. Coming to next, like what is there like for the femto platform, and which is there available in the EDOF and multifocal, is the femtis. This is basically again in your femto cataract platform, which you can use it, which you clip the lenses into your to the rhexis margin. So this gives you like a smooth transmedial surface transition, which gives you extended focus. So this again is like in a hydrophilic with a hydrophobic surface. It gives you a precise optical alignment into this. Coming next to the light adjustable, so this is basically what happens. Even though if some kind of a power or something is remaining, you can always ask the patient to like what they want, and you can just adjust to it. So this is what you are like coming into like the next thing what we are able to see. I'm just not going to brush upon the preloaded and all these things. Like when you're seeing into the optical performance matrix about all these things, you need to consider like bifocal will have a little moderate of your contrast and glare. The EDOFs decrease it. The non-diffractives are the ones which are preferred, which you can actually give you a better optical quality among all that. So the future is again dependent on the different shape of material which you can use to make the IOL. Again the discussion about like monofocal vision EDOFs, this is your light adjustable IOLs and the injectors. So summary wise, you need to see like which is the patient and what type you are going to use it. If it's a type B, it's better you still go with a trifocal. If it's an active reader, you still go for a trifocal, even though there is a risk of glare. If they are like more of computer user drivers for a dozen main thing, that you can still consider your like your Rainer or Biotech like a non-diffractive EDOFs. If you're already there is like a post refractive or anything, you can consider like your light adjustables or your IC8 like or your small aperture lens, which you can take. So to conclude, even though we have evolved so much, there is still like not like a proper IOL which is there, which you can give like with 100% accuracy. We still need a lot of time and to this thing. So you just need to tailor according to your visual expectation and like what the patient needs, and address the things accordingly. Sorry, I had to rush it since for the effect of time, and I thank you for your patience.
Thank you, Dr. Shamant. I think you covered most of these IOLs. I think most of us, I think most of the ophthalmologists who's practicing in India, they more depend upon the IOL-based procedure. I think I want comment over eye drops. We have got a laser-based platform and we have got a IOL platform. I think our pre-op workup and understanding the patient accommodation, also which patient is suitable for puja before we end.
So your voice is
Puja,
breaking.
unmute. No, Puja,
I think,
unmute.
sir, your
I need a yes.
So your voice is breaking. Actually, we couldn't hear what you said.
We were not able to hear the question, sir.
Yeah. Puja, I want your comments. Final
No, we couldn't
comments.
hear your
Take home
question, sir.
message.
uh, so I think I think, sir, it was a wonderful session. You planned the pre-op evaluation very well. Then the newer modality, which is the drops, also was covered. You also covered very nicely about different approaches of overview of presbyopia treatment. Then the laser-based therapies, and Dr. Shamant covered very nicely about all the IOLs available. But one point what he said, I was very, which everybody has to, again, keep in mind at the end, he said, is that there will be wonderful IOLs, the best IOLs in this world. There will be the best laser-based procedures in this world. You will have the diagnostics, the predictive modeling, AI, everything. But you still have to understand that all these are just technical tools, and none of it can match what a human eye would do, and what an optical system of a true human eye would do. So we can get probably 90 to 95% there of what we want to do with a presbyopic eye, but never 100%. So never promise your patient 100% outcomes, but always tell them that, we can do probably 90 to 95% of what you are expecting. So I think the take-home point for presbyopic patient is always the pre-op evaluation, choosing the right procedure, be it anything, and evaluation and counseling. Counseling is the key, and setting the expectations right.
Thank you, Pooja. I think we'll end this session. I thank all the panelists, even one more panelist was also Shruti, but I think I thank everybody, all the speakers, Pooja, and also Dr. Rohit to give his slides for Pooja's presentation. I think in the end is a wonderful session. Thank you all.
Thank
So
you.
before
Thank you,
we
sir.
conclude,
Yeah.
may I request all the esteemed speakers and the faculty to switch on their cameras for a quick photograph for a memory moment together.
Yeah.
Thank you so much. We'll take a few seconds for this.
Okay, if everybody is here, I'll just click the picture.
Everybody has Dr. Megha?
Got it.
Okay. Thank you, everybody. On behalf of the organizing committee, I sincerely thank everybody for an engaging session. Our chairperson, the moderators, and the program director, Dr. KP sir, and all the distinguished speakers and panelists present over here. And a special thanks to my fellow coordinator, Dr. Megha, as well, for supporting me so much. And of course, we conclude the presbyopia correction, the last frontier, and we now transit from science to celebration. So we have a midday musical extravaganza, and I
In
have
hall
great
2.
pleasure in introducing the Dr. Rolika.
In hall 2. So it
In
will be in
hall
hall 2. Yeah, not in hall 1. So those who have joined here, I have circulated the session link to Dr. Harshal Tak. So he will give you the link for hall 2 to join. And over here in hall 1 and hall 3, nothing will be going on for the midday extravaganza duration. Please go ahead and have a quick lunch along with the celebration, and we will join back. And there will be quiz after this. The quiz will start sharp on time at 3 p.m. in hall 1. So see you all there. All right. Thank you, Dr. Megha, Dr. Dipanjali, for the entire session.
Thank you, Dr. Rolika.
Thank you. Megha, help me out a little bit. I'm sending you a slide, okay? Don't log out and just display it from your system over here. Is that okay? I'm sending it to you. Megha? I think they got it already. Don't worry.
Okay, fine.
ठीक है?
Okay,
They have put it up already.
sure.
Okay, thank you, Sunil ji. Please
No
put this in the other hall as well. Thank you.
Hi, Sunil ji. Hello.
Hello.
Hey, hi, Rolika.
Yes, I'm here.
A quick question. Okay,
I'm
so
good.
we were just testing right now.
Hmm.
Kahoot में does he have to share the live version or the demo live host or
Host live.
host live?
हाँ.
Okay, fine. I think
सुनील जी आप
can
अनशेयर कर दो स्क्रीन.
Okay.
ठीक है.
I'll just ask them to join.
हाँ.
Ma'am, this is live.
Yeah, I know, I know.
This is
Everything is
okay.
live right now.
Yes, ma'am.
To share host live. Okay.
Yeah, I've
Okay.
already messaged him that you
There
click
you have.
on.
Okay, okay.
He sent a screenshot of it.
Yeah,
I
yeah,
said
yeah.
it was host live, and then he'll just share.
Because yeah, because when we were checking that host live and live and he had selected the professional version, usme actually leaderboard, that scoreboard after every question was not showing. Sir, आप change भी करके आ गए हो? ठीक है. एक मतलब okay.
I hope we are not live.
We are live.
Okay. I'm.
This is pre-quiz entertainment to people.
Okay. We are ready. Sunil ji ready?
Yeah, we are ready. I'm just waiting for Anirban to join.
Yeah, I think वो last minute he's trying to get that classic template because इसमें कुछ professional template में all our colors changed and everything. So
Okay, okay.
he should be joining. Okay, I'll just be back
Yeah.
in minutes.
Sunil ji. Sunil ji. Sunil ji.
Okay, I'm back.
Has he joined? No.
I'm just calling him up.
Achha.
Hi, Anirban.
Yeah. Should I share the screen, madam?
हाँ कर दे एक बार so that at least that first page is visible na.
Yes. My WhatsApp web has stopped working all of a sudden, ma'am. So, in case any Zoom link or something needs to be shared, could you please mail me in case
So,
future member?
so
Yeah.
Anirban, 1 second.
Yeah.
When you shared the screen, did you select share sound also?
No,
So
I did
go
not choose
back,
anything.
unshare the screen once.
Okay.
Yeah.
Right now.
Now, when you share the screen, at the bottom, there will be a
Hmm.
small tick box which will say
Yeah.
share with sound.
There is not there. It is showing share settings and remove from toolbar.
No. Click on share.
Yeah. Okay.
Now, when it asks you to select the screen, there's a small thing at the
Yes.
bottom which says, yeah, just make sure that
Got
that
it.
comes in because that music of Kahoot will not play otherwise.
Okay, fine. Okay,
Okay.
I've got it now.
Yeah. Now,
I've
share your
chosen.
screen.
Yeah, is it visible?
Are there.
Do I start?
Yeah, now you click on host live. Yeah, now you.
Okay.
Also, Anirban, please minimize your Zoom screen on the screen because it's coming as a black box. Yeah, this one.
Okay, I need to minimize this, right?
Yeah.
I have selected the video controls to be floating. So how do I change that? One sec. Okay, this is better now?
Yes, perfect.
Yeah,
Now
select
just
the classical one isme, not the professional.
I will choose the classic one. One sec. Okay, do I click on start now?
yes, perfect.
We need to tell rules. Yeah.
Yeah, let people join, then we can.
And click on that small square at the bottom right.
Small square at the bottom right. Acha,
Yeah.
this one, full screen. Yeah.
Perfect.
There is now it's gone.
Okay. So over to you, Dr. Mritika, for the quiz, and Dr. Lahani and Dr. Datta.
Thank you, Rolika. So we have a very interesting quiz lined up for all of you. We are just waiting for participants to join and then we can start. For those who are watching it, you can either just join, go online and search for Kahoot in case you don't have the app, and you can join the game using either this game pin or the QR code. Or you can also download the app and then join using the game pin and the QR code. Okay, so we have 3 people, all 3 of them seem to be from our SNPGs who joined till now. Great. So the prizes are also exciting. Okay, we have somebody called SG. And a lot of interesting animal motifs here. Nice. That is a brain wearing a scarf. Ash. Okay. So just to get you all introduced to the Kahoot format, these are MCQ questions. There'll be about 50 questions. We'll go through the rules again before we start. And remember, it's fastest finger first, but please read the options carefully before you select it. Dr. Anirban, and we have our quiz masters with us, Dr. Anirban Datta, Dr. Sumit Lahane, and me. We'll be taking you through about 50 questions. So over to you, Dr. Anirban and Dr. Sumit, just to introduce the format a little.
Okay, so am I audible?
Yes, you are Anirban.
Okay, great. So this is going to be an MCQ based quiz, and while the participants are joining up, just to go over the format of the quiz, it is going to be 50 MCQs with a single best option as your choice for choosing the answer, and there are no negative marks, so please attempt all the questions. It is a mix of questions related to recent advances in ophthalmology, some clinical knowledge, and a bit of TI as well. We hope that all of you will find it entertaining, and we will be starting the quiz in another couple of minutes. Anything you would like to add, Dr. Sumit?
No, please do tell your friends who are interested in attending, because in next 7 to 8 minutes, by 3:15 we'll start the quiz, and of course the initial advantage you will get, as all of you have joined. Those who join later may not get that advantage. So please do call, ring up your friends and ask them to join, so that we can start the show exactly at 3:15. Since we have 50 questions and only 1 hour left, we'll be running through quickly all of our questions, and of course for the exciting prizes and lot of learning as well.
For the people who have just joined, you can either download the app, or you can just go on, just search for Kahoot on Google and enter this game pin, or just scan in this QR code and participate in the quiz. Right, we have quite a lot of participants, and I can see people have joined by their own names for once. Usually there are a lot of interesting names.
There are 23 participants so far. Dr.
Okay,
Mitika, there are 23 participants so far.
Okay. So we'll wait for 2 minutes, and then you can go through the rules once again.
Okay, so we have to start. We will be going through the rules in a couple of minutes. Just to clarify, ma'am, we will be starting the quiz at 3:15, right?
Right. We'll just wait for about 2-3 minutes more. If
Right.
anybody else is joining, and then we can start off.
Sure, sure, sure.
So in the quiz, we'll be covering a lot of topics. Not everything will be the recent advances. There are some trivia questions. There are some historical questions. So I hope all of you enjoy it. Okay, Anirban, do you want to move on to the rules slide just to start
Yeah,
the quiz?
of course.
The game pin is still there at the bottom for those of you who are just joining. It's 487151. Okay, Dr.
Please
Anirban.
remember that while you're answering the questions, your speed matters as well as the accuracy. So if you know the answer and and both of you are pressing the same option, the one who is quicker will get more marks. So please be fast as well.
Okay, so as we had mentioned, there'll be 50 questions, MCQ style, and you will have 20 seconds per question. The time starts as soon as the options are visible on the screen. And the most important rule of all quiz, the quiz masters are always right. So should we start, or do you want to wait for some more time?
How many participants are we having?
I think we have more people joining in. Would you like to wait for some
Sure, we
time?
can wait. We can wait for 2-3 more minutes. If any of your friends are wanting to participate, please ask them to join soon. We'll be starting in the next 2 minutes. Irrespective of the winners, I really hope all of you enjoyed this quiz and have a good time.
So we can just start with the trial questions for now, madam.
Yeah, we can do that so that people who have joined can get used to it. Yeah, please go
Yeah.
ahead.
So this is a trial question which will be appearing on your app right now. Which of these is not a host country for the FIFA Football World Cup in 2026? The timer is going down on the left, as you can see. Great. So most of you have got it right.
So this is how it will show up, and we'll also get a real-time update about who's leading. Now, since this was a non-scoring question, this was just a trial question. So all of you are on 0 now.
And should I move to the second trial question?
Sure, go ahead.
Okay, so we have kept a second trial question just to put the new ones at ease here. If you are not used to the Kahoot format.
So I'm sure majority of you will get this right.
I had no idea about him, but he is very famous apparently. So
Okay, so we have 30 answers in, and oh, okay.
So you were wrong, madam. He is not. He, he is not that popular.
Okay.
I will just go to the leaderboard. Again, the scores are 0. Right. So these were the two trial questions. I think everyone has got the hang of how this quiz will go about. With this in mind, I will now move on to the real quiz, and I would like to hand over to Dr. Sumit for the same.
Yes. Thank you, Anirban, and thank you, Mritika. Rulika, can we start here?
Yes, sir. Please go ahead.
Yeah.
Okay.
So we'll begin.
first
The
question.
basic theme here was to update you about ophthalmology. So few of the things you may not be knowing, few of the things you know. Try to please attempt and read the questions and the option carefully, because if you read the questions carefully, you will get a lot of clues in itself. So let's start with the first question. Identify the correct combination of the pathways and the drug for the targeted therapy in a moderate to severe thyroid associated orbitopathy. So all these drugs are used for thyroid associated orbitopathy, but we want to know which is the correct combination. Tocilizumab with IL-6 inhibitor, teprotumab is anti-TGF beta, imatinib is anti-IGF-1R antibody, or basoclimab. And I think all of you answered. And okay. Not bad. 14 of you answered correctly, and we can see the leaderboard as well. Can we go to the next slide?
Yeah. Sorry.
So
Yeah,
we have
so-
Venetia leading with 932 points. And although the difference is not much, we have Ahan following her up.
Okay.
I'll go to
slide.
the next question now.
Yeah. Next slide, please, and next question.
Next slide.
So tocilizumab is a IL-6 inhibitor, which is the correct answer. Though the teprotumab, lot of you marked, is a anti-IGF-1R inhibitor. The combination was wrong. So though it is FDA approved, the answer here was tocilizumab. Let's move ahead. Second question, what is recommended dosing regimen for lotilaner in Demodex blepharitis? So lotilaner, for all of your information, is the first FDA approved drug for Demodex blepharitis. It's known to reduce your cholera and of course the infection. Hint here is if you know the life cycle, you will, okay. Most of you, almost more than 50% have answered correctly. It is twice daily for 6 weeks. Next slide, please. There is change in the leaderboard. And yeah. So basically the life cycle of the Demodex is 3 weeks. So they are trying to cover the 2 life cycle. That's why it is 6 weeks. And at present the dosing regimen is twice daily, 12 hours apart. Next question. The ZEDS trial evaluated efficacy of long-term suppressive therapy of viral agent, antiviral agent in patients with the herpes zoster ophthalmicus. Your time starts now, and you have acyclovir, famiciclovir, valcyclovir, and ganciclovir. Okay, more than 50 answers coming up. And here it is. Venetia is leading again. That's great. So ZED's trial basically was done for the zoster eye study in comparison with the placebo to check the effectivity of the valcyclovir, though the primary outcome was not met, but still they found that it helps in the long run suppression of the HZO. So that is ZED's trial for you. Next question, please. PAC-CXL, photoactivated chromophore CXL, is used as an adjunct in, and the options are post-LASIK ectasia, infectious keratitis, unresponsive to antimicrobials, Fuchs endothelial dystrophy, and recurrent corneal erosion syndrome. Okay. Almost 27 are marked correctly. It is infectious keratitis, and Venetia is leading the board again. So as all of you know, CXL is a procedure done for the progressive keratoconus. It halts the thinning. On the similar line of thinking, they had tried for the melting of cornea in cases of infectious keratitis, and they found quite useful, though it is not very commonly used, but as a adjunct to the ongoing treatment, PAC-CXL can be done in infective keratitis. Next question, please. We are here on the 5th question. Lot of pharmacology here. Which JAK inhibitor targeting JAK1 and JAK3 has shown efficacy in non-infectious uveitis in phase 2 studies? Ruxolitinib, all tongue twisters here, baricitinib, tofacitinib, upadacitinib. All are used, but use the most known one which you have heard of. Yeah, I think 34 have heard of it. Tofacitinib it is. Tofacitinib has been tried, and there is change in the leaderboard. We have Dr. RV, must be from the retina, I suppose. And yeah, tofacitinib it is, which has been tried and tested in phase 2 clinical, phase 2 trials for the treatment of the uveitis, non-infectious uveitis. Next question. Which MIGS procedure places micro-bypass stent directly into the Schlemm's canal without tissue excision? So, you know, MIGS is the new hot topic in glaucoma management, and there are various options available now. I have shown certain pictures, but we want non-tissue excision or an add-on procedure. Most of you have got it correct. Now the time matters. So it's iStent inject implantation. The rest all procedures are tissue excision. What we wanted to be directly as an add-on procedure into the Schlemm's canal. Dr. RV tops again with 4,700 points. Okay, next question. I think it does not need any explanation. Netrasudil Ropresa lowers the IOP by a mechanism that includes. This is the ROCK4 inhibitor, popularly known as netrasudil and ripasudil. It causes IOP lowering, also endothelial cell proliferation by a mechanism. Okay.
Okay.
So here the drop in percentage. And the correct answer is increasing trabecular outflow and reducing episcleral venous pressure. It is dual mechanism by which netrasudil works. And there is change in leaderboard again. Next question. So from retina to uvea to glaucoma, we are moving to orthokeratology now, which controls the myopia progression primarily by. Easy question. I would request all of you to read the options carefully, not to mark in the hurry. Correct. Almost all have got it correct. It is by altering the shape of cornea. And there are two Dr. Rias now.
But I have to tell you that the leaderboard can change anytime during the quiz. So those who are not in the scoreboard right now, don't worry. Your time will come. So
Yeah.
continue attempting the questions.
Yeah, so we believe on the principle that you stick till end and you never know, you may get loose balls to hit six upon. So please stick to the quiz till the last. Next question, please. MI Site 1 date. The first FDA cleared soft contact lens for myopia controls myopia by dash dash mechanism. So here are the options. They're quite quick answers. Okay, so more than 50% of you got it correct. It is concentric ring, create a peripheral defocus. It is like a bifocal contact lens, which has a central zone and a peripheral zone. Peripheral zone treats your peripheral defocus and it reduces myopia progression. Correct. Okay. Let's move ahead. SG has the highest answer streak. So SG is leading up, is trying to come as close as possible to the top 5. Next question, please. Luxturna for RPE65 associated retinal dystrophy uses. The picture is coming closely because there is a hint into the picture. But if you know the answer prior, try to mark it. Is it given intravitreally, intracamerally, suprachoroidally, or subretinally? Those who waited for last 3 seconds may have got it all correct. So this is giving subretinally. 23 of you got it correctly. So that is the only approved gene therapy which can be given subretinally. And if I should have added the cost of it, the one injection in one eye cost around 40 CR in Indian rupees. So for 2 injection, the cost may go to 80 CR at present. Next question, please. Which of the following statement contrast UBM and the B scan is true? So there is difference between UBM and the B scan. We want to know which is the correct difference between them. Please read it carefully. Sometimes color do speak for themselves.
Okay.
So that was a hint. The green color always is right at a time. So that is a color of choice when you don't know the answer.
Yes, the options were lengthy in this question, sir.
Yeah.
So
We
the
can.
ones who were patient would have got it correct.
And who can read fast, of course. Then. So UBM has a high frequency and very high special resolution, but a limited penetration compared to B scan. So option green was correct option. Next question, please. Question number 12. Repeated low level red light therapy is being studied mainly for myopia progression control, congenital ptosis, orbital cellulitis, or uveal melanoma. A lot about it being talked now. Yeah.
Great.
Lot have answered correctly. It's myopia progression control. And the leaderboard still Ahan is leading.
I think the option was also in red, sir. So
Yeah, so we have tried that way that they should get answers. So basically it's a 650 nanometer red light. which acts on your choroid mitochondria, and it increases the vascularity and the thickness of the choroid, basically, which helps to, this is the only therapy they say this can help to reverse your myopia, not only stop the progression. So it can actually reduce your axial, and that's what the few trials have been spoken about. Let's go to the next question. What is the primary mechanism of the vernicillin improves tear production? So this is a nasal spray used to treat dry eye. Okay, not bad. It activates the nicotinic acetylcholine receptors and hence increases the tear secretions. Okay, 4 participants have reached answer strict 3. Okay, so I think we are asking a lot of easy questions. Great. Next slide, please. I'm here on my second last question. After that, Dr. Mritika will take care. Which of the following best describes mechanism of underlying clinical efficacy of Vis-Nova in a fugue dystrophy? Vis-Nova is innovative therapy from Japan for fugue dystrophy. It's not available in India yet. Okay.
Oh,
Only 10 of you got it correct. It is
yes.
basically engraftment of the allogenic corneal endothelial cells onto the descemet membrane. So it's like doing your surgery, you do a descemetorexis, and intracamerally you just inject these cells, which are allogenic human corneal endothelial cells, and they help in the growth and they proliferate on your descemet automatically without doing any surgeries of endothelial keratoplasty. So it is still in a trial phase, but hopefully it will be commercially available. Next question, please. So this is my last question. Which of the following is a unique advantage of the light adjustable lens compared with the conventional premium IOL? So we popularly call it as a light adjustable lenses. Again, not available in India commercially, but those cases where you do expect certain changes in your IL power, you're not sure, the LAL lenses are being used in the USA. Okay. Post-operative customization of refractive outcome after cataract surgery. 40 of you got correct. That's great. And the leaderboard shows at the end of 15 questions. Ahan crossing the first person to cross 10,000 points. That's great. And the answer here is they're made up of unique biocompatible silicon matrix with the macromers. So you can actually twice thrice adjust for your monovision spherical and cylindrical power. And after 2-3 months, you basically lock it so that it doesn't change later. So wherever you expect a refractive surprise, this lenses help. So I finished my 15 questions now and I hand it over to Dr. Mritika for more difficult questions.
No, no, nothing like that. I do hope to see a change in the leaderboard though. What is the key innovation of the Glaucose epioxa procedure for keratoconus? Is it the use of rose bengal instead of riboflavin, combination of DALC and corneal cross-linking in a single procedure, and performance of CXL without epithelial debridement, or the use of femtosecond laser? Answers are coming in and time's just up. Okay, so majority of you got it right. It is the performance of corneal cross-linking for keratoconus. Can we see the leaderboard once? And it's not really changed much, but Dr. AG1 is the highest climber. And Dr. Shamika as well as Dr. Sakshi, their position has changed. So basically the advantage is that here the epithelium need not be debrided, and thereby it reduces the pain as well as the risk of infection. So you have a specific goggle that is put on during the procedure. All right, next question, please. What is the major design feature that distinguishes the Gore synthetic cornea device from Boston K-Pro. And your options are, it requires a donor corneal carrier graft for implantation, a flexible synthetic cornea that is implanted without donor corneal tissue, composed entirely of PMMA, or it functions by stimulating endogenous corneal regeneration. I think all of you got it right. It is a flexible synthetic cornea which is implanted without the need of the corneal donor tissue. And let's see the leaderboard. Okay, so Dr. Shiv has come right on top, and Dr. Raj is the highest climber, but overall the top 5 places remain the same. Dr. Priyanka is new, I think. Yeah. Okay. So,
yeah, so this is a synthetic device which you don't need a separate cornea for that. You can just simply make a lamellar pocket and put this Gore synthetic cornea into same. So that is the difference between Boston K-Pro and the Gore synthetic cornea. That's why it's gaining the popularity nowadays.
Yeah, it has not been launched in the market yet. It is not commercially available, but there are a lot of studies going on about this in the States right now.
moving on to question number 18. Vamikibart exerts its therapeutic effect in the Dovetail trial primarily through the inhibition of VEGF-A, TNF-alpha, interleukin-6, or complement factor C5. All right, so this was a difficult question. Vamikibart is an interleukin-6 inhibitor, and it is, let's see the explanation. It is injected intravitreally. And this was the Dovetail trial. It was a phase 1 trial to check for intravitreal efficacy and safety of Vamikibart for reducing non-infectious uveitis-related macular edema. All right, can you have the next question, please? Okay, now the ARMOR is a collaborative project for the development of AI model for detection and classification of which of these diseases? Adnexal and orbital tumors, melanoma, retinoblastoma, or OSSN? Well, the name really does not give a clue, so take your pick. Okay, so as you can see that this was a close one, and Dr. Shiv is still the leader here. So this is a collaborative project between LV Prasad Institute in Hyderabad and Wills Eye Hospital, Philadelphia, where they have developed and tested an AI model to detect and classify retinoblastoma from fundus images. With very high sensitivity and specificity. Question number 20, what material is used to create the ring segments in CARES procedure for keratoconus? So is it PMMA, donor corneal stromal tissue, hydrophilic acrylic implants, or porcine collagen implants?
If the candidates know the full form, it will be very easy. Yeah.
Yeah. So I think majority of you did get it right. It is the so now we have any change? No, not yet, but Shamika is climbing up and Dr. GBU is the highest climber for this question. So basically corneal allogenic intrastromal ring segments, they use allogenic donor corneal stromal tissue, and that is implanted into the intrastromal channels to flatten and basically to treat keratoconus.
Yeah, it is worth noting that this has been pioneered by Dr. Susan Jacob, and you should definitely look it up. It is one of the latest advances in keratoconus management.
Index over subfoveal choroidal. Is it independent of OCT image quality? Is it less affected by physiological variables, easier to measure manually, or exclusive to swept source OCT? All right. So yes, it is less affected by physiological variables such as the age, parameters, the refractive status, as well as the time of the day when it is measured. It is basically expressed in percentage in terms of the vascularity and the area of the choroid. So this is based on EDI-OCT. Moving on to the next question. What injury did Polish speed skater Kamila Celia suffer during the 2026 Milano Cortina Winter Olympic Games? Was it a naso-orbital ethmoidal fracture, traumatic brain injury, a corneoscleral tear, or an eyelid laceration and zygomatic fracture? So this was in news. It did spark off a lot of debate regarding the safety in Olympics. And yeah, majority of you did get it right. She did undergo a surgery for a zygomatic fracture and has a big scar on the lower lid. But fortunately, her eye was saved. And let's see the leaderboard. Okay, Shiv is leading and there's really no change, but it's just halfway through the quiz, guys. So you can still catch up. So this happened during the 1500-meter quarterfinals where there was a collision and the opposing player's blade actually struck her just below her left eyelid. And it has sparked off renewed debate regarding the safety and safety measures that should be taken, especially for cranioorbital injuries. Which drug became the first FDA-approved biologic treatment for neurotrophic keratopathy? Topical insulin, varenicline, liftegrast, or Senegermin? I think majority of you will get it. It's been in news.
Yes, it's been there for quite some time. Yeah.
Right. So 34 of you did get it right. It is Senegermin. Unfortunately, I don't think it is yet available in India. All right. Okay, Dr. Venetia is back on the leaderboard. Good. But Dr. Shiv still continues to lead. That's what, a duck Einstein on the photograph? Okay. Right. So this has been approved to target neurotrophic keratopathy. Dr. Anirban, do you want to just explain about this new
Yeah,
drug?
it is a nerve growth factor. So it is targeting the underlying pathophysiology of neurotrophic keratopathy. So it is trying to recreate the physiological milieu in the epithelium. It has given very good results, but nowadays topical insulin is being used by us in India. That is also working well.
Right.
Even though that's not FDA approved, as far as I know. Right. I will move on to the next question now.
Yes. Okay, iPrint Pro technology differs from conventional scleral lens design because it uses OCT-derived epithelial thickness mapping only. It is based on impression of the ocular surface to create a customized lens, utilizes adaptive optics to modify lens power, or it employs embedded sensors to monitor tear osmolarity. I think this is again an easy question, which majority of them should get it right. Absolutely. So this is based where you take the impression of the ocular surface to create a customized scleral lens. And okay, so we have more or less the same 5 people who are on top. Let's see, maybe the next couple of questions will change the scoreboard. All right. So mini peaks, maxi peaks, sawtooth, omega, and shark tooth are OCT features of which of these lesions? CHRPE, astrocytoma, CHRRPE, or solitary idiopathic choroiditis, or SIC. Be careful of the abbreviations.
Okay.
And yes, so majority of you did get it right. It is combined hematoma of the retina and the retinal pigment epithelium. Again, these are features which are described on EDI-OCT. Basically, it shows that the entire retina is involved in this lesion. And depending on the layers which are involved, these are the changes which are described. The mini peaks, which is only the inner retinal traction, maxi peaks and omega signs involve the entire retina. Okay. We can move on, I think. What is CART? Cancer-associated retinal toxicity, chimeric antigen receptor T cell therapy, complement inhibitors and acetylcholine receptor targets, chemotherapy, adjuvant radiotherapy. Now, there's a reason for this picture here. So hopefully you'll take the clue. Absolutely. So this is chimeric antigen receptor T cell therapy. Let's see, has there been any change in the scores? Dr. Anand is there, who's come on top in the leaderboard. 3 participants have just dropped the answer streak of 5. All right. That is a change. So anyway, so what happens in CART is that T cells are removed from the patients, and these are genetically modified to express a specific oncologic target. And then these are put back, reinfused into the patient so that these modified T cells actually attack the tumor itself. Now, this is being, there are preclinical studies going on for both retinoblastoma as well as uveal melanoma, but it is approved for certain hematogenous malignancies. And the actor of Jurassic Park, Sam Neill, recently revealed that he had good response for his lymphoma to CART. So that was the clue. ADAPT Oculus is a study which is evaluating the efficacy and safety of efgartigimod for which disease? Primary Sjogren's, thyroid-associated orbitopathy, ocular myasthenia gravis, and ocular cicatricial pemphigoid.
This is a tough one, madam.
Yeah, this is, but they're all autoimmune diseases in some form. But 23 of them actually got it right. So it is being used for ocular myasthenia gravis. So efgartigimod is FDA approved for generalized myasthenia gravis, and Oculus Adapt, that is a trial that is specifically for ocular myasthenia. This is marketed as Vyvgart or Vyvgart Hytrulo. It is an intravenous or subcutaneous injection showing good response in patients with generalized myasthenia. All right, moles scoring system for pigmented choroidal lesions. Now, we all know about moles, but what does E indicate? Is it echogenicity, which is low internal reflectivity on ultrasound, elderly age at presentation, enhancement on fluorescein angiography, or enlargement, that is documented growth? Read the options carefully. Okay, so yes, it is enlargement or documented growth. So moles was actually, all right, moles was actually developed by Dr. D'Amato and his team, and it is meant for primary ophthalmologists and non-experts to basically identify the risk of a choroidal lesion having a risk or a melanoma potential. So E here is enlargement over time, and the others are mushroom shape, orange pigment, large size, and subretinal fluid. And it is based on the clinical features. It does not use any imaging features because it's meant for the primary ophthalmologist, just to refer, not to treat. All right, this is also a tough question. Who delivered the ASOPRS Wendell Hughes lecture? Was it Jeffrey Rose, Robert Goldberg, Don Kikawa, or Frank Nessie? Now, the Wendell Hughes lecture is held every year. It is awarded to all right. So majority of you guessed it was Robert Goldberg, but it is Dr. Frank A. Nessie. And again, okay, so Dr. Ria climbed up on the leaderboard. So his topic was prioritizing the anatomy and knowledge of surgical technique and fuel innovations. So you'll probably identify him from this picture. He is the co-author of Smith and Nessie Ophthalmic Plastic and Reconstructive Surgery textbook that majority of us have read. And all the others were also previous winners. Visual 1 and Visual 2 trials established the efficacy of which biologic agent in non-infectious uveitis? Was it tocilizumab, infliximab, adalimumab, or rituximab? Mab. Okay, I think there's a black patch coming. Yeah, that's gone. Or majority of you got this right as well. It is adalimumab. And this was my final question. Dr. Anirban will now take over. Let's see the leaderboard till question number 30 now. It's really not changed much, but we have the last 20 questions, and those are, I think, the decider questions. So
Okay.
let's see if Dr. Shiv can maintain his position there. So this is a TNF-alpha inhibitor that reduces the risk of failure in patients with non-infectious intermediate posterior and panuveitis.
Right. Okay. So thank you, Dr. Mritika. I will take over now. Question number 31. A mutation in which of the following genes is responsible for congenital stromal corneal dystrophy? Now, while most of us may have never seen this condition, you can guess the correct gene if you know the others. So if you know your corneal dystrophies and the genes which are involved, you will get it right. Yes. So this is due to a mutation in the decorin gene. The TSESTD2 is implicated in lattice corneal dystrophy. CHST6 is for macular dystrophy, and TGFB1, as we all know, is for the anterior stromal dystrophies, which we are encountering. So if you could rule out the other options, you would have got this right. So Shiv is still maintaining his lead, though Mustafa and Dr. Ria are catching up. So congenital hereditary stromal dystrophy presents at birth, and it features bilateral opacification of the central stroma with whitish flakes. It's a pretty rare dystrophy. What type of intranuclear inclusion body is formed by HSV and VZV? Is it A. Lipschitz body, B. Halberstadt-Kowarzig body, C. Cowdrey type 1, or D. Smith body? Yes, the overwhelming majority is right. It's Cowdrey type 1. And these are eosinophilic intranuclear inclusions seen in cells infected with HSV or VZV viruses. They are also known as Lipschutz inclusions. Next, which of the following help to distinguish a vitelliform lesion from choroidal neovascularization due to ARMD? So how do you differentiate a vitelliform lesion versus a CNV due to ARMD? Is it A, due to diffuse, sometimes confluent yellowish deposits at a level of the RPE, B, hyperfluorescence of the vitelliform material, C, better than expected visual acuity, and D, marked blocked fluorescence? Okay, this was a close one. Right. So the correct answer is that vitelliform lesions will have better than expected visual acuity. So Shiv is maintaining his lead, and the gap has widened between him and Mustafa. Vitelliform lesions can appear large and impressive clinically, but they will have surprisingly good visual acuity. And regarding blocked fluorescence, you will see it in vitelliform lesions, not in the CNV, in the early stages. Question 34. What is the inheritance pattern for a pilot who has been diagnosed as trichinomalus on the Farnsworth D15 test? So is it A, autosomal recessive, B, autosomal dominant, C, X-linked recessive, or D, X-linked dominant? Again, a very straightforward question. Okay, So only 12 got this right. So by titanomalus, we mean anomaly in the blue spectrum of vision, of color vision. So when you have blue yellow color deficiency, this is inherited as an autosomal dominant trait, while the red green deficiencies are inherited as X-linked recessive traits. Which recently approved intravitreal agent for geographic atrophy targets complement C5? Is it A, pegcetacoplan, B, ranibizumab, avacincaptad pegol, or faricimab? Yes, most of you have got this right. So avacincaptad pegol is a C5 complement inhibitor approved for geographic atrophy, while pegcetacoplan targets C3, which is upstream in the complement cascade. Which one of the following statements about Sjogren's syndrome is true? Is it A, associated with macrophage infiltration of the lacrimal gland? Can have ANA, SSA, and SSB and autoantibodies? Topical beta blockers can improve dry eye symptoms? Or Diamox can improve dry eye symptoms? Again, as expected, most of you have got this right. The Sjogren's syndrome is a chronic autoimmune exocrinolopathy characterized by keratoconjunctivitis sicca, xerostomia, and lymphocytic infiltration, not macrophages, of exocrine glands. What portion of Descemet's membrane grows with age? Is it an anterior non-banded zone, posterior banded zone, anterior banded zone, or posterior non-banded zone? Excellent. So Shiv is really performing well here, and the gap keeps increasing between him and his followers. So Dr. Ria and Mustafa are in second and third place. So the correct answer is the posterior non-banded zone. It is secreted continuously by endothelial cells throughout life, and hence it increases in thickness with the age. So this is why the Descemet's membrane thickness increases from about 3 to 4 microns at birth to 10 to 12 microns in adulthood. All of the following have been used to assist in peeling of the internal limiting membrane except Lissamine green, indocyanine green, brilliant blue G, or triamcinolone. Yes. So 28 of you have got this right. So the majority is correct here. Lissamine green is actually a vital dye which is used on the surface of the eye for dry eye disease diagnosis. The remaining three have all been used in ILM peeling. Which of the following features would be concerning for malignancy if seen on examination of this lesion? This is the clinical photo. So, will it be overlying drusen formation, location in the mid-periphery, overlying clumps of orange pigment, or thickness of 0.5 millimeters to 1 millimeter? If you can identify the lesion, you will get the answer. Yes. So, very good. The majority has again been chosen the correct option. It's overlying clumps of orange pigment. Features suggestive of melanoma rather than nevus will include features like elevation of the lesion, width more than 10 millimeters, overlying orange pigment clumping, adjacent subretinal fluid, visual symptoms, and rapid growth. What is the ideal length of a temporal artery biopsy to optimize diagnostic yield? 1 millimeter, 3 to 6 millimeter, 10 millimeters, or 20 to 30 millimeters. A temporal artery biopsy is performed in patients when you are suspecting giant cell arteritis. Okay, so only 16 of them got this right. Riya and okay, Shiv is maintaining his lead.
10 questions
The
left
ideal,
only.
yeah, yes, sir.
Questions left only. Now they need to buck up.
Yeah, uh, I agree. The ideal length of a temporal artery biopsy to optimize diagnostic yield will be 20 to 30 millimeters. Please remember that a negative temporal artery biopsy does not rule out GCA. The rate of false negatives can be in the range of 3 to up to 9%. Okay, now moving on to some trivia. This Brazilian footballer gave his 1970 FIFA World Cup medal to ophthalmologist Dr. Roberto Moura, who treated his retinal detachment. Was it Tostão, Pele, Roberto Rivellino, or Jairzinho? So this is the invincible Brazil team which won the 1970 World Cup. They were famous for being the only team in history to win 2 World Cups back to back. Okay, so 18 of them have got this right. The majority has chosen the correct option. Tostão it is. He was operated in Houston for a retinal detachment in his left eye, and he suffered this detachment due to a traumatic injury while playing football. After treatment, he could play in the World Cup, and after he won, he was so grateful that he gave his medal to Dr. Moura. The gold standard applanation tonometer was developed in the 1950s by Goldman. He partnered with which company? Was it Hark Street, Zeiss, Leica, or Topcon? Yes. So everyone knows this one. Great. So Hark Street is a Swiss company which all of us know. X is a company. It's a giant in the ophthalmology field. So they have a drug, Lumigan, which all of us must have used at some point or the other. But they noticed that it had a peculiar side effect. The patients developed long eyelashes. They named it as Lattice and rebranded and remarketed it for a cosmetic purpose to ladies. So identify this company X. Is it Allergan, Santen, or Novartis, or FDC? Okay, so the answers are in. Yes, Allergan it is. So if you use Lumigan, you know it's manufactured by Allergan. Dr. Ria's score has increased, but Dr. Shiv seems to be firmly in control. Who published the landmark 1945 monograph, Ocular Onchocerciasis, and described the classic fundus of onchocerciasis? This is a watercolor painting of the condition which he saw while he was in Africa, and he drew this himself. And this became so famous that this painting is referred to in his name. Is it Ridley, Duke Elder, Ernst Fuchs, or Burkitt? Yeah, so only 17 of you got this right. Yeah, so it is surprise to a lot of people. We all know that Dr. Harold Ridley was the one who introduced the use of intraocular lenses, but he's also famous for his work in ocular onchocerciasis. Truly a remarkable talent. Who developed radial keratotomy, ran for president of Russia, and died in a helicopter crash in 2000? This is one man, while the achievements that this person has are equivalent to 3 people. This is actually only one individual. Yes, the majority is right here. So Dr. Fyodorov pioneered radial keratotomy, and he founded a major eye surgery network. The Fyodorov Eye Institute is still very strong in Russia. He ran in the 1996 Russian presidential election and died in a helicopter crash in 2000. Truly a remarkable life.
If you want to know more about him, Dr. Mritaka has written a very nice article on FADRO and Indian Journal of Ophthalmology.
Yes, absolutely, sir. So identify this American physician who is a Harvard-trained ophthalmologist and best-selling novelist of medical thrillers. Michael Crichton, Arthur Conan Doyle, Abraham Varghese, or Robin Cook. Okay, so 22 of you got this right. Arthur Conan Doyle was born in the 19th century. So this is Robin Cook, and a lot of us have read his thrillers, and the most famous one was Coma, which really brought him onto the world stage. Italian for beautiful woman. What toxic plant or deadly nightshade dilates pupils and is widely used in eye care? So if you know Italian, you can answer this. Even if you don't know Italian, it's pretty easily workoutable.
Last 3 questions after this, so
Yeah. Yes, as expected, everyone knew this. Shiv, so okay, we have 3 questions left. Dr. Shiv is firmly in first position, followed by Dr. Ria and Dr. Mustafa. All right. However, there are still 3 questions to go, so the leaderboard could flip around. So belladonna, was also known as Atropa belladonna, was historically used to dilate pupils for cosmetic beauty. It yields atropine, which is vital in modern clinical care, eye care. When sealing a small corneal perforation before applying a bandage contact lens, which chemical tissue adhesive is applied? So this is a slit-lamp photo of a patient with a glue BCL. So is it isoamyl to cyanoacrylate, isopropyl to methacrylate, isobutyl to cyanoacrylate, or isopentyl to carbonate? So if you have used this in your clinics, you will be knowing the answer. Oh no, most of you got this wrong. So this is isoamyl to cyanoacrylate, commonly available under the brand name Amcrylate across India. Why isoamyl is preferred over isobutyl is very interesting. You can look it up on internet. There's a very scientific reason for why we prefer isoamyl. Okay, so Shiv is in lead, but Dr. Ria and Mustafa have also maintained their positions. Shamika has come into the top 5 now. So isoamyl is a liquid monomer that polymerizes instantly upon contact with moisture on the eye. It creates a flexible and bacteriostatic seal. Approximately how many ganglion cell axons combine to form the optic nerve? Is it 1.2 million, 6 million, 10 million, or 100 million? If you have read your anatomy or you were attentive in your first year of PG, you will be knowing the answer. Yes, as expected, everyone got this right. So Shiv is now firmly in first place, and Dr. Ria and Mustafa have maintained their positions. And I think the last question is about to come.
All right. So the final question.
just a
Yes, the
second.
final question is coming in.
Just a second. Hello.
Yeah, hello.
Yeah. So after that, once we get our top 3, we need to get them identified. So
Right.
we'll
So they will send their names and contact details to either of us. We can just share
yeah,
the.
we'll display our number and they will be sending that. Okay. Let's.
Yeah, so once we get the top 3, we will be we can ask them to send their names, right? Or
Yeah.
do we have to ask Sunil ji?
No, we can ask them to send their names, phone numbers, and their email addresses to one of us.
Okay, great. So next, this will be the last question of the quiz. So Olympic runner and eye surgeon who died of radiation sarcoma from carrying unshielded radioactive plaques in his pocket. Identify him. A man who really led a remarkable life. Was it Dr. Arnold Sorsby, Dr. H.B. Stallard, Dr. Gerd Meyer Schwickerath, or Dr. Ernst Fuchs? Okay, so Dr. H.B. Stellard it is. 19 of you knew about him. And for those of you who don't, look up his Wikipedia article. You will be stunned about how much a man can achieve in one lifetime. So he was the bronze medalist in the 1500 millimeter race at the 1924 Paris Olympics. And he was a pioneer in radiation therapy for ocular tumors. Okay, so with this, we conclude the quiz. And we have the podium.
Let's have a big round of applause for them. In the third place, we have Dr. Mustafa. Second, we have Dr. Ria, and the winner, of course, is Dr. Shiv, and all three of them have been very consistent throughout the quiz. So, congratulations to all three of you. I request you all to please send in your details, your complete name, phone number, and your email ID. You can send it to Dr. Anirban. Can you just share your number, Anirban?
I've shared in the chat.
How do I?
I've shared in the
Yeah.
chat. Dr. Anirban number is 70817957009.
Yeah.
So, Dr.
Please,
Ria,
yeah.
Dr. Shiv, and Dr. Mustafa can message Dr. Anirban about your details. Many
And
yeah, please
congratulations.
send me your details, and I will be forwarding it to the relevant people in AIOS who will
in
take care
AIOS.
of the prizes.
Yeah, and congratulations to everybody who participated. I think all of you did really well. And I hope you enjoyed the quiz. We had fun
Yes.
making it. So thank you very much. I think we
Yeah.
finished on time for the next sessions to start.
Absolutely. Congratulations to all the winners, and for those who did not win, please don't lose heart. Keep taking part in these quizzes, and it was a pleasure to conduct this quiz.
Thank you very much.
It was
Yeah,
very
so
heartening to see them being so knowledgeable about such difficult topics. I wouldn't have been able to answer half the questions myself.
Yeah.
Thank you, Mritika, Anirban, and thank you, Dr. Rolika and Dr. Santosh Unawa, sir, for this platform and opportunity. It was very nice to conduct this quiz at this level. Thank you.
Thank you.
Over to you, Dr.
Absolutely.
Rolika. Yeah.
Bye-bye. Have a good
Yeah.
Sunday. Bye.
Bye.
Thank
Bye.
you, Super Quiz Masters. It was a very fun quiz. And I
Thank
knew
you.
some answers and I was like, can I participate? So no, I did not.
You should have.
No. Wouldn't be fit. Thank you so much. Thank you, everyone. And we're
Thank
headed
you.
to
Thank
our
you.
next few sessions in 15
Absolutely.
minutes.
Absolutely.
So we have 15 minutes reboot segment for the next session participants to check their slides.
Absolutely. Absolutely. Okay, right.
Yeah.
So I will be
Can
closing
you
the meeting,
unshare
right?
your screen?
Yeah, I'm stopping the sharing. Yeah.
Sure. Thank you so much.
Thank you. Thank you, Rolika.
Hi, Rolika.
Hello, ma'am. How are you?
Good. How are you? You are so busy.
No, ma'am, that's absolutely okay. We made the changes that you required, and
Thank you
I've
so much.
also
Because
made
you were
some
getting
changes
a
in
little
the.
upset about it.
Sorry, ma'am.
The the panelists, the speakers were a little upset because it's somebody else's photo. I know
Yeah,
how
ma'am, actually, the thing is that if at all the pictures were shared initially, then it becomes easy because these pictures have
confirmed
come.
later. So, and you guys just got it from somewhere, I don't know where.
Yeah,
I
because I think what they have to do is that they have stock photos, which they have to then follow.
No, but this was like she and he.
Yeah, I saw that there is a complete difference. I completely understand. Ma'am, anyways, the
It's okay.
session is live already, so this is open for you. So you can, that's what I wanted to mention. So this session is open and we can share the slides and check as per your convenience.
I don't have to, I don't have any slides because
Yes,
I'm
yes,
just
ma'am.
going to
Like
be
as soon as your
But if
panelists
somebody
join.
is here, we'll just tell
Right,
them to
ma'am.
Hi,
try
ma'am.
up.
I'll just
Hello.
be back in 2 minutes, ma'am.
Sure.
Oh, hi, Rolika.
Hi. How are you?
Yeah, ma'am, I'm well. I'm good.
Yeah, thank you for the support.
Yes, ma'am. So, ma'am, initial slides, ma'am, I will share.
1 second. I have given the updated slide deck to
Yeah.
Gunjan. I'll just send it to you also. Just give
Yes,
me
yes.
1 minute. I'm sending it to you, Dr. Rajshekhar.
क्या तो बोला एक साइड पता वास्ता वो धोइया मिट्टी दे पची जाए क्या अंदर पीछे बस You were saying something, Rajshekhar?
No, ma'am. Just the initial slides. I'll open.
Yes. Dr. Rajshekhar, now it's in your inbox. Can you please check that once?
Okay.
This is the updated one. So ignore the previous ones and have this updated session.
So, is it visible? The first slide?
Yeah.
हाँ खबर से આપણે ગયા હતા
Dr. Gunjan?
Hi,
Hi.
how are
Dr. Gunjan,
you?
I've shared the slides with
Yeah. I
yeah.
think he's sharing the recent one only. है ना?
Okay, perfect.
Thank you. You took so
Most
much of
welcome.
pains
That's
at the last
absolutely
moment.
fine. Apparently, just in this session, there were like multiple changes that we had coincidentally, but I think everything is sorted now.
Great.
Hi, is the slides visible now?
Yeah.
Yes.
Okay. This is the one that you shared me just now. This is the fourth.
Right. This is the one.
Yes.
Correct.
Okay.
Check the speakers one as well.
Dr. Ruchita, I hope the picture has reached you on WhatsApp as well.
Yes, it's correct.
Oh,
Thank you.
perfect.
Thank
Thank
you.
you so much for reaching out. Thank you.
अभी तो है ना. We have time. 4:20.
So, so Rolika, just to be on the same page, our job is I'll just introduce ma'am, Rupal ma'am, and then
Yes.
she is having everything else, like introducing rest of
Right.
the
Rupal ma'am
panel.
has yeah.
So
Rupal ma'am.
what I'll do is after he finishes introducing me, I'll introduce Dr. Tityal
Yes, ma'am.
and the
Sure.
other panelists. So first I'll tell Dr. Tityal to give his to say a few words, and then once he finishes, I can introduce the panelists, and then the speakers I can introduce as and when they are going to be talking, because just before they talk,
Perfect,
so
ma'am.
that by the time they put their slides and all, I would have finished talking. So that way we save time.
That's perfect, ma'am.
Because for each speaker, at least 3-4 lines we need to speak, right?
Perfect, ma'am.
And I was also thinking
I'll just
that for
Yes, ma'am.
each of the topics, we can have one panelist discussing rather than everybody talking about it. Then everybody gets a chance and it doesn't become.
Sure, ma'am. That's absolutely fine.
So, Ruchita, would you be comfortable for the complications of surface ablation? So discussion on that once Dr. Praveen finishes talking. Welcome, Dr. Kharitsan.
Thank you. Good afternoon, everybody.
Good afternoon. Good to see you.
Yeah, nice to be seen.
Yes.
Hi,
How come you're becoming younger every day?
Yeah, I wish. Yeah, I'm losing my hair. Yeah. Hello, everybody.
So what is your case about, Dr. Kharitsan?
Mine is actually on the liquefied ingrowth.
Okay.
Yeah. I just have 2 cases and I try to finish it within 5 minutes.
Yeah, then we can have some discussion.
Yeah.
Others have not joined, right?
Hello, ma'am.
Hi, Tulika. Welcome.
Thank you, ma'am. Thank
Good
you
to
very
see
much.
you.
Good to see you, ma'am. Good to see everyone.
So,
Right,
Tulika,
good
I
to
was
see you.
thinking you can be in the discussion about the smile complication after Raghav finishes talking.
Of course, ma'am. Of course.
So I'm trying to give one topic to each so that that person can have a nice discussion rather than all the panelists talking about the same topic. Right?
Okay, ma'am. I'm sure Raghav will cover everything.
Yeah, but you can have a little discussion after the thing.
Sure, ma'am.
It's 10 minutes, so.
And I'm sure that if I cannot answer that, you will be there to have my back.
Yeah, you won't need it. We still have 5 minutes, right?
Yes, ma'am.
No.
Hello, Dr. Pajan.
Hi.
Hello,
Hello. Welcome, Dr. Pajan.
Hello, Dr.
Am
Rupal.
I pronouncing it right? Would you, so Dr. Karitan, you want to, where is he? He's not.
So we have 5 minutes to go before we
ma'am.
start the session.
Anybody wants to check? Dr. Patrick?
Sorry, ma'am.
No, so I would like to welcome Dr. Patrick. Thank you for being here.
Hello, can you hear me okay?
Yes, very well.
Lovely
We
to see
can
you,
see the
Rupal.
lovely Sydney Opera behind you.
I hope that's okay.
It is okay.
I can use your background if you prefer.
It's okay.
All right, good.
Would anybody like to try whether the slides are working?
Let me
And
try.
right now is the time, otherwise it's okay.
Oh.
So while I'm introducing the speakers, you should try and put your slides on so that there is not much time wasted. And I'll confirm whether your slide is visible and you are audible. Then you can start.
You're not allowing multiple presenter sharing for this meeting. Oh, there we go. Something's happened. Okay, there it is. That one. What I need to do is this first.
Dr. Achal, welcome.
Hi, Rupal. How are you?
Thank you for being there, and I'm really sorry for the goof.
Sorry, I didn't hear
I'm
you.
sorry for that goof up.
Oh, the photo thing. Yes, I know. I was like, I hope they know it's me.
I don't know where they got the picture from.
I guess that's what I was trying to tell Dr. Rupal ma'am also. That I believe that these pictures are from the stock pictures that ARS has. So probably that's why there was a a goof up there. But I hope things are sorted now. We fix the pictures and
I
send
think
it
she's
over.
an ophthalmologist in India, isn't she? That other picture. So
Possibility, yeah.
yes, yeah, I've
That's
seen her
right.
before. So
Rupal, is my slide share working now?
Yes. Is it about the life expectancy? Yes. It is seen.
It's working, is it?
It is.
Okay, I'll stop sharing for now. Thank you.
Sure.
Dr. Rajshika, we can share the slide for the session now.
Yes. It's 1 minute now.
Yeah, I've shared again.
Hi, Dr. Rishi.
Hello, ma'am. How are you?
I did find the link. Dr. Raghav. Hi.
Ma'am, good evening.
Good evening. Good evening, Dr. Osama.
Hello.
The senior most person on this group. Person with the most experience. It's good to see you and good to have you on this session here with us. Thank you for joining. It's time. Should we start?
Rajshekar, Dr. Rajshekar, we can start now.
So good evening, everyone. Welcome to the 6th AIOS International Ophthalmic Conclave. I am Dr. Raj Shekhri, the session coordinator, and with me is Dr. Gunjan Buddhiraja. Together, we'll be ensuring the smooth running of the session. The title is Refractive Surgery Complications, Prevention, Management, and Redemption. For the program director and the moderator, we have none other than Dr. Rupal Shah, Madam. Our chairman is Dr. Dysphotopsia, and the panelists are Dr. Anshul Gupta, Rishi Swarup sir, Dr. Ruchita Rati, and Dr. Tulika Chauhan. And for speakers, we have Karivan, Dr. Osama, Dr. Praveen Badavali sir, Dr. Patrick, Dr. Pujan, and Dr. Raghav Malik. So over to you, ma'am.
Thank you, Dr. Rajshekar. So, good evening, everyone. Welcome to this interesting session. Is there an echo? Can we have?
It's fine now.
Yes. We are going to have a very interesting session about complications on refractive surgery. Every surgery does have its own rate of complications. With refractive surgery, there is no exception. But how to prevent, how to handle, how to recognize, we have a panel of surgeons who have been having extensive experience in refractive surgery from all across the world, sharing their experiences with us today. So let's gain from their knowledge and avoid complications. And to chair the session, we have none other than Padma Shri Dr. Jeevan Singh Tetial. He has been the first person to demonstrate the live corneal transplantation at the AO. He has been operating on many eminent personalities, including the Dalai Lama and the former PM of India, Dr. Manmohan Singh. He's been the chief of the prestigious RP Center. He's worked there and contributed immensely to the development of the center for 46 long years. And he's, of course, the current president of the AIOC. We welcome you, Dr. Jeevan Singh Tetial, and please give us a small opening remark if you are present, sir. Dr. Tetial. So once he joins, we can have the remark from him. Maybe he can conclude the session. So we also have with us a galaxy of panelists. And I would just like to throw a little light on their credentials. We have Dr. Anshul Gupta. She's a leading Adelaide-based cataract, cornea, and refractive surgeon with over 15 years of clinical experience. She's the founder and medical director of Eye Vision Laser and a fellow of both RENSCO and the World Congress of Refractive Surgery and Visual Sciences. She was notably the first surgeon to perform the Allotrex corneal inlay for presbyon correction in her area. And Dr. Gupta serves as a senior lecturer in 2 universities and holds several prestigious leadership positions. So welcome, Dr. Anshul Gupta. We also have Dr. Rishi Swarup, who is the medical director at Swarup Eye Center in Hyderabad, who has held important positions, including the chairman of scientific committee in Indian Ophthalmic Society, editorial board members for Indian Journal of Ophthalmology, and so on. He has several awards and lectures in national and international podium. In addition to being a fantastic ophthalmologist, He's a nature lover, fitness enthusiast, and an amateur photographer. So we also have from Indonesia, Dr. Rijeta Rani. She is practicing at the KMVI Clinic and National Eye Center, Surabaya, East Java, Indonesia, where she is also an instructor for phacoemulsification and corneal refractive surgery. She is head of iLink education program and organizes and conducts many ophthalmic seminars. And we have Dr. Tulika Chauhan, a senior consultant in cornea and refractive surgery at the Center for Sight Services, Dwarka, New Delhi. She has been the coordinator for the fellowship program, which is really sought after at the Center for Sight Eye Institute. She has several book chapters and publications in prestigious national and international journals and part of various clinical research and trials. I've not been able to give all the details about everybody because otherwise I would have taken up the entire, maybe not just 1 hour and 15 minutes, but 2 hours if I introduce everybody in detail. So I'm just going to give some salient features about everybody. So without much ado, I think we can go on to the first speaker, Dr. Patrick Versace, a person who is rightfully the opening batsman. He's an Australian cataract and refractive surgeon who has been involved in laser vision correction for almost 30 years plus. He's a teacher and a member of government regulatory committee over and above, working in both public and private systems. Dr. Versace's presentation today explores the use of high resolution imaging to make LASIK flap creation safer in different difficult situations. So over to you, Dr. Patrick.
Dr. Versace, you have to unmute yourself, please.
Yeah, the standard Zoom mistake. I'm unmuted, I hope.
Yep, now you are.
Thank you so much for inviting me and for the introduction. I feel very honored to be part of this panel. Let me go ahead and try and share my screen, make sure this is going to work properly.
Yeah, your screen is seen.
That's up there now?
Yes, it is.
Okay, so we start with something oblique. You know, we're outliving ourselves in the end. There's a wonderful book out called The Immortalist, which is the Tech Brothers and all the things they're doing to try and remain youthful. This guy at the bottom left, he takes plasma from his son and injects it into himself to try and stay young. What's that got to do with LASIK? Well, my talk is about avoiding LASIK complications, not creating them or dealing with them, but avoiding them in the first place. And I've seen a few patients in the last couple of months who come along like this. They had LASIK many years ago when they were myopic, and they've done really well. They got a bit older, and now they don't want to have to wear reading glasses. So we're presented with somebody who's had LASIK flaps created, typically using a microkeratome, of course, because it might be 20 years ago. They're now either emmetropic but presbyopic, or in the case of this gentleman I'm presenting, in one eye they're hyperopic with astigmatism. But importantly, they're here to see me because they don't want to have to wear reading glasses now that they're into the 50s and experiencing presbyopia. So what do you do with these people? Well, you can go and do some more laser. You could do PRK to treat the hyperopia and maybe induce some monovision. You could cut a new flap, or you could lift the existing flap. Then you've got to think about when you do laser, do you give them some monovision, or do you use one of the blended vision profiles, Presbyond or Presbymax, Read, one of these things. Alternatively, you could talk about doing a lens procedure, of course, and giving them some monovision or using an EDOF lens and decide whether to do one or both eyes. Well, to me, the attraction is when there's no cataract and they don't want me inside their eyes to do some more laser vision correction. The problem is that when you've got a microkeratome flap, what I'm demonstrating here with an MS39 high resolution image is you have this very, very shallow angle of entry to the flap. And the problem with lifting up a flap like that so that you can do some more hyperopic laser is that epithelial ingrowth is really very common. So I'm most hesitant to lift a microkeratome flap years later because of the risk of ingrowth. Okay, so maybe you say you should just do PRK and keep it really simple because you've got a nice thick cornea, no problem. And that's okay, but a lot of patients really don't want to do PRK. We know through what's published that PRK does, for hyperopia, does have an increased incidence of haze. It's at least double what you see with myopia, up to 35%. depending upon how much hyperopia you're seeking to treat. And stability of the outcome takes at least 6 months for it to be completely finished. This is not like doing myopic PRK, which is very predictable. And as a side question, it's interesting to think about why these people have more haze after hyperopic PRK. Well, it turns out that those peripheral keratocytes are more prone to turn into fibroblasts and lay down fibrous tissue, scar tissue, under the control of cytokine release. So they're more responsive to cytokines. They're more responsive to tissue growth factor beta. And at the peripheral cornea, the extracellular matrix is somewhat stiffer. And this again causes those keratocytes to be more responsive to inflammatory mediators. So the bottom line is that the peripheral keratocytes, which is where we're doing our hyperopic ablation, are more likely to result in haze and scar formation. So the attraction to me is being able to create another flap. This gives us the benefit of fast healing and really very predictable visual results. The problem, of course, is that to make a new flap in the existing flap, you've got to be very careful not to transect the original flap. So my approach now is to examine the existing flap, get a sense of how deep it is. And microkeratome flaps typically are 180 micrometers, 200 micrometers thick. But we can confirm that now with these high-resolution imaging tools that we have available to us. I'll get a sense of the diameter of the flap. And once I've got this information, I'll go ahead and program another flap using a femtosecond laser. And to do that, I'll reduce the diameter of the flap a little bit from the original flap, and I'll go to a depth of perhaps 100 micrometers, but always paying attention to the epithelium, because there's a chance it's not as regular as you'd expect. It may be thicker than you'd expect because of the previous laser vision correction surgery. Importantly, once I've created the flap with the femtosecond laser, in my case, the Schwind ATOS, I won't lift that flap. I take the patient back to the MS-39, repeat the scan, and then I can examine their eye, and I can examine the new flap, and I can convince myself that the new flap does not transcend or transect the original flap, so that I can then safely go ahead and lift that flap gently, but knowing that I'm not going to get a little loose bit of tissue which can result in a very irregular cornea. So I think that making a flap within a flap becomes a relatively predictable, I'm not going to say safe, but predictable thing to do as long as you take care. And here I'm using a high mag view here to confirm that my new flap is around 102 micrometers thick. The original flap was 220 micrometers, so I do have good clearance and plenty of room to do my hyperopic ablation. So that is what I will do now for these people who come forward with a bit of hyperopia or wanting treatment for presbyopia. I'll typically do a Presbymax treatment, so it's only one eye normally, and I'll induce a bit of spherical aberration depending upon what happened with the original surgery, and give them a monovision treatment. Now, this idea of using the high-resolution imaging can be used for other situations. For example, if you have some problem during calyx, lenticule surgery, you can verify the integrity of your lenticule by doing an MS-39 before you try and dissect and remove your lenticule. Here's an example of a case where we had a suction break at some point during the posterior cut. And we weren't 100% sure at what point we lost suction. So before I do anything else, I take the patient to the MS-39, do the scan. I can now look and I can see the flap of the interface that I've created, and I can measure the diameter of it. I know that it's complete, so I can go ahead, redock, and do the anterior cut. So that's just a very simple presentation to talk about how I avoid a complication with a flap within a flap, specifically in the context of wanting to do a hyperopic ablation because of presbyopia and the desire to give monovision vision. So for discussion, is PRK okay? Am I being a bit overcautious? LASIK or a lens, which is better? What do you think about flap within a flap? And then just in general, the use of high-resolution imaging as part of our surgery when we're doing flaps or lenticules, because there are situations where it's going to add value. Appreciate your listening to me and very welcome to have a discussion and answer any questions. Thank you.
Thank you, Dr. Patrick, for such an interesting start of the session. If there are any questions for him from the panel? Or some
I have a question for Dr. Patrick, Dr. Rupal. May I?
Sure. Can you please stop sharing the screen, Dr. Patrick.
Yes, I'll stop sharing. If I can find the right button. Here we go.
Please go ahead with your question.
Hi, Dr. Patrick. Very nice presentation. Yes. So in the case that you showed in the end, it was a hyperopia, which you were trying to do a retreatment with taking a slightly smaller diameter femtosecond flap at a deeper depth, correct? Now,
No, I was
the
doing a
challenge in
femtosecond. No, I was making a flap at a shallower depth. So it was a flap within a flap.
What about the diameter? Diameter was also smaller, isn't it, than the
Yes,
original?
I reduced it slightly because I don't want my new flap to go over the entry wounds of the original flap, the flap edge. I want it to be within the flap completely.
Yes. So the 2 points I'd like to make. One is when you're trying to do a hyperopic ablation, sometimes your flap diameter becomes a bit of a challenge, especially if your original flap has not been very big. Second thing is there's been a nice article by Dr. Sonia Yu describing side cut only approach for enhancements, in which she would just do the side cut and relift the flap, and then you could just ablate there instead of making a flap completely, and that would possibly be good for especially those where you don't have enough working space to make a flap within a flap, and that may be another alternative approach.
And I think that's a great approach. I think my only consideration with that would be to be sure to have a look at the original flap, because they can be surprisingly thin at some points when they're cut with a keratome. But yes, that's a good technique.
But I agree with you, Dr. Rishi. And probably it would be a good idea to have the new flap incorporating the old one completely in the new flap, rather than going more superficially, because otherwise we'll be sometimes left with wedges on the sides, which can sometimes be ablated or create an irregularity. Also, would you like to do an ASOCT before doing a flap cut like that, so that you know exactly where you are and maybe plan your next surgery accordingly? Anybody else has any comment, any suggestions, any questions?
Ma'am, I just want to ask one thing. Suppose if we do not have, like MS39 is an amazing instrument, but suppose if we do not have such high resolution OCT, then it's very tough for us to assess the thickness of old flap and where we are going to maneuver, right? So in such cases, what Dr. Swaroop has said would work better for us in this scenario. So where we can have MS39 and see where we are going, where the plane is, then it is wonderful to do this technique. It's amazing. Thank you.
So shall we go on to the next one? And that's complications in the new technique, the blue-eyed boy that is there right now, again for use for us, which is the CLEX. It was initially only in the form of SMILE, but now since we have so many other platforms which has joined the bandwagon, I think there are also oops moments which are going to be there with each platform. And we have really a guy who has experience with at least 2 of those 4 platforms, Dr. Raghav Malik, a senior consultant at Center for Sight. He has trained a number of doctors in phacoemulsification and refractive surgery, but to his credit, he has been the co-investigator in the 3 first-in-man clinical trials of the ELITA platform. So he has been the pioneer in silk technique. He has multiple publications in Index Journal and has been the chief instructor for 3 years in a row of the well-attended IC at the ISRS about the debates in refractive surgery. I'm surprised that you are quiet right now and not having any debates. He was awarded travel grant and was also given the best paper of the session at the APSCRS in Seoul 22. So Raghav, please throw some light about complications in a procedure where we are not really expecting too many complications to occur.
Thank you so much, ma'am. As Dr. Patrick also very rightly said, and he also said that if there are surgeries, there are going to be complications. So I will be speaking about complications in calyx on a whole, but I will be showcasing mostly SMILE and some cases of silk. So we at Center for Side have been the pioneers both for Smile as well as Silk. We have Dr. Rupal who is considered the queen of Smile, and we also did pioneering work in the Elita. So I'm going to just start my presentation. So basically, we all know that any calyx surgery, that is, be it Elita, be it Smile, be it a Smart Sight, it has four basic cuts. That is one posterior cut, one anterior cut, one side cut, and one main cut. If there is any issue in making these cuts, we are going to have complications. So some points we have to consider is that we have to treat ocular surface (MGDs) prior to the procedure, because if we have secretions, we can have those cold and dark spots, letting us have difficulty in dissection. We take care not to overexpose the cornea, or we can have exposure keratopathy before the procedure, leading to again black spots. Then the conjunctiva and the conjunctiva should be dry and the cornea should be moist. There should not be pooling of any fluid on the cornea. And finding the planes is the most important part of the procedure. Now, there have been a number of signs that have been shown in publication that do tell us how we find the anterior and the posterior plane, which is the most important part of the procedure, especially for surgeons who are just starting the procedure. So there is the meniscus sign, there is the white ring sign, and the stop sign that basically tell us how to find the anterior from the posterior plane. Once the planes are found, most of the procedure is pretty easy. Then, of course, we do have the ASOCT guided procedure also, where we can use the ASOCT to just find and delineate the plane. So there is a case where using the ASOCT, this is the ELITA platform. Once the lenticule is formed, and once you take your dissector inside the cornea, you can pretty well see. Now you see at this point, I'll just pause my video for a second. Yes, you can see, yes, we are in the wrong plane. So this is the lenticule and this is where our instrument is. So our instrument is gone behind the lenticule. We want to do the anterior plane first and then the posterior plane. But this goes to show how the ASOCT can be a useful tool for us to delineate the planes. Then coming on to the most dreaded part, that is suction loss. Now, suction loss can happen at various points. I'm going to talk about Smile because we've had a greater experience with Smile over the past decade. So suction loss can happen at multiple points. If the suction loss happens in less than 10% of the posterior cut, we can always restart. If it happens in more than 10% of the posterior cut, we can convert to a femtosecond LASIK flap, but increase the flap diameter. If it happens during the lenticule side cut, you can repeat the side cut, but decrease the lenticule diameter by about 0.2 to 0.3 millimeters. If it happens during the cap cut, repeat the cap cut. And during a side cut, you can always repeat the side cut. We have used manual techniques also. And ultimately, you can always do a circle scan after a suction loss. So you can just remove the lenticule like a relax. Now, this is a case where there was a suction loss in the posterior plane. This is Smile, of course. You see there's a posterior. Now, this is more than 10%. So in this case, you can go ahead and make a femtolaser flap and just lift the flap and do an excimer. Now, this is a case where there was a suction loss during the side cut. The posterior plane has been made, and then immediately after that, you can see this pooling of fluid showing us that a suction loss is impending. And just as the side cut is being made, there is suction loss. And we don't have the anterior laser starting at all. So we can always redock. We use the centration, the infrared, to find the center of the pupil, and we can always redock and make another lenticule, but we should decrease the size of the lenticule. Now, coming on to suction loss during the anterior cut. So in this case, we'll see that the posterior plane is made completely, and we also have the laser firing on the side cut. But we can see there's an impending suction loss, and then the anterior cut starts, and we see that the suction loss is about to happen, and there it goes. The laser stops. So in such a case, you can always redock. We have to use the infrared light and find the plane, and then make the anterior cut again. And the side cut. The rest of the procedure is pretty easy, again going and entering into the main incision and finding the anterior and the posterior plane. And once the planes are found, you can always go in and remove the lenticule. You can see how even after so much manipulation, the section is pretty smooth. There isn't much difficulty. The lenticule is removed in toto. Always go ahead and check the lenticule. The lenticule is completely removed. Now, this is a suction loss during an entry cut. You can see that the posterior cut is made. And the anterior cut, after it's being fired, we see that there is a suction loss. We can always redock, and we do have the option of just firing the entry cut. There you go. The anterior entry cut is made, and then we can always go ahead and just complete the procedure pretty easily. The anterior is removed. Now we can always do a circle scan also. This is when you see we are making the anterior plane, and during the main cut there is suction loss. So the main cut is not made. So in this case, we did go ahead and try to open the main wound. We could not. We used a blade also to find the entry, but it was a bit difficult. And looking at the situation, we did go ahead and make a circle scan. You can see this is the entry that we were trying to make. And once the circle scan is made, you can go ahead and lift the flap. We should bear in mind that the lenticule is already made. So we are trying to separate the lenticule also. Kind of doing maybe like the first generation of a smile where we made a flap and then removed the lenticule. The lenticule is stuck. It does require some dissection, and once it is done, you can see the lenticule can be peeled off pretty easily, and then the flap is put back. So this is a case where there was an eyelash while the lenticule was firing. You can see there's something, it's an eyelash, but again, the surgeon did go ahead and fire the laser. We have to understand now that the cold spot is going to be in both the planes, the posterior as well as anterior. In such a case, the idea is to slowly try and decrease the size of the cold spot. So you should imagine the cold spot to be an island. Try and encroach on the island and try and decrease the real estate, or try and decrease the area of the cold spot. And very slowly we are able to go ahead and kind of remove the lenticule. So there can be a remnant fragment. This was a case that came to us where the patient had a remnant refraction about a -2 cylinder after the procedure, and a remnant fragment can be seen and can be removed. We need to check the lenticule in toto, and you can see that if there is a missing piece of lenticule, we can go ahead and try and remove the lenticule as much as possible. We can always go ahead and irrigate the interface. You're going to swell that small area, and we can remove that piece of lenticule. We can do ASOCT also to find any remnant lenticules. And they also have the circle software. We can convert the lenticule into a flap and remove that remnant lenticle also. I just have a couple of quick cases where I want to show you how we have complications in Elita. This is just before the laser fired. This is the right eye and the left eye. It looks good. But immediately after the laser fired, we can see the right eye is good, but the left eye, there were two planes that were created because the patient had moved under suction. The Elita does not have a live show, so we do not know whether the eye is moving or not. And after the laser has been fired, we can immediately wait for the OBL to disappear and do a surface ablation. And the patient did very well. This is another case where another surgeon had done a silk, and the patient came to us with dissatisfied vision in the right eye, vision of 6/12 part. And when we looked at the patient, we could see that there was a decentered ablation showing that the main wound was just at the pupillary margin. And a pentacam showed kind of a topographic change showing a very uneven flattening and steepening. Did an ASOCT, there was a remnant lenticule. And this is again the pentacam, and on the we have the Spindamaris 1050 RS. We did use a two-step procedure just to manage this case. You can see how we can see topographic change and change in the epithelium map also. So what we did was that this is the preoperative patient, and then this is the ablation profile where we are doing a small trek, that is the topo-guided regularization of epithelium, where only a 20 micron flattening is done so that we can regularize the cornea. And once the cornea is regularized, we go ahead and do a topo-guided PRK. This is how the cornea was before the trek, and this is how the patient was after the trek. So we can see that the cornea was regularized. This was the refraction after the surgery, and this was done with the topo-guided surface ablation. Just to conclude that the evolution of surgery is heading towards more preservation of corneal biomechanics. That is a different discussion altogether, but CLEX is where we are at now, and lenticle procedures take us one step closer to that quest of getting as biomechanically stable as possible. A few tips and tricks make the procedure easier and flatten the learning curve. And the MS integrated ASOCT is also hitting the mark by giving us the anterior and the posterior plates. Thank you.
Thank you, Dr. Raghav, and thanks for sticking to the time. and still elaborating all the possible complications. I see that most of the complication that you showed was related to the suction loss,
Yes,
and
ma'am.
that is easily avoidable now by the faster lasers, which take much less time. And I think once the initial learning curve is tackled, then the procedure can go much smoother. Also, if you find that there is something which is there in the interface, or something between the contact glass and your cornea, like the hair that you showed, it's a good idea to just stop and remove the offending agent from there before actually completing the procedure. I think rather than taking that chance of being able to dissect, because not everybody is as good a surgeon as you are, I think it's better that you stop and redock rather than, maybe you would be using one more license, but it's still a good idea to
Agreed.
just
In hindsight, definitely,
go
yes.
ahead and not do that. Dr. Osama, you have any comment, any suggestion?
Yes. Actually, I have a question for Dr. Malik about the case of silk that you presented. We often see cases of this. Actually, this is an incomplete lenticule.
Yes.
So why didn't you try to find the remnants of the lenticule first before you convert it into a topo-guided treatment? Have you tried that?
Okay, so this was a patient. This was a case that was done about 6 months prior. So the patient came to us. The patient was lost to follow-up. It was done by one of our colleagues, and the patient came to us. The patient had a vision that was not improving beyond 6/12 part. And when we did look at the slit lamp, so we could see a decentered ablation, decentered lenticule, and it was an uncut area. We could not find that lenticule piece. Only on doing the ASOCT could we see that there was an uncut area of lenticule, which was also shown by the topography. That's when we decided to go ahead, regularize the topography first, and then do a topo-guided PRK.
Okay, but
Did
in
you
case you know
consider converting
what
it to a
actually
flap?
happened, if it
Raghav, did you consider converting it to a flap? Because you can.
Yes, that we could have, and we could have done again a topo-guided LASIK because this was an uncut lenticule. It was not a case of lenticule that was not, that was left in situ. This was a
I think
totally
it was uncut and the rest of it was ripped around it. That would
Yes.
be
Yes.
highly
It's difficult. It's difficult to say because the case was not done by us, so we did not know what the history was. But looking at the lenticule and looking at the retroillumination photographs, there was nothing to suggest that there is a lenticule in situ. But looking at the topography is how we can backtrack and figure out that there was an uncut area or a cold spot there.
I would
It is
like to add
possible.
something
It is
here.
possible because there may have been something.
Dr.
in the-
Tulika also saw this patient. She
Yeah,
could
Dr.
quickly,
Tulika, please.
chip in.
Yeah, so I would like to add something here. If we see those photographs, we know that there was highly decentered clefts. So it is artificially decentered the apex of the cornea. And when we see there is uncut area, as Raghav said, there is no retained lenticule as we see there. So what we did by topo-guided TCAT, we tried to center the apex first. And then the patient was only improving to 6/6 with a contact lens. By glasses, I think she was 6/36 and she was not improving more than that. It is because of decentered and we totally disturbed the anatomy of the cornea and the physiology of the cornea by decentered cleft. So first of all, the main motto was to center the apex of the cornea and then decide whatever the remnant refractive error is and how to correct it. So patient underwent 3 procedure. Now she's 6/6 under follow-up. So yeah, we do not find any retained like tag inside there, which was also clear from the OCTs. Yeah.
And did you use any special precaution to do this topo-guided PRK on her?
Ma'am, I did first,
MS.
I did I did TCAT in this patient. And because of the AI system and all, we did the best possible thing what we can do with this is Schwinn platform. And then I waited for almost 9 months for this patient. Then she was improving to 6/6 with the glasses. And when for 6 months, the refraction was totally stable, not even the astigmatic axis is also changing, then we decided to go ahead because she's a young girl of 22. So the only thing which I was very, strict about is the stable refraction and the astigmatism should be stable with no change of axis for 6 months at least. But anyways, we did the surgery after 9 months of TCAT. So yeah, she was always stable and when she was 6x6 on the glass plane, then I did the surgery.
Very nicely done. For the want of time, we'll just move on and then we can have some more discussion if time permits at the end of the session. So please hold your guns. So we have next a very prolific surgeon, a renowned ophthalmologist working at the prestigious L.V. Prasad Eye Institute in Hyderabad, Dr. Praveen K. Vadavali. He wears many hats. He is the director of Shantilal Sangvi Cornea Institute. He is the director of Institute of Excellence. He is the director of Technical and Communication, head of Refractive Surgery. And he is also the founding member of the Cornea Society of India. He has over 130 publications and over 600 presentations done both nationally as well as internationally. And he's, as I'm telling you, wearing many hats. So today he is also right now the moderator in another session and is a speaker here. So welcome, Dr. Praveen. He'll be talking about complications of PRK. I am surprised that he agreed to talk about this because surface ablation is very dear to him. And I thought that you would feel that there are not really many complications with surface ablation. Dr. Praveen.
Thank you. Thank you very much, Rupal, and thank you for having me on this session. I think one of the ways to speak about complications is to also showcase how rare they are. So I think that is the reason why I like to speak about PRK complications, but also thank you for the kind introduction. So what I'll do in the next maybe 8 to 10 minutes or so is to talk primarily about PRK and corneal haze, because if you list all the complications of PRK in the early, intermediate, and the late postoperative phases, most of the early complications are related to acute causes like poor healing of the epithelium and potentially infiltrates in the cornea. Midterm complications, what most people are worried about is corneal haze. And in the long term, corneal haze is probably the one that worries most people as well. So in effect, most complications of PRK are not related to surgeon error. And that is why it's such a great procedure when you have a large group of people who practice in an organization who do refractive surgery. It probably has the least complication rates, especially if you have good systems and processes. The wound healing in PRK probably is the one part of surgery that is probably not as well controlled as the rest of the surgical technique. And in the early post-op period, the fact that you have an epithelial defect, the fact that you ablate the Bowmans, and also the fact that you have a lot of inflammatory mediators in play. The acute inflammatory phase in the first week after surgery, where you have apoptosis and release of cytokines, and then the stromal remodeling phase, all of these have an influence on the frequency as well as the severity of haze. Haze, again, is of two primary variants. You have the early or the transient haze, which is extremely seen in most patients who have PRK and tends to occur at the first to the third month after surgery. And this is something that you will see in most patients after PRK. But like I said earlier, this is transient and tends to fade with time. What really worries a refractive surgeon is a late or the persistent haze. And the late persistent haze, as you can see on the picture on the right side, has some very characteristic features. The fact that it is stippled, the fact that it appears as if there is scar tissue, and the fact that it appears as if there are gaps or clear areas of the cornea in between is what characterizes it. And it should be distinguished from the scars that can occur in some cases because of secondary complications in PRK. But the distinguishing features of post-PRK haze are the fact that it is granular or stippled and is always limited to the optic zone. So it's also important to understand the area of ablation the optic zone, as well as the kind of ablation, if there was a significant astigmatic correction as well in the PRK. So in OCT, it's very remarkable to see the kind of pattern that post-PRK haze assumes. The typical sawtooth kind of pattern, subepithelial haze that is smoothened by the epithelium on the right side is the typical pattern, whereas scar tissue, again, does not have any particular characteristics, but it tends to occur in the area where there is inflammation in the eye. So a few questions about haze. Number one, why does haze occur? Haze, like I said earlier, occurs because of the tissue healing response following PRK. Two primary events. The early event is the apoptosis that occurs immediately following laser ablation and removal of the epithelium. And then later on, there is mitosis and transformation, or at least the beginning of transformation of some of the keratocytes that are left behind to myofibroblast cells. So typically, there are five factors or five partners in the development of haze. One is the laser itself. The second part is the anterior keratocytes that commit suicide or apoptosis and they die out. And then the migrating epithelial cells, which eventually seal the epithelial defect over a layer of fibronectin. And then you have the new epithelial cells that come in from the periphery, the limbal stem cells, and close the epithelial defect. And then you have the remaining keratocytes that become activated and then secrete a new matrix. So we have ways in which you can prevent haze by using mitomycin C to reduce the conversion of keratocytes into myofibroblastic cells, and steroids that also occurs over a long time that reduces the activity of these transformed keratocytes. How common is haze? Not very common. Most mild or early haze, like we discussed earlier, peaks at 2 months. Severe haze usually is apparent after 6 months after surgery, and that's when you need to worry about haze. Any factors that determine haze? High myopia, well known, above 6 diopters tends to have a 100% increase in the chance of haze compared to a low or moderate myopia. But even this percentage is relatively low. It's apparent that above 6 diopters, about 2% of patients develop haze. Low to moderate myopia, it's about 1% or so. Astigmatism, especially higher corrections above 3 diopters, tends to have a higher percentage of patients who develop haze, especially in the peripheral cornea. Depends on where your laser ablates on the cornea, but it does have a higher prevalence of haze. How do you prevent haze? The most established as well as accepted method to prevent haze has been mitomycin C. Mitomycin C has been used ever since Parag Majumdar reported its use more than 20 years ago, and has been in the prevention of haze after PRK. Interestingly, the percentage of mitomycin C, whether it's 0.02 or 0.002, seems to be equally effective in reducing the onset of post-PRK haze. And there have been some reported alternatives as well, including fluorouracil, ceramide, as well in preventing haze, but nothing has been adopted worldwide at scale like how mitomycin C has been adopted. Another important aspect of ensuring that haze is reduced is post-op steroid regimes, and post-op steroid regimes are extremely important along with protection from UV. And it seems as if the first 6 months are where you can modify the onset of haze. Mild to moderate myopia, typically we use steroids for around 3 months. Higher myopias, we tend to use steroids for around 6 months or so. Haze affects the vision, tends to increase the higher order aberrations and reduce contrast sensitivity, in addition to reducing the best corrected visual acuity. What has been our experience with haze? We have so slowly transitioned as an institute to do about 70% of our refractive surgeries are now PRK as compared to LASIK or SMILE. And when we started analyzing data from these patients, we right now have a cohort of around 20,000 patients who undergone PRK. Reported here is about 10,000 patients, and the distribution of refractive error in our patients has been quite wide. So we also have a significant number of patients who have high myopia, more than 9 diopters who've undergone refractive surgery and PRK as well. Comparing the outcomes of those patients who've had PRK above 9 diopters, which is the top panel, with people who have had PRK, which is the bottom panel, and comparing the visual outcomes, it seems as if the lower myopia obviously have better visual outcomes, more precise corrections, but the higher myopes, with 93% of them being within plus minus 1 diopter of correction, also have very promising outcomes. And these are comparable to any kind of refractive surgery that is done for myopes in that range as well. About haze, it is obvious that the ones who have higher refractive errors, the panels on the right side, at each time point tend to have more significant haze as compared to those who have lower myopia. But in all categories, the haze tends to be transient and the haze tends to come down quite significantly at the 12-month time point. So of the number of cases that we analyzed between 2016 and 2020, we did about 4,000 PIs during this period. And during this period, only 21 of those 14,000 required repeat surgery. And that is about 0.15%. So it's an extremely low number of patients who require repeat surgery. But what is even more telling is the fact that of these patients who required repeat surgery, about a fourth required surgery because of undercorrection, about a fourth because of overcorrection, and about a fourth because of residual refractive error. Only 1/4 of these patients required surgery because of haze as a repeat surgery. So that's a haze that requires surgery of 0.04%. So it's extremely, extremely rare to require a repeat surgery for somebody who has haze after PRK. What is also interesting is the higher the refractive error, including the astigmatism, the time to recovery of visual acuity, also because of transient haze in the initial period, tended to be a little longer. How do you treat haze once you have haze? The most effective method has been to repeat the PRK as a PTK. And this is a patient who had quite severe post-PRK haze. With PTK for the patient, expose the eye to 0.02% mitomycin C for 2 minutes as compared to the original protocol. Though this is immediate post-operative, the majority of patients will have resolution of haze with this method. And to sort of summarize the onset and development of post-PRK haze, most early onset haze is transient, and what is important is to continue using topical low-dose steroids. Late onset haze that causes refractive errors as well as diminution of vision that requires surgery is usually quite rare. But it is important to remember that it is easier to prevent haze than to treat haze. Once it develops, it is much more difficult to get rid of. So it's easier to ensure that your patients are adhering to a protocol, using steroids and protecting themselves from UV. Mitomycin C during surgery and steroid use for 6 months after surgery is very effective in reducing the onset of haze. And PTK, if you have haze, is a very good option in treating haze. There is only one case in which even after PTK, we had recurrent haze, and we eventually had to do an FALK for this patient to prevent haze. And eventually this patient underwent an ICL for his high myopia, and now he seems to be quite stable. So thank you very much for your attention, and hopefully, even in a talk that talks about complications after PRK, been able to sort of share the fact that it is not such a big deal.
Thank you, Dr. Praveen. This was what was expected. You really gave a good overview and put it correctly in its perspective. So surface ablation is here to stay. It's not going away anywhere. Even with many more additions that we are having in terms of options for doing refractive surgery, it still remains a good addition to your armamentarium. I think that's what we should be concluding from this. Would you suggest any newer ways, like do you think that vitamin D has any role to play, or curcumin, as people are saying, to prevent haze?
I mean, when it comes to vitamin D, I think 95% plus of our population is deficient in vitamin D anyways. So vitamin D appears like the obvious culprit, and there is some molecular evidence that it might be useful. So I think it is a good idea to give vitamin D and calcium supplements for overall health, but it may not have too much of an impact on prevention of corneal haze. I think what has been most effective is rigorous counseling and ensure that people follow up and adhere to their regime of medications. And there has been extremely compelling evidence to show that you don't have haze that is insurmountable if you follow this protocol.
Thank you very
Another
much.
thing that
Dr.
I find
Rucheta.
useful, especially in Australia where we have a lot of sun, is really counseling them about UV exposure, and making sure that they understand that it's not just for the first week. It's like, for 3 months, to really, really, really particular about their UV exposure and wearing sunglasses. The other thing I was going to ask you is if you've had experience with losartan, which has become fairly topical in this sort of context. And can be useful certainly for the milder cases, but I don't know if you've used that and found it useful.
Is
No,
it available?
It's difficult to get. Now, a couple of companies do make it for us. They do make it, but it's not available readily. You have to. So all the medications they do come in a powder form. So they do make eye drops for you, but you have to reach out to a couple of. I think Mankind does, and there's one more that they do make losartan drops. They do help.
Yeah, we have to have it compounded here as well in Australia, so I don't think it's sort of commercially. There's a brand
Not
that
yet.
you can
Not yet.
but yeah.
Yeah, we compound in our
Yeah.
pharmacy, but we have used it in corneal scars, but not in haze. And again, I believe that haze is easier prevented than treated. So,
For sure. Yeah, for sure.
Dr. Praveen, if somebody has a keloidal tendency, do you think it has any direct implication in terms of greater chance of haze?
I think keloids have been probably given a bad rap with time because keloids do tend to be very variegated. You do have it's very difficult for people to answer a question if you have a keloid tendency and ask to see a scar. And the worst haze that we've seen has not been people who have had keloids. I don't think it really independent risk factor, and it is not a protective factor either.
Thank you very much.
Point. I've seen some really bad late onset haze, which actually just disappeared by using long-term steroids, So it's not a bad idea when you see a bad haze to actually give a trial of long steroid use. And you may not even need to do a PTK in many of these patients.
Agree.
Yeah. Sure. So we move on. Thank you, Dr. Praveen. It was really interesting. So we have next some case discussions, and we will have the first case discussion by Professor Osama Ibrahim. He has been professor from Alexandria University, Egypt. He's been a mentor for hundreds of ophthalmologists. He's a pioneer in the SMILE technology, which was where I had the opportunity to find him as a friend. Above all, I know him as a humble, helpful, generous, and knowledgeable person to have as an asset in your life. So, Dr. Osama Ibrahim, please. Dr. Osama.
You're on mute. Mute, Osama.
Dr. Osama, please.
Yeah. Thank you, Rupal, and thank you all the organizers of the All Indian Ophthalmology Society for their invitation. I'm really honored to be among this distinguished group of surgeons and refractive surgeons. I learned a lot, and I would like to thank Rupal, my mentor, the one who taught me how to do SMILE at that time. I'm trying to get, I don't know why it's not giving me the option to share. Can somebody help me there, or?
So are you using a screen on phone or are you using a laptop?
A laptop.
So there would be a green sign of share where you can
Yes, I
click
pressed
on.
it and it gives me three options to share the entire screen,
Yeah.
but it's not.
Yes. Yeah. Just share the entire screen and open your presentation
Yeah,
first.
okay. It's open now. It's open, the presentation, but it's not highlighted, the share. The share button is not highlighted.
Please go back on the Zoom platform and then again share your screen if your presentation is open.
Yeah, I'm doing all this, but the share button is not highlighted. I don't know why. The window, entire screen. It's not, I don't know which.
Maybe what we can do is go on to the next one. And in the
Yes,
meantime,
yes.
maybe email it to one of us so we can play it from our way.
No, it
Yeah.
is.
Should be working, I don't know.
You want to try once more? Till I'm introducing Dr. Karidzan, maybe you can try once more. Because Dr. Karidzan's introduction is quite long.
Strange.
Sorry, Dropper, would you like me to go first or?
Yes, I think it is better that
Okay,
you.
I'll just go first, yeah.
Yes, please.
Okay, Osama. We will give you the time. Don't worry about it. Okay, things happen. Thank you, everybody. Thank you, Dr. Rupal.
Can I just introduce you in few
Oh,
words,
okay.
Dr.
Sorry.
Karidzan?
I
I
thought.
know that your presentation itself will speak about you, but he's associate professor in Department of Ophthalmology in the Faculty of Medicine, International Islamic University of Malaysia. He's also the present director of Cornea External Disease and Refractive Surgery Services at IIUM Eye Specialist Clinic, Kuantan. He spent a year as an adjunct corneal clinical instructor and international fellow at the UCLA in 2008. He has a number of publications, number of presentations. He has a great sense of humor and a person with deep knowledge about his subject. Please go ahead, Dr. Karidzan.
Okay, thank you so much, Dr. Rupal, for that. Again, thank you for the organizer to actually allow me to share some of my cases over here in this particular session. It will be like a 5 minutes presentation. It's actually a straightforward things. Let me just start on this presentation. So basically, I would like to share two cases that actually come in and are presented as a late liquefied epithelial ingrowth in LVC. So the first case is a 26-year-old female, had a femtolasic done. We last actually follow up with her at 6 months. At that particular time, we detected that she has the epithelial ingrowth near the paracentral. The vision is still good, 6.6 OU, both eyes, and 5. There's no history of trauma, infection, DLK, nothing to do with that. There's no clear origin of this ingrowth, but it was not detected prior to that, only at 6 months. So you have this, that's looking like a typical epithelial ingrowth that we do everything that we can to see where is it. And we did actually offer the patient at that particular time if they want YAC to be done. And then patient, since the vision is still good, patient said they want to actually have a look at it, observe it, and and then after they get transferred local outstation. And came back a year after that. During a year after that, then the presentation was actually on the right eye 636 with a pinhole of 612 and N24, whereas the left eye is still good. Now, at this time, when we actually look at it, then you actually have, that's it. Now you have all central, bulk, and that is actually the ingrowth that we saw before. If you look at the differences between that and this, you can see that it has gone after 1 year, and I do not know how the patient can still see well with that, but the vision 636 does actually reflected that the vision is actually affected with that particular ingrowth there, and it has actually gone within 1 year to that. And that's usually what patients do. When they actually have a good vision, they come in. They have when they have a problem, they come in. So when we look at it as slit scan, we know that this is actually interface is actually quite thick. So we go ahead and look at into our ASOCT. We look at ASOCT there. This is actually 6,000. You can see that there is actually a local thickening over there, and then it has actually have a lump over here. What actually worries me on this is more when you look at the ASOCT is actually the homogeneity of the lesion itself, and as well as when it's affected the flap. We can see the clearly flap over there, and this has actually involved the flap. The other thing that actually worries me at that particular time, because you can see it almost like encapsulated. So when you look something like that, you know that you're going to have difficulty when actually clearing this up. So when you look at, and this is what will happen intra-op, assessing to it is not a problem. We've been very careful because we can see the fragility of the epithelium or the cap side, and actually it's a bit, visible when we look at the anterior segment. So we closely try to look at again where is actually the actually source of that, but we couldn't find it, slowly, and then carefully lift it up, and we can see that there's actually adhesions over there. Now, just by actually having a feel, we actually got a feeling that this is actually I can see the fluid over there as well. You can see that there is actually indentation at the cap, and then we quickly just actually clean the liquid. Now, you send it to the microbiology and everything, don't find anything there. So just actually snip that, and then clearly try to actually look at that jelly-like and try to separate it to see whether there's a lot of damage has been done from the keratolysis. And then on the flap, we have carefully, and this is really, really fragile. So we look at that and then try to actually look at again whether there's actually a source where is actually the trace of that epithelium come in before we actually assume it is an inoculation of epithelium during surgery. And then quickly just put the suture there where I think the most possible thing coming in. Now, this is actually a day after. You can see that I put a suture over there. You can see that there is actually the swelling as well as the opacity over there, and then come to the to the 3 months, and it become a bit better on that. Now, the issue with this is actually this is actually the OCT after 3 months. When we look at it, it looks better. You can see that it's better than before. And then when you compare it with what we had before, you can see that it's regularized, but we could not get the vision better. It is actually 6 and then 8, it's better than 636, but we do lose 2 lines over there. Then it's actually 665 before. So you can see that even that we can get the normal architecture back, but we can never get a good visions. Now, the femtolacid liquid after growth, the key intraoperative finding that we have is liquefied interface material, very friable flap and anterior cap. We do have metamycin actually standby, but with that particular architecture, we do not want to risk it. We do not get the origin of ingrowth, the standard epithelial ingrowth removal. We do that. Then I just put the half of the suture over there because I'm suspicious that is where it come from, bandage contact line. So in case 2, it's actually 42 years old male, had smile done, monovision, a right eye for the near visions, and the right eye is actually for far. Follow-up after 7 months, ingrowth detected at 7 months. Again, there's no history of trauma, infection, DLK, or prior lip flap because of smile. So when you look at it, there's actually, again, paracentral over there, really the beginning of it. Again, when we actually offered the patient actually refused. The patient is actually offshore in the oil and gas business, saying that, okay, this need to be done. We need to actually do something about it, even though the vision is still good. Patient refused to do anything at the moment, and as usual, and we look at that, we can see that with the slit, it is still early, but it's interface. We can't see anything else. We thought it's, again, maybe the inoculations of epithelium. So after 15 months, come back to us with a vision drop 6, 12, and 12. Now, when we actually look at the slit lamp, there you go. That small thing then become really dense opacity in the interface. The vision have dropped, as I said before, 6/12. And 5, when we look into this, you can see that is very dense on the other angle. Now, when we look into this and you compare to that within 15 months, and you actually have the, this is easily prevented before. Again, we succumb to the patient's needs, saying that they do not need to want to do anything. They will come back later. They never do. And that's what you have, and we have to deal with that. So when we look at the ASOCT, again, we can see, and this time what we worry is actually because this particular lesion really actually changed a lot. When you look at the serous compared to the anterior just now, you can see that the same morphology, the same presentations there. You have homogeneous, usually the scar never homogeneous. You actually have irregularity in the appearance of the ASOCT. This is homogeneous, almost encapsulated over there as well. So we know that, again, we are dealing with something. And the thing is, because, sorry, let me go back. Because it's actually a smile, we actually have to use a circle to do it. And I really be careful with this because I do not want to go through that particular lesion. So we docking it a bit decentral, but make sure that it's actually within the circle parameters. You can see that there is actually a bubble there indicating that, almost OBL happened, but that is actually going to that fluid. Quickly actually do everything that we can, just make sure that the plane is actually, and it is actually at the interface, and we can see it's a very, very adhere. And we're prepared for that. So actually we're trying very carefully not to damage the cap. And then usually we look at the counter force and the force that we need to do. And then we get the material there. And again, the simple thing that we do again. And only this time, I can see that, it's not visible in our video. It is actually a regular surface that we have. So I actually, opt to do this diamond burr just to make sure it's regularized. We put it back. And then just actually observe. I do not put any stitches over there because obviously it doesn't come from anything else apart from the main incision from our smile, if it happened. So why this case is different from me? There's no flap available initially. Cap was very delicate and friable again. Attachment is actually make it difficult for us. So then we do circle to do it, perform it, but we have to do it in a controlled manner. So if you look at this, this is 1 month after, you can see that that is actually all the scar that we have. We do not have that. So we do not have the opacity in the middle of it, but the vision has not actually improved that much. It just improved in terms of the near vision, but not the far vision. So if you look at that, now this is actually 2 months afterwards. It looks better, but we could do a better job if we didn't early. What this case has changed in my thinking is actually AS matter now, ASOCT, just like been highlighted before. And again, anatomical success is not an optical success. In the late ingrowth, this is a late ingrowth. The problem no longer just a misplaced epithelium. We deal with that before. We know what to do. But with this, you have the epithelial necrosis, digestions, liquefied debris. And then, usually we don't have a good optical outcome on this. So I would actually say do not underestimate the late epithelial ingrowth, liquefied ingrowth changes the surgery. We counsel the patients even before we go to the procedure. Thank you so much for your attention, and sorry that I'm taking more time than I needed. Thank you so much.
Thank you, Dr. Karitan. Dr. Osama, will you be able to share your screen now? The take-home message here, I think, is to act in time so that you can avoid further complications.
Yeah. Do not have. That's the thing. When we want to do this, we need to actually have a consent from the patient. When the patient doesn't consent to it, then we stuck. We're stuck. Then they come.
Dr. Osama, are you ready?
Any other comment I would make about that ingrowth is obviously if you notice that at an earlier stage, to perhaps try to have more regular follow-up. Like you would see some implantation of that epithelium in the very early post-op phase, potentially even day 1. So
you'll see some signs at least.
Yeah,
right.
That's what I think.
Yeah, I'm agree with you, Dr. Gupta. Actually, the position of the ingrowth is in the central. Yeah, the position of the ingrowth is in the central vision. So I guess the earlier, the better. Maybe the different procedure can be done if it's in the peripheral. Agree with that.
Another point that I'd like to make.
Move ahead.
Yeah, sure.
We can have a discussion later. We have 2 more case presentations. I think we are running short of time. Sorry. Dr. Osama, are you sharing your screen?
Yes, I'm getting a message that I cannot share it because somebody else is sharing.
Yeah,
I don't
now
know
it's
how
on, so
come.
I think now you can share.
Yeah, I highlighted, share the audio, but is it shared now? Very strange.
In the meantime, I would like to introduce Dr. Yao, who is an associate professor of ophthalmology, Eye and ENT Hospital of Fudan University, Shanghai, China. She has an extensive experience of 18 years in refractive surgery. She has been the coordinator for APAC training courses on SMILE, ICL, and Presbyopia. And she also has researches
Yes, now it's
focus on biomechanics of cornea. Yeah, please share. Visual quantity and customized planning for ICL. Yeah, I think we can see your screen.
Rupal ma'am, just a reminder about the time.
Yes, so we'll quickly have both the
Sure.
Dr. Yao, after Dr. Osama finishes, you start without my talking in between, please.
Thank you, ma'am.
Dr. Osama, please. We can see your screen. Please unmute, sir. Dr. Osama, you need to unmute. Please unmute Dr. Osama's mic.
So you need to unmute yourself.
Dr. Osama, you need to unmute, please. Dr. Rajshekar, can you do it from your end?
No, ma'am. I've texted, so.
Dr. Osama, you can go ahead.
Sir, can you please, unmute yourself before sharing?
Yes, you are unmuted
Very
now. Please share.
Yes, yes. Now it's yes. Now it's unmuted. Sorry. So
Yes.
let me share again. I'm sorry for
Sure.
the
No problems.
glitch.
Sir, now you can share.
Okay. Very strange. I'm pressing the share button. It went back again. Very strange. Let me be the last speaker. I think there is
Okay,
something
Dr.
wrong in
Yao,
the.
would you please share your screen?
Okay. Thank you, Professor Rupal. Thank you for your invitation. It's my pleasure to present my case. I will share my screen first. Okay, so this is a complication after SMILE procedure. And I'm Dr. Pei Jun Yao from Eye and ENT Hospital of Fudan University. Our hospital has a large amount of the surgeries and outpatient visits. I think it's similar with the doctors in India. And we have accomplished over 600,000 patients in last year, and the surgery over 48,000 procedures. And now, yeah, we have published several cover articles in JRS. And this case is smile surgery. He has non-inventable smile procedure with -4.5 diopter in both eyes. Pretty normal pre-op examinations in both eyes. And this is the pre-op pedicle. And this is 4 maps. So the story happens on the first day after the surgery. The patient complained about a persistent foreign body sensation in the left eye, which started only 5 hours after the surgery. He experienced a sudden exacerbation of the left eye and feels severe foreign body sensation. And he actually used some gentle wiping to release the foreign body sensation. But the residual symptom persisted overnight, and there's no associated pain or significant vision loss. So when he come back on the first day, the vision is actually not bad on the left eye, but the conjunctiva has some mixed injection presented. There's no cell, it's also very quiet in the anterior chamber. The autorefraction, we can see a little bit astigmatism with a little bit high hyperopia. And we can see a lesion on the cornea at the peripheral of the cornea on the left eye. Actually, it's outside the lenticule, and it's a little bit distinct, crescent-shaped white infiltrates the superior temporal corneal limbus. The subtle granularity is noted within the stroma adjacent to the lesion. Actually, in the lamella, there is some inflammation. We can see in this conjunctival injection, which is not very severe, but you can tell from the other eye. And here is the lesion, and we can see it's also it's not only in the lamella, but also at subepithelium. And on the same eye with the lesion over there, we can see the lamella. There is like Sahara inflammation in the lamella. We do the OCT, you can see the lesion actually is outside the lenticle. And here the lenticle is a little bit increased refraction. And then here is the lesion we can observe from the slit lamp. So what is the impression for the left eye? Because it's on the first day after the surgery, and only a little bit foreign body sensation, but not not very severe aching on the left eye. So we will differential diagnosis infectious or non-infectious. So if we want to rule out the infection etiology, we have to do some microbiological workup. And for example, the smell, the culture, and the sensitivity testing, but it will have the injury to our cornea, which will definitely impact the visual acuity. And also confocal microscope when we are suspicious of the fungal, which is not so likely. If for the non-infectious process, we should use steroids. So actually, the patient has a sign of DLK definitely, but the lesion on the peripheral cornea is kind of confusing. We use a broad spectrum antibiotic combined with the topical steroids to see whether it's effective or not. But unfortunately, it just the symptoms getting more severe. So we decided to do the steroid. We use a high dose steroid to make it a little bit mild, a symptom. And then after 1 day, we use the flap irrigation. Actually, we use the 4 minutes irrigation, use a solution of 10 microgram dexamethasone dissolved in 5 milligram BSS.
Cold pressed. Phone call.
Okay, let's continue. And then after that, we still use the topical steroids to maintain the therapeutic levels. And then after that, we find positive response to the steroid. And we can see in the lamella, the inflammation is getting faded. And the lesion is a little bit like being stable. But after a long period of the topical steroids, it's getting better. After 1.5 months after the surgery, we have a visual acuity of 1.2. And all the lesion has completely gone. This is the pentacan, and we can see there's nothing left on the cornea, which is very clear in the lamella. So after the 6-week follow-up, this is the left eye. And OCT shows there's no residual lesion on the peripheral cornea. So when we see a lesion after the SMILE surgery, we usually think of several causes. But in this case, because of the possible response to the steroid, and we can diagnose that this patient has a marginal immune reaction in the left eye, probably because of the suction cone contact with the cornea, because it's outside the lenticle area. And also he has a diffuse lamellar keratitis, of course. Yeah, the third diagnosis is the post-SMILE status in both eyes.
Can you please conclude?
Yeah, so this is the case I present today. Thank you.
This is really an interesting case, and it tells you how to differentiate between an infectious and non-infectious keratitis and keep that suspicion in mind. I'm sorry for the want of time. I think we will not be able to continue with another presentation, Dr. Osama. Maybe next time we will have the pleasure of listening to you. And at the conclusion of the session, I would like to thank all the participants for being there and spending time with us to make us more knowledgeable. And I would really like to see you all again next year. And thank you, Dr. Rajshekhar, Dr. Gunjan, for the support that you gave us. Thanks, AIOS, for this opportunity. Have a
Great session. Thank you.
We just want a group photo.
Yeah, Imam, group photo.
Thank you.
Yes.
Good evening, sir.
Please don't go away.
So can everyone open the cameras?
Please also send to everyone.
சரி மின்மேஸ் பண்றேன்.
I've taken one shot.
மின்மேஸ்
You can also
பண்ணேன்.
take one.
அப்புறம் இது என்னோட
So that's thanks.
Thank you. I hope everybody had a big smile.
Yes.
Thank you all. Thank you, everybody.
Thank you so much. Thanks, everyone.
அது சம்மதேஷ்.
ഇതില്ല. Minimize பண்ணிக்கிறேன். ஒரே செகண்ட் இதேம்மா மியூட்ல தான் இருக்கு. என்ன எதை மினிமைஸ் பண்ண சொல்ற?
If the presenters want to try their slideshows, they are free to try. We'll be starting the session at around 6 p.m. You can let me know. I can unshare my slides.
Hi, Dr. Ilan.
Good
evening, sir. Good evening. So, betting on RCB today?
Yeah, I'm waiting for that match.
Hello. Should we start our meeting now?
It's 6, I think you should.
Yeah. Just
Okay,
one more minute is there, I think, no?
Just 1 minute.
Yeah. So the first speaker is Samresh, but I have his recorded presentation to show. And then Dr. Arun Glani is not connected. Doctor, can you talk to Milind Pandey, Sri Ramurthy?
Okay.
Arup Chakravarti was also one of the speakers.
Good evening.
Hello, Arup.
Hello, this is Milind Pandey here.
Hi,
Oh,
Milind.
wow.
How are
That's
you?
wonderful. Wonderful.
I'm very well, and you?
Very
Yeah,
well,
you're
very
right
well.
there. Fine.
Excellent, excellent. Can I
We are
just
so
check if my slides are going through?
Yes, sir. We just 6 o'clock.
Okay, so you started. Fine.
Arup
Should
has
I
also
start then?
joined. Let's start.
Ramurthy,
Can
can
we have
you
the first speaker 6 o'clock?
wait? Can you connect Ramurthy? Can you connect to Arup?
Yeah, I'm
Yeah,
here.
Arup has
Arup
joined.
sir has joined.
Arup has joined. Okay,
Yeah.
then let me start off. Very good evening to one and all of you. A very warm welcome to the AIS International Conclave webinar. And our due in the next 1 hour is to talk on managing the unhappy patient, the dysphotopsia, surprise, and dissatisfaction. And I'm truly lucky to have on the expert panel Dr. M.S. Ravindra, who heads the Ravindra Eye Hospital at Bangalore, a great cataract refractive surgeon. I'm truly lucky to have on the panel Dr. Ramurthy, who's the chairman of the Eye Foundation Group of Hospitals and our past president AIS. I'm truly lucky to have with us Dr. Krishna Prasad, who's a senior cataract and glaucoma surgeon from the Hubli Eye Hospital, and an amazing surgeon and with a great academician. We're really lucky to have with us Dr. Abhijit Desai, who is a cataract surgeon, a leading cataract surgeon from the Agarwal Group of Hospitals based in Mumbai. We are truly happy to have with us Dr. Y.L. Rajshekhar, who's again going to bring in a lot of energy and dynamism into this webinar. We're lucky to have with us on the expert panel Dr. Arup Chakravarti, who's known to all of us, again, a senior cataract and refractive surgeon from Trivandrum. So we have speakers on the with me, Dr. Samresh Srivastav, who has sent his recorded video because he's flying to the ISRS. And his talk is going to be Dysphotopsia decoded from optics to chairside solutions. I would be talking on the refractive surprise. That thing went out of just 1 minute. Refractive surprise. And I would have just 1 minute. I'm sorry. I would have Dr. M.S. Ravindra talking on retina, cornea, or brain, solving the post-op puzzle. And then there'll be challenging case scenarios in the context of managing an unhappy patient by Dr. Milind Pandey. And if Dr. Arun Gulani has received my link and joins in.
He has joined. He has joined.
He would be showing a challenging case scenario in the context of managing an unhappy patient. So without wasting any time, we shall go on to our first speaker, Dr. Samresh Srivastav's recorded thing from talking on dysphotopsia decoded from optics to chairside solutions.
Good
Do
evening,
let me
everyone.
know.
I'd like to thank Dr. Chitra Ramamurthy Madam for inviting me to talk on this particular course on dysphotopsia decoded. And I would like to congratulate the AIOS for conducting such a wonderful.
We are not seeing the video. We are not seeing the video.
You are not seeing the video?
We will decode the
No, we are only able to hear the video, ma'am. The audio. Can you reshare?
Just 1 minute.
And look at practical chairside answers.
How do we? You all are not able to see it?
No.
Surgery was
No, ma'am, we are not able to.
And the patient reached 20.
I think you are not shared the screen. Whoever is sharing that.
Our first instinct is always to
Just
reassure
1
them
minute.
that everything looks okay, but to the patient, their vision is flawed. Today, we will decode the physics behind this, the frustration behind this, and look at practical chairside answers.
I don't know.
It's very important that we look at these eyes from more than one angle, use it in more than one diagnostics, and if need
Yeah,
be,
now it's on.
Yes.
from our colleagues, because
Now we
sometimes.
Start from the beginning.
Yeah.
Good evening, everyone.
Can you see it now?
I'd like to thank Dr. Chitra
Yes.
Yes, ma'am. Yes, ma'am.
on this particular course on dysphotopsia decoded. And I would like to congratulate the AIOS for conducting such a wonderful international webinar of such a large scale. In the next 10 minutes, we will decode the physics behind patient dissatisfaction after perfect surgery and look at practical chairside answers. You know, we have all been there. The surgery was textbook perfect, the lens is beautifully centered, and the patient reached 20/20. And yet they are miserable. Our first instinct is always to reassure them that everything looks okay, but to the patient, their vision is flawed. Today, we will decode the physics behind this, the frustration behind this, and look at practical chairside answers. It's very important that we look at these eyes from more than one angle, use it in more than one diagnostics, and if need be, also take a cross opinion from our colleagues, because sometimes we miss things, particularly when it comes to dissatisfaction despite a spectacular functional outcome. I'm going to divide this talk into two different sections. One, where we are going to discuss what is known as positive dysphotopsia, and the second segment later, which is the true negative dysphotopsia, which has a totally different mechanism at play. Let's just understand what is positive dysphotopsia. Positive dysphotopsia can present as bright arcs, glare, starburst, or halos. And typically, the culprit is these light rays that enter the eye from periphery, and then they strike the sharp truncated edges of these IOLs, which are generally high refractive index IOLs. So instead of refracting cleanly, these rays undergo internal reflection and focus on unwanted second line of sight onto the peripheral retina, causing problems and causing these visual phenomena. Typically, when you see a positive arc of light in the periphery or peripheral starburst. Glare is typically due to, as we discussed, internal reflection or an apparent light. Halos, on the other hand, happen because there is some sort of opacity in the central visual axis, either in the form of a posterior capsule opacification or a corneal swelling that hasn't gone down after cataract surgery, or if the lens is scratched or partly opacified, or if the patient has a really poor ocular surface. In patients with diffractive lenses, it is mostly the interference of those diffractive rings that cause two light points to form that cause halos as a visual phenomenon in these patients. First things first, when these patients come to us for evaluation, we have to look for simpler causes that can cause these problems first. In my clinical experience, it's things like residual refractive error, mostly astigmatism, a posterior capsule plaque that has not been peeled out, or a small L-shaped pulse that's lying in the posterior capsule in the visual axis, or a decentered lens. Rarely it is problem with patients' neuroadaptation. Let's look at it in a clinical scenario. So this is a patient who came to us with age-related cataracts, and we put, this was many years back, and we put a +3 full range diffractive lens. And the patient is upset after surgery, he never really saw very well. And he always said, I thought multifocal IOLs were integrated into classes, and so I spent so much. But why am I not comfortable? His unaided post-op vision is 6/9 N8 and not a full range. And that's because the patient has a residual refractive error. This is not a fault of the lens. This is a fault of calculation. It's a biometric error. This was an older generation formula, so that could be attributed. But the problem is not in anything else, but in the fact that if you put these glasses, the patient sees well at all distances. That's why it's very important, and I wanted to bring this out, that when a patient comes and is dissatisfied, please have your best optometrist do a refraction and see if you can, and I would encourage you to put that refraction in front of the patient's eye and see if the visual phenomenon disappears. Chances are it probably will. If they have a residual refractive error, you may want to treat it by using a laser vision correction or by a lens exchange surgery, both of which need a lot of chair time. Another patient with a similar story came to us with a 6/6 N6 vision, but says the vision is not very crisp. This is a very interesting patient, because when we put this patient on an aberrometry, This is what we saw. So I'll just give you a background that when we put a lens inside the eye after a cataract surgery, we have to understand three anatomical positions. One is the center of the limbus, which is marked by a blue cross. Second is the center of the pupil, which is marked by a green cross. And as you can see over here, it's overlapping the central pupils. And the third is the red cross, which is the line of axis or the visual axis on which the patient is fixated. Now, with these 3 points in mind, let's look at this patient I'm talking about. Notice that this patient has 3 different points, not overlapping, but far away from each other. The visual axis is far away from the center of the limbus and the center of the pupil. Now, when you do a cataract surgery and you place an IOL, the IOL will typically go and sit inside the capsular bag, which is the center of the eye, because that's where you center the IOL. But if the patient's visual axis passes not from the center of the lens, but from the diffractive rings, it is easy to understand why this patient has problems, because he's seeing not from the center of the optic, but is seeing from the diffractive area. This patient will typically have halos, glare, and other sort of photophenomena. So it's important to measure these patients' angles, particularly if you're doing full range diffractive lenses. We can get away with EDOF lenses and monofocal lenses because they do not cause visual deterioration as much. But if you're putting a trifocal or diffractive lens, it's worth looking at this picture. Now, moving from positive dysphotopsias to negative dysphotopsia. Now, negative dysphotopsia is very clearly a patient that complains of a gray concentric shadow, typically on the side of the incision or temporal side. This is temporal dysphotopsia. That gets better by either lifting the eye or by squeezing the eyes. The optics are pretty simple. In the area between the optic and the edge of the optic, there is an illumination gap where no light goes and hits the peripheral retina, so a dark crescent forms. This is a disease of omission. This occurs, as I said, because of illumination gap, as you can see in this diagram also over here. The light passing through the edge of the IOL is always bent inwards rather than bending straight, and this light missing travels, down onto the retina. How do we differentiate this instantly in a busy clinic? By using what is known as a shadow test. For a patient complaining of a dark temporal shadow, block the ambient light coming from that side with a card. If the shadow disappears, you've confirmed that there is an optical ray gap. Furthermore, dilating the pupil usually alleviates these negative dysphotopsia symptoms because it allows peripheral light rays to bypass the IOL edge and then fill the dark zone. So 2 tests, one is holding a card and the second one is to use a dilating drop. Now that you have a patient with negative dysphotopsia, our management strategy must follow a very important, strict step-ladder fashion. Most important is for us to not panic, because this patient will typically come with a complaint. Second is for us to register the problem in front of the patient and accept that there could be this negative dysphotopsia, but reassurance and watchful waiting would be my step number 1. And with this, in this only majority, I would say about 80% of these patients will neuroadapt within 3 to 6 months. If they don't neuroadapt, then we want to try non-invasive fixes, like maybe give a thick rimmed glass on the side, prevent or physically block the peripheral temporal light entry. But only when these conservative measures fail do we want to step up for surgery. For a persistent negative dysphotopsia, reverse optic capture, which means bringing the optic anteriorly, is known to be highly effective. The catch-22 situation is that if you wait long enough, the capsule fibroses and it becomes difficult to perform any movement that involves exchange or reverse optic capture. But in my understanding, there are very few patients in my practice that have actually had to physically do it. So one has to keep in mind a good time frame and take a prudent decision. IOL explant or exchange is the last thing on my mind, but really you may have to do it. It's not easy because one, it will cost both the hospital and the patient, and it will create a lot of frustration in the patient. And there is no guarantee that post-operatively the patient will be comfortable. Again, point of advice is please evaluate the first eye performance and treat the negative dysphotopsia before you think of touching the second eye. Many times you're in a rush to operate the second eye, assuming that if you do the second eye, patient will forget about the first, but it may only worsen the situation. So please take your time and let the patient adapt before you touch the second eye, cataract allowing. And please never do not shy away from prescribing glasses to these patients first, because that alone may solve the problem. So to summarize, it's important to build trust by validating symptoms of the patients early. Please do a quick chairside verification, as I discussed, to rule out if there's a corneal or a retinal issue. Then give brain time to adapt. And if you must intervene surgically, change the optical geometry, but please do so in good time. I thank you very much for patiently listening to this. And I apologize for not being physically present for this webinar, as I had urgent travel, which I could not avoid. Thanks a lot to the entire panel, and thanks Chitra Madam for this opportunity once again.
So I think I'll initially keep our discussions a little brief, and once I know we've adequately, all our speakers have given the talk, if you have time, we could take more. We'll just take a couple of questions. I would take the first question to Dr. Arup. Now, which IOL characteristic would you feel contributes most to this dysphotopsia? Do you think it's the edge design, the refractive index, the material of the lens? This is the optic size or asphericity?
See, basically, I mean, as regards the negative dysphotopsia, I think that is more commonly seen in the initial stages. In any lens which is in the bag with a perfect rexis overlap is capable of giving rise to negative dysphotopsia. The lens which is least likely to give this sort of this thing is, the silicon lenses. Some of the silicon lenses, the Bausch & Lomb LI61U, and then Star used to have a silicon lens earlier. So I think if you have to exchange a lens with a lens which is less likely to give rise to, less likely to associate with negative dysphotopsia, I think it will be these two lenses. So it is basically a perfect lens, well-centered intraocular lens with a perfect overlap, round overlap, is which usually gives rise to negative dysphotopsia. And positive dysphotopsia, as mentioned, it is basically the lens which is giving rise to it, the square truncated edge lens, or sometimes we have noticed that if the lens has been damaged during insertion, some of these patients may complain if it is present in the visual axis. They complain about for the symptoms, and we need to exchange those lenses.
And also the high refractive index lenses also are being understood to be causing more dysphotopic symptoms. Going on to the next question, I'll ask Ramurthy. Do you think the multifocal and the EDOFs are actually merely unmasking dysphotopsia, or do you think they truly increase its incidence?
I think they truly increase its incidence. I mean, multifocals, it's not just the material by virtue of trifocals, by virtue of the diffractive rings. They split the light, and whenever the laws of physics that whenever there's simultaneous macular perception from different distances, there is not all rays of light is in focus, and what's not in focus is what is causing the dysphotopsia symptoms. That's the reason that in spite of multiple modifications, variations, none of the trifocal lenses or multifocal lenses are able to completely get rid of the dysphotopsia. Of course, the present crop of modified monofocal lenses or the EDOF lenses, which have purely a curvature change and not a diffractive rings, fare much better than them and have a dysphotopsia profile which is closer to a monofocal lens.
Yeah. While I'm trying to get my presentation connected, Dr. Rajshekhar, how long do you think you would like to wait before you intervene surgically?
Most of the times, to allow good neuroadaptation, I play to the patients as if it's one of the most expected ones, and they should ignore that. So because if the patient keeps seeing the dysphotopsic symptom more and more, the neuroadaptation becomes that much more difficult. So and hence how we position ourselves with regard to the outcome is one of the important things. So till now, 4 to 6 weeks, I tell them, and when they come back, I'll say some people take little more time. And most of the patients by 3 to 4 months time, they would have overcome that. And we haven't had to intervene. Some patients, we end up giving pyrochloride drops and tell them if it doesn't help, then we may have to go for an exchange. So far, I didn't have to do any exchanges.
I think one should not rush into yak capsulotomy in these cases. So we have to wait, because in case the patient requests a lens exchange, and if you've done a yak capsulotomy, the exchange process becomes more complicated.
Did you see my presentation?
Yeah.
Yes.
Okay. So I'll start off by, I don't know, you're seeing his presentation now?
We're seeing your presentation. We were seeing your presentation.
No, I don't know what is happening. It's getting delayed.
No, we were seeing your presentation. You had.
I think that is the first surprise from her.
I don't know what happened
You have
to
to
my presentation.
share it again, I think.
No, is it your first
Wasting
surprise
time.
in the talk?
We are seeing a dysphotopsia around your head as well.
See, this
Dr.
is
Kudlu.
Dr. Samaresh. You have to close this and open the other one on the screen.
You had done it right. You had closed Samaresh's presentation. Just open the.
Not, oh God. Would our
We are seeing from your desktop only. Now your
Go ahead.
presentation is
Go
coming
ahead. Yes, you're right.
Yeah. Okay, I'm very sorry. I don't know why this happened. So my due is to talk on refractive surprises, prevention, prediction, and perfecting outcomes. So basically, we all know that a residual refractive error is a prime reason for dissatisfaction amongst premium lens surgery. And this was one study done way back in 2003 to 2010 in a series of number of eyes in Wales, where then they sort of brought it out very forcefully that the 4 leading points are inaccurate biometry, wrong IOL selection, transcription errors, and handwriting misinterpretation. So this was a large study. So the first one is the inaccurate biometry. So basically, planning for the worst is by doing the best before the surgery. And what is the best that we can do is use the latest generation formula, the 4th or the 5th formula, ensure that we do accurate measurements, be the K value, the actual length, the ELP assessment, with the help of the newer variables which are there in the formula. Repeat the test, see whether to even check on 2 biometers, even to check it with the other eye to validate and check on the consistency. Now, this was a study which compared the number of formulas, and what came through was that the Hill RBF3, the Barrett Universal 2, and the EVO in 92% of the situations were within plus minus 0.5 diopter of target emmetropic outcome. What we also need to understand that when it comes to a trifocal or a multifocal lens, our threshold for correcting astigmatism has to be very low. This was another very popular phaco study, and what we found is 70% of the patients we walk off with absolute excellent results, but is in only 30% of the patients we are stuck. So when you're doing your measurements, when you feel that the standard deviation is more than 0.2 and doing a keratometry, you need to rule out dry eye, do all those tests which is needed to rule out dry eye, treat the dry eye, repeat your measurements. If that is okay, but still the standard deviation is off, then it could be a
The audio is cut.
Audio and video, both, sir.
No, we are not able to hear you.
Cornea the very next day and ideal post-op outcomes. But then it is also important to determine what went wrong in that particular case So then it means we have to repeat the refraction with the best of our optomes, do a dilated examination, slit lamp evaluation to see whether there's something got missed, repeat your biometry, look at your surgical records, look at whether the value of IOL implanted was what was needed. And if none of the above are there, then you would have to presume that it's a wrong IOL labeling. So when you know you have a refractive surprise, the next options are, when would I do a toric IOL rotation? When would I do an exchange? When would I do a laser vision correction? And when would I do a piggyback? So this was a patient who got operated and came back after a week with a +8 diopter of residual in his eye. Now that is abominable. And then the first thing we did was check on his biometry, and we realized that the IOL inserted was the right one. And then all the other factors being okay, then the
Your video is frozen. We're not able to hear.
Sorry, I think you lost me a bit, no?
Yeah, completely frozen. In between, it broke. The voice and video were not coming, and then
Yeah. I'll share again. Are you able to see my presentation now?
yeah, now we can see.
Yeah.
Yes.
So then we have to decide the timing when we have to perform a refractive enhancement. If it is the wrong IOL, the earliest, the better. If it is toric, we could even wait for a week or so. But if it is a laser vision correction, we would really like to wait for a stable refraction and stable topography. Even 6 weeks or 3 months may be okay. And we should also look at the other eye and see whether there is a need for a neuroadaptation. Now, this was a patient who had a small sphere and a cylindrical refractive error. And what was needed, all that I did in this patient was create arcuate keratotomies, which have a coupling effect. And we have the latest formula, Donald field nomograms, which tell us what is the exact arc length which is needed to correct that small astigmatic error, and that should suffice. Now, if laser vision correction is indicated, it could be small refractive errors, more often myopic errors, more difficult primary surgery. And if it is a flap-based, I would like to wait for 3 months. And these have become a lot more uncommon. And in that, if we are doing it, it would be a femtosecond laser platform. But surface ablations are the easiest way because these older patients have dry eye issues. And if the refractive stability is achieved by 6 weeks, we would go ahead and do that. And this is again a figure showing a cataract surgery done earlier, old video with microkeratome and the surface ablation. Now, if it is a toric IOL residual error, we need to decide whether the patient is going to benefit by doing a rotation. And you would see this is a characteristic refractive error of +2 with -3.25, where actually the spherical equivalent is 0. These are the cases which would need a toric IOL rotation. And you could go back and check on the Barrett RX formula or on the astigmaticfix.com. And when it comes to the actual procedure, you just need to go back and open up the incision, and with just the infusion cannula on, with the Varion overlay or any similar digital overlay, you have to just reposition it and very gently remove your instruments and ensure even after removing your instruments, the IOL is locked into that position, and then close the case. Now, if there's a re-rotation, then the query starts. Could it be a zonular instability? Was the haptic absolutely okay? Would I need to place a CTR? Was a CTR placed in the other eye? And of course, I would have to take the help of the online formula. This was going back to that old patient who had a +8 residual. We need to know what was the implant placed, what is the endothelial status, is the eye still inflamed, was the PC status okay, and then whether we have the right instruments and be prepared for an anterior vitrectomy if it was needed. And in this particular case, we decided that naturally IOL exchange was the only way to go. And in this particular case, we brought the haptic out and stabilized the lens by holding the haptic. And we had to just cut halfway through, which is what is often done. Now I would even go to the side port with an IOL micro forceps and grip the IOL if I do not want to do it this way, and go ahead and cut it, bisect it into half, and then pull it out in the routine manner as we would do. With the hydrophilic IOLs, which are hardly there excepting in some companies, you can actually, without even enlarging the size of the incision, which just a hand over hand technique, you can get these IOL out and then go back and inflate the bag with enough viscoelastic, dispersive viscoelastic, and place the fresh lens of choice. Now, if it is a patient has come to you late with the requirement that he has a residual refractive error, and you're going to do an IOL exchange for him, then this is a different scenario, because there is already capsular bag fibrosis which could have occurred. So you would, of course, some of these eyes, you would be able to easily just clean up the space, inject viscoelastic to a visco separation, or if you are able to get these IOLs out, you could cut it and remove it. But sometimes you may even decide to, if you're not able to get the haptics out, you would leave the haptics behind, just cut the optic and go ahead and do it. If it is that the residual error is significant and you're not able to do an IOL exchange, or you would not want to go ahead and do that, you could place a piggyback IOL lenses, which do come in. If the primary lens is a hydrophilic, you would place a hydrophobic. And we have sulcoflex lenses and different lenses which are there, especially for piggyback lenses, which would take care of the surprise. This was an old surgery wherein the patient had a significant residual error of +3, and we went and implanted a hydrophilic lens of a larger optic, and these have undulating haptics. And there has to be, these piggyback lenses have a posterior concave surface, which prevents the interlenticular opacification, which could happen in these eyes. And post-operatively, you could go back on ASOCT and check whether the vault was okay. Actually, the second eye often gives you a chance to titrate. If in the first eye there's a small residual error, you can do a micromonovision or do similar, or change the lens, do a mix and match, and then treat these patients. Like in this particular case, the patient long back had a laser cataract surgery with symphony lens, but was not happy with the near vision. In those days, we had the Technis +4 lens, and that was implanted at that point of time to take care of that extra near vision. This was again another older case wherein we did a symphony in both eyes, but all we needed to do was just a micromonovision. And when we talk of micromonovision, we should not try to bring in a difference of more than 0.75 diopters between the primary eye and secondary eye, because you do not want to compromise on the binocular status or the stereopsis. And sometimes there is a difference in refractive error, there is a residual refractive error, and the patient, you would just not do anything. There are a whole lot of newer range of lenses and a lot more examples which I could have shown you how best you could do it, a mix and match, or how are you correcting it. But probably the future is a breakthrough technology wherein you would have a way of doing a post-op IOL power adjustment and take care of these patients. Thank you very much. Like going back to some interactive questions in this particular topic of mine, I would like to ask you, Dr. Ellen Kumaran, which are those patients whom you would consider are high risk of getting a post-op refractive error, even before they enter the OT? Like, who are those patients whom you might expect?
But I couldn't hear the question properly. High risk before entering the OT of post-op refractive errors.
No, I'm not. Yeah, some patients you sort of know, you're wary that these patients, you might end up with residual refractive error. Like, who are those? Like,
yeah,
for example,
predominantly I would look at people with irregular corneas, people who have had their corneas touched, such as a refractive surgery, and most importantly, I would place the high hypermetropes, change in the shape, the relative sizes of the eyeball, anterior to posterior. These are the three groups I'll take it seriously. That said and done, commonly we face problems with dry eye patient. Dry eye patients, without treating those patients, when we subject them to cataract surgery, we find these surprises. And the post-pterygium surgery patients, which has not been evaluated properly.
Yeah, even post-vitrectomized eyes and extremes of axial length could be areas of challenge, although we have better formulas now.
Yes.
Dr. Krishna Prasad, Now, which formula would you feel in your practice you feel gives you reliable outcomes in these long and short eyes?
No, actually, as Dr. Ilan said, you have to be really wary of certain situations. In such situation, we take multiple gadgets, like probably we'll have more than, I mean, two optical biometers doing it multiple times. And number two, the formula also. As you said, Barrett's Universal 2. I mean, that's basically there in the IOL master or basically in the Anterion. That is the go-to formula for us. We also actually look into Hoffer Q, but my go-to formula is in most cases Barrett's. So Barrett's probably works best for most of the axial lens, but more importantly, getting the consistent values. Sometimes these eyes in the same machine, multiple readings give you different. So basically taking one reading and thinking that that is the accurate can be a big mistake. So on different days, on different machines, I think on such eyes where you are suspecting such a surprise or expecting a surprise, then probably you need to probably work. You probably, if you spend time more preoperatively, you will have less postoperative problems. I think you should never rush these surgeries. You should be always be aware of this.
Before I ask the next question, could Dr. Ravindra connect his presentation? Because sometimes, like, I managed to flop it a bit. Dr. Ravindra, are you there?
Yeah.
He is going to be talking on retina, cornea, or brain, solving the post-op puzzle. On to you, Dr. Emerson.
Sure.
Dr.
I'll share
Chitra,
my presentation.
the previous question that asked, that the Kane formula and the EVA formula also have been giving good results in these extreme situations.
Yes.
What is the panel's opinion on Barrett's true axial length formula?
Barrett's true axial length formula. Why would you like to add a word on that?
Argus has as a biometer uses short segment measurements for the entire axial length. So in these extreme cases, that would be a better formula to actually apply.
Okay.
You mean the Argus also has that?
Only Argus has it, I think.
Yeah.
So yes, on to you, Dr. Ravindra. Before
Dr. Chitra, is my slide visible?
Yes, slide is visible. Yes.
Fine. Okay. My sincere thanks to AOS office bearers and the course director, Dr. Chitra, for inviting me to join this and learn a lot from you guys. Basically, unhappiness prevails. You may have the best of situations, but the best of IOLs and best of consumables, but there are occasional patients who are very unhappy, and you really are pushed to a corner as to how to handle them. Cataract surgery does not guarantee a satisfied patient, however much is your expertise. There are many reasons why the patient can come back and complain to you. His knowledge is something which is amazing today. Google and AI, they can, by the time he walks out, he already has the answer. Refractive surface, dysphotopsia, ocular surface, structural defects. And more than that, the cost, he compares with the next person who's sitting next to you, who had a surgery in the camp, and he had perfect surgery done free of charge, and he has paid a lot of money, and then he has a lot of complaints. So the proportion is that more he has paid, more the complaints he's likely to come back with. The staff behavior, the waiting, soft skills of the patient, all are important as far as the patient's well-being is concerned. Sure, when he comes and sits in front of you, normally what we say, everything is good, surgery I've done very well, the lens is good. That's the usual answer that we say. Patient will never be happy. You should put on the patient after a reasonable amount of time, say a month's time, a rigorous systematic investigation protocol that you developed in your own clinic, and do not hesitate to take the opinion of second colleague that you have there or in some other hospital. So there are post-operative dissatisfaction technically can be so many of them. I don't want to go into the details. The crux is that they expect chair time. They expect you to listen. That itself clears most of the questions that he has, especially if the eye is normal. And he expects a scientific answer, which is found in Google or one of the AI media. So what are the options you have? You give some placebos, medications, or treat the surface, whatever it is, and laser vision correction. And the last is IOL exchange. Both of them I have not done at all in my surgeries ever since, I started doing surgeries. So before initiating an invasive intervention, based upon the symptoms, you can classify them, whether they are related to the optics, whether related to the surface, whether they're related to the retinal problems. Roughly, you can make it out. Or are they pre-existing? A hypomature cataract patient comes and you really do not know what's happening inside the eye. They can be pre-existing. So it can be optical, it can be psychological things. These have been described, but if the patient complains of positive dysphotopsia, it's because of high refractive index materials, which Dr. Chitra pointed out. And, it may be because of multifocals and EDOF lenses. Negative is more in women and more in the left eye. I would like to know what's your experience. That's what we have seen in our practice. It's a lady, right eye is perfect, left eye is perfect. But the symptom of negative dysphotopsia is only seen in the left eye. So this we have looked at, and all our consultants have looked into it, and this is a fact. Then refractive surprise and aberrations, especially blur, ghosting, monocular double vision, reduced contrast, they're all related to residual powers. You can pinpoint based upon the symptoms, higher order aberrations. They can be dry eye, they can be IOL tilt and decentration, or they can be PCO, as Samresh pointed out. So these are the technical things that are there. Nobody knows what is the ideal size of the pupil, which minimizes the negative dysphotopsia. And Michael Simpson said that 2 millimeter pupil is the one, very tiny pupil is the one which causes maximum dysphotopsia, negative dysphotopsia. And if such pupil is found, you just dilate it a little bit, maybe with the brimonidine kind of a drug, not to dilate fully, and that may help in preventing. All these are found only at night times. Daytime, they do not see this. When the contrast is high, they see that. So don't try to classify. Don't ask questions. Do you see this much, that much, this much? I mean, they'll get really worked up. So these are all for your consumption, how they see, but then do not discuss with the patient is my thing. Night vision symptoms, I've already told. If you see, they can occur in combination. If you see glare and starburst, it indicates there could be a posterior capsular pre-existing opacification, or there can be refractive errors, which can be aberrations, or it can be surface conditions. It'll point out where you have to investigate these patients. If they complain of halos, definitely they're related to multifocal IOLs. Waxy vision is something which is very common. Patient says, I don't see it clearly. I see everything, but it's smudged. Edges are not very clear, very sharp, like what I used to see or what I see in the other eye, unoperated eye. So this is because in a plano or in a monofocal lens, everything is pointed out at the fovea. In a multifocal lens or any EDOF lens, it is spread over a larger area. When it's spread over, even in myope for that matter, when the focusing is spread on the fovea, in front of it, and behind it, based upon the multiple focal elements that the lens has, you have smudging of the edges, like what you see here, the pinpoint light perception. Here it's smudged all around. So this is light, but it happens even in the daytime when you are trying to look at the distant objects or intermediate objects. So this is a range of focus. So companies say I have a range of focus from distance to near, but in my opinion, it's good to see all the distances, but at every distance, because you're not removing the elements which focus at different levels. They're already there. So it's a combined effect that you see. More enhancement you do in the EDOF, more amount of smudginess they have. So that we have to keep it in mind. When a company representative says it covers a lot of areas, that means all these areas are focusing on the fovea in front and behind when you're looking at an object. So this doesn't get into our mind, at that point of time. So you can see the pictures of left side, how a normal eye looks like, and the right side, though the near vision is better, but it's at the cost of distance and intermediate. So we have, it's always nice to prevent these things happening. We have a nice checklist here. We've been using it. We ask the question whether the patient uses distance zone how much, mid zone how much, near zone how much. Do you want better vision for distance or better vision for intermediate like a computer guy? Or do you want better near vision? All these I say, we have a table here, easygoing to perfectionist. So this is not, we don't ask patients to circulate, but by the time we interrogate the patient, counsel them, a person who asks a lot of questions, he brings a lot of references. So he is going towards the perfectionist, and we'll have to be very, very careful in handling him. But for a person who says everything is all right, sab chalta hai, then you can go for whatever you want. So, so that's the preventive aspect of this. So premium IOL screening checklist, everybody will have that. And any premium lens, you will have to look at tear film, T-Butt, Shermer's test or T-Butt is essential in them. Look at the cornea. Even a tiny pingula that is present on the temporal side or nasal side, causing a bump, can give rise to tear film instability postoperatively, and these patients have to be there. And mebomenitis is another condition. MGD is something which you'll have to do. We all know that we'll have to look at angle kappa and all those things that may not spend time here. When a patient comes with surprise results, we all get worried. For example, if I've got a lot of patients who plan multifocal, but they end up with 0.75 on the minus side or a 0.5 on the plus side. But patients, you talk to them. The moment you see, our optometrists are tuned to saying, they get worried. No, this is a patient. So he won't go in the line. He will be stopped and additional tests are done. And patient is so happy till that point of time, he starts worrying. And somebody escorts and brings it to me or one of the colleagues, and he is treated as something which has gone wrong. So this, you have to tell everybody in the hospital that nothing has gone wrong. This surprise is normal. 0.5, 0.75 can happen in spite of your best. Our staff should know about it more than our patients. So that will give a lot of consolation. He should flow like a normal person, and then from behind she can send a message or tell us that there is a patient who is surprised, and look at the person and then you decide. And we have a chart, very good chart. This is the chart post cataract.
Concluding shortly, Doctor. You'd be concluding shortly, no? Because
sure, another one slide, one or two slides.
Yeah.
So I'll go fast. Post cataract, I don't want to see all the tests we have done before the surgery. This is pre-op. Sorry, sir. That's a pre-op on the right side, and left side is post-op values. Everything, including slit lamp examination, is repeated, and then one of the optometrists and our colleagues will say prediction errors, biometric, where the error is there, we pointed out, and plan corrective action, we'll do it. This is especially essential before you do the second eye. We have to go through a couple of points before we post the patient for a second eye. It may be third day or fourth day, it doesn't really matter. But many of them, this is for surprise. Doctor will assess the symptoms, review. I'll skip this. Don't show anxiety or worry. Retinal macular checkpoints. One of the most important things that you'll have to check, especially if you could not see the fundus, is how well the patient fixates your fixation target. So that gives an information, and if there is an anisometropia preoperatively, whether he's using the best of his neural capacity, that's the phobia to check it. And by all these are already done. So psychological lifestyle, the patient's personality and lifestyle requirement dictate the ultimate capacity for neuroadaptation. If he is desiring to get the don't use the word neuroadaptation. Don't use the word that you will get used to it. Say that it will get corrected and this will disappear after a long time. If you want to change the lens, I've never done it. We always give the second eye priority and then come back to the first eye in case there is a surprise. The patients are very happy and they won't come back. Are willing to accept mild rings around light at night in exchange of independence from reading glasses. Tell that if I change the lens and put a monofocal lens, you will lose the capacity to read. That itself will push them back, and they'll accept the halos or whatever you have. So with that, I will conclude, and I again thank Dr. Chitra and everybody in AOS for giving me this opportunity to share. Thank you. Thank you.
I'll rapidly take 3 questions based on cornea, retina, and neuro, which is what this talk was about. In the cornea section, Dr. Ramurthy, do you think the higher order aberrations actually explain most of these mystery unhappy patients?
Sir,
You are muted.
Before taking up any of these patients for or trifocal or EDOF lenses, we do conduct a very detailed examination of the cornea, apart from a biometry, etc. Any case with a significant amount of aberrations, especially coma, is a relative contraindication. Again, we are quite careful about patients who have undergone prior refractive surgery. What we want to see is a sea of green, a well-centered treatment, if at all we are taking up these patients for a EDOF lens. And then, of course, angle kappa was something that was being talked about quite a bit. And nowadays, the thought process is that we had a cutoff of 0.5, and now it is believed that it doesn't matter so much. I myself have seen that now that we are measuring it regularly, having a patient with angle kappa of more than 0.5 is extremely rare. It occurs in less than 10% of the cases. And even in those, it doesn't seem to correlate with the postoperative symptoms. So essentially, the regularity of cornea, the higher order aberrations is what we most importantly look at. And
yeah. Can you hear me?
Yes.
Yeah, Dr. Aru, what OCT findings should never be ignored, even when the visual acuity is 6/6?
So if the patient has got, all the cataract patients, I feel, should undergo a macular OCT. And if any abnormality is seen in terms of, macular hole or epiretinal membrane or early onset of age-related macular degeneration, any evidence of past edema, I think with these patients are strictly contraindicated to take up in a higher order multifocal intraocular lens.
Dr. Milind, while you are getting your presentation connected, I'll take one more question. Dr. Rajshekhar, do you think you can actually predict which of these patients might go in for a cortical adaptation failure? Preoperatively, and you would be wary of some patients.
Yes, some of the patients who are typical type A personalities and high expecting kind of patients are the ones who may not be able to get adapted. And in these cases, onus is on us in how well we console them, saying this is one of the common things. They think that something rare thing has happened to them and they're suffering because of that. So it takes multiple visits and some chair time, and downplaying the symptom is the best thing.
Yeah. And one last question, Dr. Krishna Prasad. Would you actually think a patient is actually unhappy through refraction and everything, and might even do a macular OCT, but would you routinely perform a topography in these symptomatic pseudophakic patients?
You mean post-operatively or pre-operatively?
Post-operatively. No, he's unhappy post-op. Would it strike you that why not I go back and do a topography also? Would you?
Yeah, definitely. Normally, every patient, we don't do a pre-operative topography, only in patients where we suspect some surface problems. But otherwise, in a patient which was uneventful, but the patient is very unhappy and everything else appears to be very much normal, then definitely topography will really dig it for us, because what is not visible, it makes the invisible visible. So definitely it's a good idea to get a topography in case we are struggling for answers. That's a very good idea. Very good idea.
Yes. Yes, on to you, Dr. Milind.
Thank you for the invite and the opportunity to present one of my, I think this is a case I learned the most from, possibly the most. So this is the kind of patient we don't really want. We don't want an unhappy, angry, frustrated patient. But we do get this quite a lot. So this is an old patient of mine from 2013. An Irishman, a very relaxed chap, bilateral cataracts, glare, dazzle. That was his refraction, nothing much, but best corrected at 6.9 only. and 6'9", 6'12". But previously, he had been a high myope with a high cell. And in 1997, which was a few years before he came for surgery, he had LASIK in both eyes for that kind of a treatment. Now, in 1997, LASIK was in its very early stages, so it was quite interesting to see what they did. And a few months later, he had a retreatment for his left eye, which had shot up to +4 from -6. And then we have data from 1998 when he was 612 plus, plano in the right eye, and 612 in the left eye with that refraction. So quite a complex kind of a patient. And this was his IOL master and corneal topography, where he was measuring 1 diopter still in the right eye and 1.25 in the left eye, and slightly worse total keratometry measurements in the right and left eye. So we did a left eye first, refractive cataract surgery with the 2 diopter cylindrical toric lens, 80 Torby, 2.2 millimeter incision. 2 days later, he comes back with a 2 diopter of cell at 5 degrees, just literally flipped the whole thing, and he's overcorrected by the same amount. So then the question comes, what do we do? Now, I had a chat with him. I said, look, we could wait for the left eye to settle. It's quite well known that corneas which have had previous laser surgery, especially multiple procedures, can take a long time to settle. And while that is settling, we could proceed with the right eye. And this time we will ignore the corneal sill that's been identified. And he was quite happy to go with that. So that's what we did. So 2 months later, he had his right eye done. Right eye was fine, everything. We used a monofocal non-toric lens. But the left eye remains at -2 plus 2.5 and no change in that sill at all. What are the options for the left eye? So the options are we do a monofocal exchange for a toric. So in other words, a non-toric for toric, or we put a sulcus piggyback toric. I chose to put a sulcus piggyback star Visian ICL. I thought it would be an easier way to do this. This was 2-3 months after the implantation. And I didn't think having much of a problem with this. And lo and behold, he was quite happy with the result in terms of his vision, but he had significant halos and coasting is what he said. So I reassured him. I said, okay, this will be fine. You'll readapt to this and everything. And a few months later, I get this lovely note, a letter, which my secretary passed on. Dear Mr. Pandey, hoping you can allay my predicament. Try as I can, I can't get used to my left lens. What are my options? So we bring him back in, run through the topography and everything, basically saying he can't drive at nighttime because the halos and glare are very severe. One thing I do in these kind of situations, because the language can be quite challenging, I just ask my patients to draw what they see. And this is what he drew in the clinic. In the left eye, it's these circular things that he saw. And the moment I saw that, the penny dropped as to what is going on here. And it really is the hole in the center of that ICL, which is what's causing these. So the options were to remove both the in-the-bag and sulcus torics, sulcus ICL, and replace with an in-the-bag monofocal, which I should have done possibly the first time around. Exchange the sulcus piggyback lens, piggyback ICL for a sulcoflex, or you remove the ICL with the hole and replace it with an ICL without the hole. So I said, okay, we're going to try and remove both the in-the-bag lens and the sulcus toric and replace with monofocal, if that's possible to do. If on the table, I find it's too risky to do that, then I will just exchange the ICL for a sulcoflex. So at surgery, we removed the ICL, but the in-the-bag IOL removal was attempted with very severe fibrosis around the intraocular lens, and it was getting quite challenging. So I bailed out and I stuck in a sulcoflex toric -2 +2. And problem solved. Patient was very pleased, no halos, UDVA, and everything seems fine. The moral of the story is that we always come across situations of huge surprise. We expect something and something else happens. And if we keep doing this 2 or 3 times, then it gets very difficult. Now, this was a very challenging patient with multiple prior LASIK and everything. But the fact that the patient was pretty emotionally comfortable in going through that rocky ride is something that comes through. And you have to think in terms of first principles. If this doesn't solve it, why is he getting these halos? And it ended up with that hole in the ICL, which was really doing it. So it's important to think from first principles always when one is solving problems. One has to gather what the actual situation, the reality of the patient, understand it, and then work through in a systematized way what the issues are and what the possible solutions can be. And you have to communicate and carry the patient along with you. And if you do that, then really there isn't much of a situation where patients are unhappy, because patients really know that you have the best interest in heart. And if they don't believe that, then that's really a much bigger problem, because you've lost their trust altogether. Thank you.
Thank you. So, Dr. Ramurthy, your thoughts on it? And after that, we would take Dr. Gulani's talk, and if you have time, discuss.
Very nice presentation, Milind, but we have used a lot of phakic intraocular lenses, both ICLs and other lenses with a central hole. We do get patients with complaining of halos in the nighttime, sometimes bothersome, but many of them adapt. But this kind of a problem we are not faced. Of course, using an ICL as a piggyback lens is an off-label use, and I would rather use a Sulcoflex lens, which you used rightly so in the as a next option, because those are designed for placement in the sulcus. ICL with its much smaller diameter, especially a toric lens, whether its stability of these lenses is questionable. And since we have a better alternative, maybe Sulcoflex is the way to go. I'm not sure that because among the hundreds of phakic intraocular lenses that I have personally placed, this kind of issues we have not had.
That's right, and I agree with you. The key situation here is the fact that this is a very peculiar eye. This is a high myope who's had multiple corneal procedures, has a deep anterior chamber, and hence the optics of that hole behave very differently with the pseudophakic lens inside. And that's really was the point of of showing this lens, is that in these kind of eyes, which are very unusual, which are very peculiar, you can't really use generalized rules to say this is what will happen, because there will always be eyes that will surprise you.
Right.
Thank you so much, Dr. Milind. That was very nice of you to chip in for this international webinar, and do stay connected for a few minutes before this session gets over. Thanks a lot. And I would love to hear from you, Dr. Arun Gulani, about your very interesting case.
Certainly. Can you hear me, everybody?
Yes. Yes.
First of all, thank you so much for the invite. It's an absolute pleasure to see you all. So let's start with my mindset and the topic that I've been given, challenging case scenario in the context of managing unhappy patients. Are there happy patients? So as the late Steve Jobs said, if you want to make people happy, just sell ice cream. I always believe, do what is right. In fact, I do not give options to anybody, and happiness will follow. Having corrected perhaps every kind of premium lens implant from all over the world with the clientele of patients who comes to us, and not having exchanged a single lens with us, despite being the anatomy, is what I want to share my mindset with. If we have time, we will talk about these concepts I talk in my course at the ISRS, and which is lens and barista, what your patients are actually saying, selling bailing, tailoring after with alterations, ingredients versus recipe, lens inserting, adjusting, exchanging technicians, and the art of conviction, confidence, and accountability. So let's start with what kind of patients we see in our institute. As they arrive from everywhere, as you know, many of my patients are complex cases. They're very, very intelligent, very educated. They research for months, years before traveling to me. And they send me all this data. If that doesn't make me smart, then they send me videos after surgery. Many of these are engineers, surgeons, celebrities, everybody, but their logic and mindset is the same. So here is an amazing engineer. He's explaining to me after I fixed his severe RK LASIK eye, and he's 2015 vision. And after this surgery, he goes back home and he sends me measurements of his vision and how thrilled he is. So very important, the clientele of patients we all see nowadays. I'm sure all of you see such patients.
Come to the conclusion that about 5 feet away, the eyes are equal, and then from 5 feet on out, the right eye takes over.
And of course, then they send me graphs of post-op vision and how improved they are and why they feel they've done so well with all the planning. If that doesn't end my ordeal, my referring surgeons from across the world, these are the emails I get from them. Always appreciate your no-stitch magical cataract surgery through such dangerous eyes. Patient is seeing unaided 20/25 minus. I explained to her that you missed half a diopter astigmatism. We'll keep you posted.
Times, I'm a patient of Dr. Galani.
All of you understand this, which is why I do not like doctors talking about lenses. When the patient's happy, they give credit to the lens. When they're unhappy, the discredit is the surgeon. That's absolutely not fair. May I encourage all of you to understand the minuets of surgery that I expect every eye surgeon to know, because I believe every eye surgeon is a vision corrective surgeon. By this, I do not mean you need to know glaucoma, retina, or oculoplastics. What I mean is everything from cornea to lens in between and sideways, so you become invincible as a vision corrective surgeon. So these minuets, these Lego pieces of surgeries, you must know before you do your first premium lens, because that makes you infallible, strong, convicted, absolutely confident in your work. So think like a master chef. The lens implants are just ingredients. There is no reason to give it importance beyond that. It's the vision recipe that you do that's just mind-blowing, and then your surgical artistry in a 3-centimeter eyeball as a master chef. When a patient arrives to me, until date, over 2 decades, I've not exchanged a single lens of any surgeon from anywhere in the world, and no matter what the implant is, because I always look at the recipe. How can I make this lens optic work? Right from the tear film to the cornea to the lens and back. And that mindset is very important. Of course, if the lens is anatomically damaged or causing anatomical damage inside the eye, yes, I understand. Exchange, but that's the least important and intelligent thing, as far as I'm concerned, to do. It's the most easiest thing to do. Remove the lens, beg for mercy, no negative review, and sorry, and go home. Everybody loses. Keep that previous surgeon's work and make the entire eye work around it. So keeping that mindset, let's discuss with you how I think. This is a prototype patient. In fact, 16 patients are landing this Monday with unhappy 20/20 outcomes from very good surgeons across the globe. How do I think? Here's a patient. He's a pilot, keratoconus, hyperopia, high K, central scar. Doctors put in a premium lens implant here and opened the PC2. Patient's very angry in a potential lawsuit, 2200 vision. So what am I thinking? As every surgeon who was visiting that day wanted to see me plan my surgical skills and what they will get to see, and as every surgeon that this patient saw throughout the country, and wonderful colleagues, very brilliant colleagues, they all were talking about how to exchange the lens. All kinds of techniques going on in their mind. Nobody's talking about how to make this patient 20/20 at least interventional and make it amazing with whatever the patient already has. That's the mindset. So the patient has hyperopia, presbyopia. What I do is I like to count all the issues, like pins before bowling, right? And then my clear system, keratolenticular extended armamentarium refractive system, which has over 41 techniques that everyone can do. You can then design what to do. So the issue became, the one surgery I need to correct all these problems would be surface myopic laser surgery. Problem is the patient's hyperopic with all these issues going on. So I start thinking, what happens is a transition in the patient's psychology and brain. He was flown in very angry with his surgeon, and he has spent a lot of money seeing other doctors and surgeons across the country, unhappy. But when I start thinking, and all the doctors around me who are visiting start wanting to see what plan I'm making surgical, I just go into a mindset. How do I keep his surgeon's work and bring this patient to become a pilot again? That mindset is very important. So as I start thinking, the patient becomes your cheerleader. He forgets his anger to his own surgeon, starts cheering for you because now he's thinking. I go, how do I make you myopic? And he goes, how will you, doc? I say, okay, here are the pins in front of me. Corneal scar, astigmatism, pseudophakia, hyperopia, high K. So what I need to do here is a plan with which I can get all the pins. I don't like a single pin standing. So on approaching this case, I decided, let's leave the eye where it is. Because the eye has a deep anterior chamber, posterior capsule is open. Even if I do all my skills and exchange the lens, I'm not guaranteeing 20/20 because that's an invasive surgery. Instead, I put a piggyback lens on this patient, turn the patient into myopic astigmatism, and now he's ready for my myopic laser surgery. So let's look at the data here. Pre-op vision 2200, refraction. Remember, I refract every patient. A refractive surgeon must know how to refract. Nobody else does the refraction for me. I spend hours and hours as these patients land from everywhere on the planet. I disregard topography, wave fronts, OCTs, everything that I have three machines on. Refraction. The only criteria that gives patient correlates of vision. So I refract the patient to 20/50. Then I plan a lens, again, forget the name of the lens, a piggyback lens, and I put in a lens to create myopic astigmatism. No big deal. 4-minute surgery through the same incision of his previous surgeon, topical, absolutely great experience for the patient. I wait till the patient stabilizes, and I need to reach a refraction of -1.75, -3 at 60. Now I attack with surface laser surgery with just 50 microns on his keratoconus. Of course, patients over 60 years, remember? Strong. And the patient lands straight at 2015, unaided always. Always when I speak, it's no glasses contact. The patient's back to being a pilot. Again, if you look at topographies and stuff, which I don't look at in the pre-op, this is just for teaching purposes. I keep showing these things. You can see the impact of the topographical changes in these patients. What is the summary of this case? If you see, actually, I made his vision worse by putting a piggyback lens. Before taking him to the final vision, the patient and you have to have confidence in each other. I call this taking the patient first to Iceland, dark and cold, while the ticket actually says Louvre in sunny Paris. So very important, the patient and you have to have confidence that you're going in the right direction. And that does take these patients. Now remember what the patient remembers. Few minute surgery, topical, you honored his surgeon, patients beyond 20/20, back to life. So the summary of this is a mindset that allows us to think beyond surgical acrobatics. Anybody can exchange the lens, the easiest surgery to do, just like a transplant. When I think of that, I think no one's thinking here. Everyone's out to lose. But to think through the process, provide the patient the perfect vision he had originally started with, return the relation of the patient and the surgeon back to perfection, and took the patient forward from the mid zone straight to the vision end zone, and always without glasses and contacts. Do not lower their expectations. Very important, doctors. Now, I have lots of cases for you. Let's go through another one quickly while we have time. And then if not, we'll stop and take questions. 73-year-old patient, multifocal lens, put in Dr. Leonard.
Questions.
Pardon me?
Sorry, I think we should discuss your case because we have only 3 minutes to hand over. So
Go
we
ahead,
can't
please.
go on to a fresh case. So,
Go ahead,
Arup, can your thoughts on this case? Arup, are you there?
Yeah. You tell me, Chitta, what was your question?
Yeah. No, what your thoughts on this case, which Dr. Gulani showed us now?
Well, I have been following his work for the last couple of years, and what he shows is really amazing and unbelievable. Wonderful results, definitely. His approach is definitely commendable. Congrats, Arun.
Thank you, Arup. And may I just say this, please, on this forum in particular, all of you are amazing surgeons. Mind-blowing surgeons is the word I use. But I really want to change the mindset of doctors. You are not a slave to a lens. I, in my practice, see the world's most demanding patients. Here's a statement I'm making on record. I haven't given an option to a single patient till date. You are the
Dr. Abhijit, Dr. Rajsekhar, would you all have anything to add?
No, we are also like Arup, we are also fans of Arun. Once we had called him to Bangalore Ophthalmic Society meeting, he changed the way that all of us think and do. Let us hear more from him. It's slightly not the routine kind of thing that he thinks. It's
then Ramurthy.
Amazing concepts and amazing presentation. Nothing less was expected. Dr. Gulani mixes up all the tools that are available in the armamentarium to take the patient back to emetropia and a happy patient. Obviously, all of them in all our hands do not work as well as it does. I mean, sometimes there are unsatisfied patients, and I cannot say in my refractive career all my patients have been as happy as what it has been in his hands.
Dr. Abhijit,
Can I
what
interrupt?
would be the biggest, yes, Abhijit, what would be the biggest mistake the surgeons actually make while handling unhappy post-op patients?
Hi Arun, that was a nice presentation, a very nice case. But sometimes you need to resort to a lens exchange as well. Like I had a patient in whom trifocal toric was put in the sulcus and it had rotated, and whatever the re-rotation was done to get it back in the axis, it would go back to the same axis, and there was an induced cylinder of 6 with some spherocylinder on the plus side. Now, in this kind of a case scenario, we thought over it, and finally we had to get a customized Sulcofix trifocal lens ordered for the patient, which was used not as a piggyback, but as a lens exchange, and the IOL was put in the sulcus, and we had a happy patient. So, yes, I agree with on the clear concept that Arun is talking about, but maybe sometimes you need to think about how can you think out of the box to give the patient happy moment.
I think to
So
answer
if we
Chitra's
have
question,
time,
I mean, I think it is better not to dismiss the patient's symptoms, and that is the biggest mistake.
absolutely.
Yeah,
Absolutely.
absolutely.
So Abhijit,
That's
the
good.
only excuse or only one indication, as I said in my talk, where you exchange the lens is the lens itself is damaged or causing anatomical damage to the eye. Beyond that, I'm just making a statement. There is no lens that needs exchange if you resist it enough
Absolutely.
to
Yeah.
take the patient to perfect vision. So if we keep that mindset, the biggest issue I see with every patient who flies to me, I'm writing a book on this actually, What Your Patient Wants. You know that movie, What Women Want? So people, what y'all are being taught, everybody in the country and world, is wrong. Patients are not asking for lenses. They want you all, the doctor. We are disregarding that importance. And that's why you see my points that I can't discuss today because we don't have time. I call it lens and barista. Go get your lens on Amazon, go to your local barista, get it done. If you want an eye surgeon who does magic in 3 minutes, totally different concept. So we have to reinstate that power that doctors have, that status that doctors have and deserve back. Patient cannot call you for a lens. It's an ingredient. You're the master chef. It's a Michelin star restaurant. You don't charge extra for a clean plate and silver and making the food hot. It's all expected. So this is my way of teaching, which I think is very powerful to empower doctors again, because all these patients who come to me have the same story. They were given a menu card, the doctor then defies it, then they are in trouble, then there are lawsuits. The lens has nothing to do with it, I tell them. The lens is FDA approved. The doctor did a great job. Let's see why you can't accept it. And then start working on the optics, the cornea to the lens and back. And all of these people can be helped. And another part of my talk I can't do here is part of my course, how to take people forward. A 40-cut RK patient can still have multifocal optics. I've done it. So if we have that mindset that the lens is nothing more than an optical manipulation gadget in the eye, the whole concept changes, as you know how I think. And of course, the patient is your best judge. That's why every video I show patients in it, because without the patient, it's BS. Cannot say patient did well. So if we have that mindset, it's amazing that every patient, keratoconus, RK, LASIK, ectasia, all of them can have amazing surgery to 2020. It's just that we have to raise our mindset. It's not the lens. The patient has to start understanding the magic is all of you. With that, I'll end my talk, but please, any questions, I'm always here.
Thank you. Rolika, do we have time for any discussion or is it over?
Ma'am, no, the time is up. The session will be starting in some time, the next session.
Oh, okay. So thank you very much, my speakers and panelists in this session for allowing me to, the way I attacked you with the rapid fire questions, because I was so keen that something goes across in this 1 hour, 15 minutes, which we've had together. Thank you very much for your presence. Thanks a lot.
Can we have a
Thank you,
group
ma'am.
photo before
Thank you so
logging off?
much.
Just 2 minutes, all of you. Can you have your videos on? We'll have a group photo.
Yeah.
Yeah. Thank you. Thank you so much, everyone, for joining us on a Sunday.
Thank you.
Thank you,
Have a
Dr.
good night.
you.
Bye-bye.
Thank you. Thank you. Thanks a lot. Yeah.
Thank you, everyone. Thank you, everyone, for the session. Thank you, Parth.
Yeah.
Thank you, Chitra ma'am. I'll just wait for the other session to join. Soumya, you are here, right? Soumya?
Yes, ma'am.
Hi, Dr.
I'm here.
Soumya. Dr. Anirudh has also joined. So both
Huh.
of you are here. I'll just handle the other two sessions.
Okay.
Just share the slides, please, and keep it going. Anirudh, thank you, both of you.
Thank you.
Thank you.
Hi, Anirudh.
Hi, Dr. Soumya.
Hi. I just talked with Pooja Khadar madam. She told me that just to introduce chairperson as well as herself, moderator. Then she will introduce the panelists and the speakers.
Sure. So I'll introduce the session. Maybe you can introduce the Dr. Pooja, or do you want to switch it around? Hello, Dr. Soumya.
I will introduce the moderator.
Sure. I'll introduce the session, then hand it over to you. Then you can maybe introduce the moderator and the chairperson, and then we can get started. Okay.
Should I tell anything about the chairperson in detail? Or she will tell, moderator will
Yeah,
tell.
that I think she'll take on. I'll just share the.
I will just tell about her. Madam has sent me her details.
Yes.
It's an ophthalmologist, clinical scientist, and institutional leader specializing in refractive and ocular surface disease and director at Apollo Hospital.
Can you see my this thing?
Yeah, I can see. You will be telling the best of IRSI and the program directors as well, right?
Yes, yeah.
Then can you change the slide? Next one. I will introduce the chairman, Dr. Jeevan Singh Titiyal sir, as well as the moderator of the session, like that.
Yes. Yeah.
And she is the director of Apollo Hospital. Which branch? These are work champions. Apollo Hospitals. Oh, director at Apollo Hospitals. A lot of hospitals. Ma'am. Ma'am is online, it seems.
Yes.
Hi. Hi, ma'am.
Good evening.
Just for info, doctors, we are in continuous broadcast, please.
Hello.
Hi,
Hello.
sir.
Hello, sir.
I think everyone is coming, sir.
Say again.
We can wait for some time.
I think after 3 minutes, we'll start.
Yeah, yes, sir.
Perfect. Okay. I thought it was half an hour from now. I was mistaken, but I was corrected because of you. Thank you.
Okay, sir.
Hi, good evening to all of you.
Hello.
Good evening, sir.
Hi.
Good evening.
Good evening,
Good
sir.
evening, sir.
Yeah,
Hello, Professor Anas. Nice to see you.
It's a pleasure seeing you. How are
Hi,
you?
sir.
All good.
Dr. Pooja had not joined yet, no?
Sir,
Pooja,
I'm here.
oh,
Pooja
you're
is
there?
there, sir.
Yes, sir, I'm here.
Yeah.
Ashraf, how are you?
Yeah, you are
I'm
there.
fine.
Yes,
How are
yes. I
you?
can see
How are you, Pooja?
Ashraf
How are
also.
you,
Yeah.
Johan?
Good,
How
good
are you?
evening.
See you.
Yeah. Actually, I just landed from the airport, just
Oh,
entered.
A lot of people are landing from Coimbatore right now.
Yeah. I think we're on the same flight now.
Myself, Dr. Soumya, and Dr. Anirudh will be the program coordinators today.
Perfect.
Sir, we can wait for some more time and start the session.
Yeah, you have 30 seconds.
We'll start at 7:30?
Yes.
Yeah.
Well, I think this may be the last session, but we are still always in crunch of time.
But you look fresh.
Trying to.
is Damian is here also, yeah?
I did remind him. Let me.
Because I think he's still in China. I think so.
Oh,
I think so.
then you all can present for a little longer time.
Yeah. Should I start the session, Dr. Pooja?
Yeah, please go ahead.
Okay. So a very good evening to everyone. I know it's the last session of the day, but it's going to be a wonderful session. It's titled The Best of ISRS. It's going to be about an hour 15-minute long session. The program directors are Dr. Ashwin Agarwal and Dr. Susan Jacob, and we have a wonderful panel lined up. I'll hand over the podium to Dr. Soumya to introduce our moderator for today, Dr. Pooja.
Can you give me the next slide, please? It's okay. I would like to introduce the chairman of the session, Dr. Jeevan Tityal sir, And the moderator of the session, Dr. Pooja M. Khamar, and she is an ophthalmologist as well as a clinical scientist and an institutional leader and specializing in refractive surgery, ocular surface, and translational diagnosis. So she is the director of Apollo Hospital Group. I welcome you, madam. I hand over the session to madam to go on. Thank you.
Thank you. Thank you. Can I share my screen, please?
Yeah.
Thank you. So a very good evening to all. And welcome to this session of ISRS, the best of ISRS, which represents the International Society of Refractive Surgery, the global vision of advancing refractive surgery through innovation, education, and collaboration. So on behalf of AIOS and also ISRS, I'm representing ISRS today as a council member of the same. We will bring together an exceptional lectures from national and international faculties to discuss innovation, optics, corneal surgery, cataract surgery, and the future of refractive surgery. And this is going to make this session extremely exciting. So before I invite all my speakers, I would like to welcome Professor Jeevan Titiyal sir, who is the chairman of the session, and also Padma Shri awardee, president of AIOS, former chief at RP Center AIMS, and also one of the most respected names in Indian ophthalmology. He is also the chairman of session, and he's going to give us a talk on in situ phacoemulsification in eyes with phakic IOLs. Our other speakers are going to be Professor Ashraf Armia, who is from Egypt, an internationally renowned cataract and refractive surgeon, global educator, and also leads in keratoconus and surgical innovation, and also has societies. We also have Professor Damien Gatinel. He doesn't need any introduction, but he's from Paris, one of the world's leading authorities in ophthalmic optics and refractive surgery. We all keep hearing about his innovations all the time, and today, if he can join us, he's in China, but he's trying to join us. His talk on wavefront in diopters is really something very fascinating, which we all struggle with, how to decode the wavefronts in diopters. So please hear that out. We also have Professor Anas Anbari, who is an international recognized speaker for his expertise in corneal transplantation and complex anterior segment surgeries. And we also have Professor Gaurav Luthra. In India, he doesn't need introduction. He's from Dehradun, a highly respected refractive and cataract surgeon, known for his work in premium IOLs and refractive cataract surgery. And I would also like to invite all my panelists, apart from Professor Gatinel, Dr. Luthra, and Professor Armia. We have Dr. Tushar Grover, Dr. Rushad Shroff, and Dr. Shivani Patnaik, who will be joining me. So without any further delay, I would like to invite Professor Ashraf Armia. And while he's setting up, if Professor Titiyal has some words to start the session, I would welcome him as well.
Yeah, thank you so much, Pooja, for a wonderful introduction to the session. I think we are really thankful to Ashwin and Sujan for curating this beautiful program for today's session. And on behalf of All India Ophthalmological Society, AIOS, I'd like to welcome all our international faculty and national faculty for this wonderful session, which is going to come not only for people who have joined just now, for people who are going to see these programs subsequently through the AIOS website, because we have a large number of members, more than 27,000 people. And those people are going to benefit the today's session. Especially, this is one of the most challenging sessions I can say, because some things people don't understand at all. And again, welcome all of you, and hope that we'll have a very nice discussion. Thank you, Pooja. I think we can start now.
Thank you. Thank you, sir. And Professor Armia, he's going to be talking about physiology and driving force behind the innovation in asymmetrical intracorneal range segments. Over to you, sir.
Thank you so much for the invitation. I'm really honored to be among all of you, and to be even in India virtual, but I'm really honored to be there. Thank you so much. So I'm going to share my presentation. So asymmetrical intracorneal rings, I really enjoyed starting asymmetrical since around 4 years. It's really different in everything, and I am talking this today about what's behind it, the bioforce, not the examples as, but mean more about the physiology and the biomechanics. So I have no financial disclosure regarding this presentation, but these are my disclosure to companies that I'm a consultant to. First, I am really happy that announcing this release this month of this huge cataract surgery book. A lot of Indian also are sharing in this book also with me. It is one of the biggest books in cataract surgery by Springer, more than around 1,000 pages, 120 chapters, more than 600 images and videos, more than 145 authors, and it's from 4 continents. So I'm happy that this is now, it's 2 years working to release this. So asymmetrical intracorneal rings, we all know that there is some special patterns in keratoconus that we need, that when we were using the symmetrical, it was not okay as normal. Like this pattern, the snowman, like the duck right or left, or when it's big duck like this. Most of these, when we are using the symmetrical, we are not getting the results that we need. And we all, I don't have any financial disclosure about AGL, but when we have something like this, and we have something refraction like -9, and you put 2 asymmetrical rings reaching this is what we all want to reach. So to reach this, what we really need, think about the physics, biomechanics, and what's behind the asymmetrical intracorneal rings. So first, we should think about the arc shortening effect, which is the primary biomechanical principle. The intracorneal rings works as shortening of the corneal arc length. So the thicker segment, which is the more arc shortening, leading to more flattening over that meridian. So thinning segments, less flattening. This is the concept. So why does this matter in keratoconus? Because applying more arc shortening in the weak, steep area causes greater flattening where it is needed, reduction in the asymmetry, which is in the pattern that we show, and the apex shift back toward the center, which what we need, that we localization of the decentered apex. And applying less arc shortening superiorly avoid overcorrection, because most of the cases that we are using big arc in the lower part, post-operatively you lead to flattening, more conversion to the hypermetropic side. So this is why one thick inferior ring segment work so well for the inferior cones. So the redistribution of the corneal tensile forces, this is what we are getting from the asymmetrical intracorneal rings. And this procedure leading to, when we redistribute the corneal forces, we reduce the high order aberration, which is especially the coma, which is maximally reduced through the asymmetrical intracorneal rings. And this is by reducing the vertical asymmetry on the topography. So this is the biomechanical explanation of recentering the cone, because we are pushing the cone to the center. So local flattening versus global flattening. So we are local flattening of the area of steep versus the global regularization of the whole cornea. So the asymmetrical segments equal local flattening where required. So single inferior segment, selective inferior flattening, which is asymmetrical segment pair to global localization. And in keratoconus, the superior curvature is usually normal, and the pathology mainly in the lower part of the cornea. So hence, the asymmetrical rings preserve the healthy corneal areas. So if we are going to think about asymmetrical and symmetrical intracorneal rings, so the most disable abrasion in keratoconus is the vertical coma caused by the inferior steepening. This is the main pathology, which leading to the decentered apex. So the asymmetrical rings flatten the inferior curvature, re-centralization of the optical apex, and increasing the night driving complaints, mainly from keratoconus, because you are decreasing the coma dramatically. So asymmetrical implantation matched the biomechanical map of the disease, which is the superior is different than the inferior in the cornea. So if we are going to summarize this, so summary of the physical rationale of the asymmetrical rings. Most important that the arc shortening effect is greater flattening inferior. This is the biomechanical concept about the intracorneal, the asymmetric intracorneal rings, and the high order abrasion coma is improved quality of vision in this type. So if we have the duck-shaped phenotype keratoconus, so this is mainly the steep axis of the patient, and this is the coma axis. So when we put the asymmetrical intracorneal rings, we are mostly flattening the more steep here and less effect in the upper part. And if it's a snowman like this is the steep axis and this is the coma axis. And usually when you put two asymmetrical rings, so you have the maximum flattening in this area and the less flattening in this area. And one of the most difficult, pellucidal lobster claw phenotype, which is, in my opinion, the KRAS work very well in these phenotypes. But if you don't have the availability in your hand, the KRAS, you can, mostly this is the steep X, and usually the coma X is usually perpendicular to it. So when you put asymmetrical, you choose the where is the more steep, so you can put the asymmetrical in this area, the thicker, and this is the effect. So flattening in this area will make the whole central part of the cornea less flat, improving the quality of vision. And if we are going to compare the high order abrasion, which is the most important factor in asymmetrical intracorneal rings, the vertical coma reduction in the asymmetrical is dramatically improved, moderate in symmetrical, and the coma axis normalization is excellent in the asymmetrical, fair in the symmetrical, and the quadrant symmetry is high effect when you're using an intracorneal ring, asymmetric intracorneal ring system. Why? Because keratoconus increase the vertical coma due to the inferior steepening, and the asymmetrical rings directly flattening this region show its coma drop sharply, and the symmetrical rings help but do not specifically target the cone. Also, the patient with asymmetrical cones tend to gain more functioning vision with the asymmetrical rings. To summarize it again, best to use. If it's inferior cone, asymmetrical best choice. Why? Because you are targeting inferior flattening. If it's central cone, symmetrical, because it's a balanced biomechanical effect. If it's a paracentral or advanced keratoconus, the asymmetrical, the thick inferior and thin superior. Why? Because greater cone recentering. If it's a pellucidal marginal degeneration, neither use long 300 degrees symmetrical ring, because you cannot differentiate where it is, because it's different biomechanics. You cannot detect where it is. And if it's a post-LASIK ectasia, single asymmetrical segment localized ectasia required for focal flattening. Finally, I will have to say that the asymmetrical intracorneal ring segment outperform symmetrical rings in all cases where the cone is decentered, inferior, advanced, or coma dominant. This is where you can use the asymmetrical intracorneal ring segment. And the symmetrical are preferred in the central cones where regularly geometry. Finally, we are inviting everyone to join our Egyptian Society of Cataract and Refractive Surgery meeting in Cairo this November. Hoping to see everyone in the beautiful Cairo, and our MIOM also this year. Thank you so much.
Thank you, sir. That was a very wonderful talk, and also it was bang on time. So I would now like to invite our panelists and Professor Tithyal sir, Dr. Anas, if you have any questions, we do have time. So
Pooja, I think it was a wonderful presentation, and the concept looks so sound because most of the cone in keratoconus are inferiorly placed, and like I know maybe it has the value of asymmetric rings to be placed in those cases. It means that most cases would require asymmetric rings implantation because most cones are inferiorly placed in a keratoconus. It may be very early cases where you have a symmetric central cone and symmetric this thing. And understanding the coma, which is normally in these cases will be a vertical coma, which is creating problem for these cases. I think this gives a very nice concept. And only consideration for my thinking was once you are placing a asymmetric segment in an area which is thinner, would the depth of these rings will be making a difference because your channel will be quite symmetrical all around. So your the area from where inserting will be little larger for those rings. That was the end of this. How does this? Is there any chance of shifting of rings in a?
This is true. The tunnel is different. The tunnel definitely is the same, and we are measuring it according to the thickness and the depth of the thicker part of the segment. So as much it is more fitting in the thicker, in the part of the more steep, this is the maximum effect we are needed. As much it is less and little bit not tight in this area, this is our aim that we don't need more flat.
Okay.
And I'm also saying that it's not just I'm putting the rings, it's also cross-linking, because without the cross-linking, you are not going to have the maximum effect. So we are just relocalization of the cone, taking the most benefit of flattening, which is I don't do rings and cross-linking at the same time nowadays. I stay from 3 weeks to 1 month to have the best effect of the ring. Then I prepare the patient for cross-linking after 1 month. So I take both benefits of what I need. But you are right, because there are 2 types of PMMA asymmetrical intracorneal rings. There are rings that is different in the thickness all over the ring and the widths. And there is another type that it is different in all the segments. So you are putting the segment in the areas where it is maximally needed. So some rings, some companies develop the asymmetrical rings, which is a center in the middle, more thicker and more wider, and the periphery is less. And other companies work on the whole segment size. So it's different. And the beauty in the asymmetrical that you have right and left. So you have clockwise and anti-clockwise, because it's very important, because if it's anti-clockwise, you cannot introduce from the thinner part. So most of the company has clockwise and anti-clockwise. And definitely the Kairos will going to play more role in this, because you are more and more customizing the asymmetrical pattern of the rings.
Yeah, absolutely correct. I think Sujan is not here today, but she has done all these, customization of case in these cases, with good results. Thank you for putting this concept in front.
Thank you so much.
So I think I have one more question based on your talk, is that we are in an era where customization is everything, and we have a lot of innovations like CARE, CTEC, and also biological corneal strengthening. So what do you think, this question is open for everyone to answer, what do you think is the future of intracorneal ring segments, especially the PMMA ones?
In my opinion, Kairos will play a more upper role above the PMMA. In spite that the PMMA give more flattening, in my opinion, give more flattening and more long-term, because the normal tissue, it changes from time. So it can give now, but we don't know after 3 or 4 years what is going to happen. But the effect of the PMMA will last because it is the same effect. Has no tissue, so you know what you are going to put, what you are going to have. But the Keras, you don't know what you are going to put, what you are going to have till now. In my opinion, the customization of cross-linking, in my opinion, this is the coming future. So you play on the area that you need more flattening with the cross-linking through the AI, more effect on this according to the biomechanics of this portion. So you are going to take more cross-linking, more flattening, more changing in the coma in this area, and the less effect in the less corneal biomechanics changes.
Thank you. Thank you. So now we'll move on to our next talk, and I would like to invite Dr. Anas Anbari.
Shivani had a question. Shivani.
Yes, please, Shivani, go ahead. Sorry.
Thank you so much. Thank you so much. Sir, very enlightening talk. I'm really enlightened by this talk. It's intracorneal ring segments is something that we regularly do in our practice at Mumbai. I would just like to know if after this, the induced irregular astigmatism, what is the role of rigid contact lenses in your experience, sir, with these irregular segments, asymmetric segments?
The concept of the rings is regularization of the cornea, but we are not changing the refraction. We are not aiming to improving the refraction of the patient. We are changing the irregularity to reach the maximum we need, and then after stabilization of the case, we push the patient for fitting of contact lens. This is the aim. Or if the patient is intolerant to contact lens, we go after 1 or 1.5 years for phakic IOL, which is a good option to change the residual refraction for the patient.
Okay. Thank you, sir.
You're welcome.
Thank you. Thank you. So we'll move on to the next talk, and I would like to invite Dr. Anas Anbari, and he's going to be giving a talk on cataract surgery and astigmatism management after corneal transplantation. And who would be a better person to give the talk because he has a very good experience when it comes to corneal transplantation. So thank you, sir, for accepting the invite. And please share your screen and over to you.
Trying to share screen. No. Well, I can't see where the share screen is.
It's on the bottom. You see a panel where you can switch on your audio and video. In the center, there is participant chat. So there is a share button. You just click on that, and then you'll be
on share. Yeah, I'm getting a window opening.
So there'll be multiple windows where probably you'll have to open your presentation first, sir.
My presentation is open.
So on the screen, are you able to see multiple?
Okay.
Yeah.
Zoom would like to record this.
I think Mr. Sunil from the support team, can you send him a request where he can share the presentation?
Doctor has been shared by the presenters themselves, please.
But
I can see share at the bottom.
Yeah, just click on that.
Okay, I get a window opening.
Yes, on the window you'll see multiple screens where you will also see your presentation, which is open. Application windows. Do you see something like application windows?
Doctor, can you click on the share button once on the bottom 6 o'clock?
I get the setting open. So okay, I press the arrow at share.
No, not the arrow, not the arrow. Just on the longer one, not the shorter one, the longer one.
Dr. Pooja, just allow me if I can.
Okay,
Dr.
I'm getting the
Bari,
screen now.
just click on the share button once.
Okay.
You will have a pop-up.
Screen.
Yes, on the left-hand side top, you have entire screen. If you can just click on that. Yes.
Okay, I got it. Sorry.
Thank you. Thank you.
You got it now?
Thank you, sir.
Can you see my presentation?
Yeah, we can see now. You go to
Okay, perfect.
perfect.
Thank you.
Perfect.
So I'd like to thank the AIRS and the ISRS for the invitation. I'm honored to be invited and delighted to participate. I just have one question. Is Dr. Gattinez going to be present? Do you want me to extend my talk a little bit further than 10 minutes?
He said he's trying to join. He has some
Okay.
network issues,
So
but
we'll
yeah.
deal with
So
time.
probably
Yes.
we.
Thank you. So if we do cataract or astigmatism management in post-keratoplasty, you should know that 1 in 4 of eyes in post-keratoplasty will get cataract. It occurs more in DMEC and PK than in DLK. Astigmatism is the most common cause of suboptimal vision in post and eventful cataract surgery. And the average astigmatism in post-keratoplasty is 4 to 6 diopters. So after knowing this, now we know that managing astigmatism is as important as managing cataract in post-keratoplasty. Factors influencing the decision of corneal refractive surgery in post-keratoplastic corneas differs from virgin corneas. It includes endothelial cell loss, recurrence of the pathology, astigmatism amount, and regrafting possibility, refractive ability, timing for surgery, and which procedure to be done. Now, endothelial cell loss could lead to failure and regrafting, which changes the current refraction. Endothelial cell loss at 5 years for PK is 50%, for DLK is 4 to 20%, or 22, depending on the use technique. DSEC and DMEC, 55%. The endothelial cell loss post-cataract surgery with virgin corneas is 5%, in PK 40%, and DMEC 25%. If we do specular microscopy, it is advisable to do manual counting, that depends on the machine. Now, keratoconic eyes in post-keratoplasty show astigmatic changes, which means that it keeps remodeling itself, just like what Professor Armia said. Now, the keratoconus recur in post-keratoplasty, and it shows the original size of keratoconus that we see usually on pentacam. The different indications lead to different graft survival. However, different indications lead to the same amount of astigmatism in post-surgery. There are many factors, preoperative and intraoperative, that we can mostly control in order to reduce the astigmatism. However, there are post-operative factors, including wound healing, drugs used, including steroid and immunosuppressants, inflammation, rejection, corneal neovascularization, wound adhesions, and the timing of suture removal or adjustment. To correct astigmatism in post-surgery, we can remove one suture, that is the one causing high astigmatism, after 2 months from the surgery. The healing of the graft-host junction completes at 1 year. So we do not remove the sutures before 1 year, that is for PK or DLK, unlike what we thought earlier. Now, a patient can tolerate the glasses after their surgery of up to 3.5 diopter cylinder, and the average astigmatism after keratoplasty is 4 to 6 diopters. 15 to 30% patients develop more than 5 diopter. Irregular astigmatism, high order aberration, limit the vision obtained, and add to patient inability to wear standard optical correction. Management of regular astigmatism up to 3.5 diopters by glasses of contact lenses. However, high or regular astigmatism, high order aberration, can be managed by RGP, scleral hybrid, piggyback contact lenses, but 20 or 8 to 20% cannot be corrected satisfactorily with contact lenses, and we need surgery for the astigmatism. We need to achieve refractive stability before we do any surgery. And refractive stability can be achieved after 1 year. We remove the sutures, and then we wait 3 months, and then we repeat the measurement on 3 successive visits, and then after we confirm it, then we can do the surgery. However, the stability can be significantly delayed due to patient age and general health status or the use of immunosuppressive agents. These are the used methods to correct astigmatism. We can use, usually we need to use 2 of them, and the choice depends on the level of astigmatism, regularity, status of the cornea, anterior chamber, and the lens. We need to manage these before we start doing refractive surgery in post-cataplasty. The timing of the cataract surgery should be as early as possible in order to avoid using energy as much as we can. Using toric IOLs in post-cataplasty, it has a place, but remember that toric IOLs are made for regular astigmatism. So if the astigmatism post-cataplasty is stable and symmetrical, then we can consider it. And considering that, and keep in mind that the graft is stable and will last for some time. And if there is any failure in the future, then we should consider Dissac and DMEC in order not to change the refraction when we do penetrating cataplasty. And patients should be realistic with realistic expectations, and they should know that biometry is a little bit limited in their condition. The toric IOL is contraindicated when we can use the contact lenses. We should remember that we need to use the hydrophobic acrylic lenses in order to reduce rotation. And the amount of rotation depends on the higher the cylinder, the higher the rotation, and there's no statistical differences between PK patient and non-PK patient. We use the hydrophobic because the hydrophilic could turn white if we need to inject air in the anterior chamber. We need to manage the dry eye, and there's the protocol of the ASCRS. And if we do so, then we get better biometry, AC visualization, post-op outcome, and for the K, which K we should use for our biometry, and we need to achieve refractive stability. This is the K that we need to use. We do it with the EKR, the holiday equivalent K reading, 65%. We use it and we enter it in the biometry machine. In post-Dissac and DMEC, we need to consider the de-swelling effect of the cornea. And in Dissac, we need to consider on top of it, the shape of the graft will cause hyperopic shift as well on top of it. Phakic incision should be posterior, and we should avoid the graft host junction. The size should be less than 2.4 if possible. We should use the Archinerve soft shell technique, and those who use intracameral lidocaine make it 1%, not higher, because it could cause damage to the endothelium. Capture says, as usual, 5 to 550 millimeter, well centered. And we should use the chop and rely on the mechanical force, high vacuum, and we should perform off-axis globe rotation in order to manage all the cortical cleanup. Now, do we put sutures on the incision? Yes, we put on the main incision and even on the side port if it leaks. Now, the marking is one source of the rotation error. So we should mark one mark with the hand using the orange needle on the slit lamp, or use the if we have surgical microscope that allows marking, then we should use it. The management is the same. We reposition it within 3 weeks and use the capsular tension ring if there's repeated rotation. There's no place for presbyopia correcting IOL in post-cataplasty because of the high order aberration that it causes. And the follow-up, we should remember to use increased amount of steroid to reduce the rejection possibility, and we should monitor for the compliance with the steroid and check the IOP during this period. as well, if a patient had herpetic eye disease before, then we should consider pre-op treatment with antivirals, valcyclovir, and maintain it as long as we use the steroids. Astigmatism in post-cataplasty is a multifactorial and a significant cause of post-graft dissatisfaction. It requires multifactorial solution designed for patient needs and clinical situations and take advantage of each corrective option. Thank you very much.
Thank you, sir. Any questions, any points for discussion?
Thank you, Dr. Nassim. Very excellent talk. It was some really nice insights. The one thing that I would like to discuss is you mentioned that Barrett Universal is what you would prefer with the holiday EKR values. So I was wondering, maybe do you think that the Barrett True-K or probably the Holiday 2 would be more accurate, because Barrett Universal might not be accurate in terms of effective lens positioning, etc., in a post-keratoplasty eye. What is your take on that?
I'm using Barrett and I'm using the EKR 65%, and I'm happy with it really. Some machines do calculate the posterior surface of the cornea, some don't. I use IOL Master 700, and even though, because what Holiday does is 65%, not the whole amount, so I need to enter these figures.
Sure.
I think the toric IOL implantation is always a question mark there in post-graft patients, because I've had a patient where I've implanted toric IOLs and subsequently I had to redo the graft, and entire the toric lens implantation was now in a totally in a different situation. But if possible, as you rightly pointed out, if you have the regular astigmatism, and then after you have removed all the sutures, maybe if you have a very significant corneal toricity, maybe yes. If you have the situation where your cornea might not change subsequently, sometimes we have to do early cataract surgery. In some patients where the lens becomes intumescent or some other problems, sutures are still intact, I might go for routine spherical aspheric lens or a spherical lens, and try to correct the remaining astigmatism by giving the spectacle subsequently. Because I've had a patient where I had to struggle down to balance the intraocular lens in those cases. Any experience?
Yeah, please.
Yeah.
I have a question, and it's a very nice presentation. It's a highly informative one. What's your experience about post-keratoplasty LASIK for the residual corneal astigmatism?
That's
either surface ablation or femto LASIK, and you control about 5.5 flap.
Okay. Now, regarding the point that Dr. Tityal mentioned, if there's a problem, if there's a failure with the cornea, we try to replace the endothelium, try not to change the whole cornea. That will reduce rejection and will not change the refraction. It might do so a little bit but if we do DMEC, we should get away with it. Now, what I do sometimes is that I put compression sutures, and we can only use the toric lenses if patient is not keratoconus. In keratoconus, as we said earlier, the eye keeps remodeling itself. So without the, except the ectasia cases, we can use the toric lenses, provided that the irregular astigmatism is low. So that's one point. The other point, thank you very much as well. LASIK in post-keratoplasty could be a headache. I agree, and it's a bit difficult. I know that probably you can do it, you're as experienced surgeon, but for the average people, probably the surface ablation is much better. It's easier and with less potential complications. Of course, with the use of mitomycin C.
And from your experience, Anas, for keratoplasty post in cases of corneal ectasia, usually in the last years we saw a lot of cases of ectasia at the margin of the host. So there is the part of the very small rim of the cornea starts to become ectatic again and starting to. So there is some work nowadays that before you do the cross-link, before you go for corneal transplantation, you cross-link the cornea as much as close to the limbus in the areas that you are going to leave without removing the cornea. And what's your opinion on this, and what's your experience in this part?
This is a very, very important point because we have like 11.4% recurrence of the initial pathology in keratoconus. Now, one way of avoiding this is to use a large graft, but you know very well, 8.5 millimeters grafts or beyond will cause high risk in rejection. So it's really, you need to balance things. And failure to remove the initial pathology will leave you with a very thin margin where suturing is going to be troublesome. I myself, I will enlarge the graft and do a DALK. And I usually do the optical recognition, the Mellis technique, because it causes less endothelial loss. And if we have to enlarge the graft, then we use the medication for a longer time. I keep medication for a year, and then I switch patients to fluorometallon. I never stop the steroids.
I think not a bad idea, Ashraf, if we do a cross-linking in these cases, because normally the standard graft size will be 7.5 or a 7.75. And as rightly said, larger graft may have a higher rejections. But you are correct that we need to think on that. We can cross-link the cornea before and do a standard keratoplasty. Maybe the subsequent ectasia at the host graft junction or beyond will be less. But these cases are, not in very large number. But if you see you have a long follow-ups, then you might see some patients like that. As far as, doing LASIK in a post-graft patients, in a patient with a very high cylinder sometimes, what we had done in the past when we had a microkeratome and subsequently femtosecond laser, we used to first create the flap beyond the host graft junction, raise the flap of 140 microns, just raise the flap and put it back. Now wait for at least another 4 to 6 weeks. The entire astigmatism will decrease to a minimum level in these cases. Then subsequently you can play around with other things. Rather doing ablation at that time, just simply making the flap, it acts like a relaxing incision. We make a flap 8.5 and it takes away. But you have to be a little careful in those cases where host graft junction is a little poor. What we have done a UVM for all these cases to see what is the type of host graft junction, how well is the opposition. And after a complete suture removal, waited for at least 6 to 8 weeks before we attempt this procedure. That worked quite well in some cases.
Thank you.
Pooja, we can go to second.
Thank you so much. So I think we'll move on to our next talk. And I would like to invite our AIS president, Dr. Jeevan Tityal, sir. And he will be delivering his talk on in situ phacoemulsification in eyes with phakic IOL. Over to you, sir.
Okay, just hold on. I was not prepared. Let me open my presentation first. Okay.
If you want some time, sir, we can.
No, I'm there.
Okay.
Share it. I have to share it. Because my talk is going to be very fast. I hope you can see.
Yes, sir, we could see.
Okay, thank you so much, Pooja, for a nice moderation. And this is, I think, sometimes we do face cases with phakic IOLs, subsequently having cataract, or they require a cataract surgery because of posterior segment pathologies where you may have to combine these surgeries. And situation, sometimes you like to have a single incision surgeries, or you don't want to disrupt the intraocular tissues where they can have a lot of inflammation also. We know that all surgeries, especially related to refractive corrections, let it be refractive laser procedures, do have intra-op and post-op complications. Those can be managed very effectively. But looking to phakic IOLs, where it is placed just anterior to the anterior lens capsule, behind the posterior in the posterior chamber, do have high chances of cataract formation and also glaucoma in these cases. So this is one case I like to present here. A young patient who had undergone ICL almost 18 years ago came with the nuclear sclerosis with the vision going down. We planned for surgery for this patient. The calculation IOL power, which was discussed for a post-ectasia, post-keratoplasty, is really challenging. But cases with the phakic IOL is quite simple because we have not changed the ocular penetration of optical or ultrasonic rays to calculate the axial length. So all formulas are suited. It depends on how you take it in your experience. I think aberration profile should be checked because all these patients normally would not have a corneal aberration that higher. If you see this patient has very little aberration, no coma, atrophy, just a simple astigmatism. But internal aberration is quite high because of the induced lens-induced aberrations. The coma is quite less in this particular case, less than 0.04. Good MTF and a PSF value with this patient. So these cases will definitely be benefit with the newer generation Haggis or very true formulas. So this is what we had planned for this patient. We thought let's do a femtosecond laser assisted surgery where you have the advantage of creating the capsulotomy and lens fragmentation and fragmentation before you open the wound in these cases. Sometimes if you enlarge the wound, then try to take out the lens, it might cause meiosis and your capsular access. Other procedure can be difficult in these cases also. So this was the case here. You can see a very shallow vault anterior lens capsule opacity. So we've designed the 4.9 millimeter capsulotomy with 8 incisions, and because there's ICL inside, it doesn't let the bubbles escape that well. So it can cause the barrier for a laser application. Sometimes you can have skip areas, and your fragmentation can also be a little challenging. So this particular case, one of my first cases where I tried femtosecond laser way back almost 10, 15 years down the line. So this is what I'm now, because I do have the fragmentation done. I just put the viscoelastic underneath the ICL and lift it up so that the haptics can come out. Just hold it with the plain forceps, pull it and use your second hand, and that will help in pulling out also. You can see the entire lens has come out. This was 2.2 incision. The lens is taken out very easily. Luckily, I had the free floating anterior capsular opening also. So that made life so simple. Nicely dilated pupil. Luckily, this patient had quite a soft nucleus because of just the nuclear sclerosis only. So therefore, I think sometimes you can do a manual surgery also, but if you have access to a femtosecond laser devices, that definitely helps in decreasing the manipulation inside the eye for creating nice capsulotomies or capsular X in these cases also. It was very simple and just 0.97 CD. This is my hybrid technique to take out the remaining cortex from all around, injecting the hydrophobic IOL for this patient. The important thing here in these cases for a especially myopic patient is to have a very nice centered capsular access so that we have the better effective lens position for these cases, which is so important to achieve a good long-term outcome for these patients. Sometimes their back can be little loose in a myopic patient also. So this patient did pretty well subsequently. You can see patient had a 6.6 and 8 near vision with monofocal lens itself, and a very nice post-op MTF value for this patient. DLI value, you can see it is. This is my second case because I used to do a lot of very size phakic IOLs initially for my patient, and some of them would come with the cataract formation later. This particular case had come to me multiple times because my inclination in either side was little, you can say, not very significant inclination, that this patient did have multiple dislodgement of inclination. I had to do a multiple re-inclination, and patient developed uveitis. You can see ectopic UV and bound on pupil. The superior side where the larger incision was done had already developed the stem cell deficiency. You can see conjunctivalization. Normally, in such cases, a rigid phakic IOLs, we would like to have a superior, 5.5 millimeter incision, take out the lens, suture it, then shift to a temporal side for doing phaco. Because doing phaco from superior side after suturing will be difficult. So in this particular case, I had no other choice. I had to do a single incision surgery. Therefore, in situ emulsification was planned for this particular case. So this is a surgery for this patient. You can see IOCT also gives you a nice dimension. The lens is quite far away from the cornea. The proximal inclination I'm releasing with the Sinskey hook. Once it has come out, I'll just shift this lens inferiorly so that I have a space for a manipulation. So normally in these cases, because bound on pupil, I had to use multiple iris hooks. So I normally use 6 hooks in these cases to have the opening, which is like a hexagonal appearance, which you normally see with the expanded devices. After staining the anterior capsule, I'll be doing a capsulorrhexis, which is around 4.5 millimeter here. It is important for us to realize that, don't go for larger rhexis at this stage. Sometimes if it goes to periphery, it will be difficult to manage. As such, these cases are a very large, excellent, high myopic patients. Maintaining the antechamber depth will also be difficult. The hydro procedures, if possible, should be done as adequately possible. Soft cell technique being used. Again, shift the lens little inferiorly so that you can go the phaco probe. And you can see I have brought down my IOP to 30 so that you have a least fluctuation happening in this very, very deep bag in these cases. So subsequently, I'm taking out the nucleus, which is softer here. Rotate the nucleus. Just play in the middle so that you don't actually go to periphery, because soft nucleus sometimes is very difficult to have a chopping done. So it's a just rotation, little bit of getting the nucleus hold and rotate and leave the epicortical cushion till the end. I just opened my IOCT. You can see I'm working a quite depth here. See the space here, is significant space is there. This is my cornea, this is my phakic IOL. Because it is attached in the distal part, the lens is not fluttering, it's not moving, it's not hitting the endothelium. Many of my people have asked, would this lens hit the endothelium and cause more endothelial cell loss? It's not true because it's attached there. You can see the space during my surgery also. It remains quite static here. And this actually is preventing the flow of PSS towards endothelium also. It's a second protection to endothelium. In cases where I had this patient had a lot of uveitis and multiple surgery attempted here. So after completing my aspiration, I'm injecting the expand series of IOL, which goes underneath the phakic IOL. And it's important at this time, normally from 2.2, I enlarge to 2.8 so that I can insert this lens safely within the bag. Rotate and just get the haptic inside. You can see nicely the space is quite well maintained despite having 2. At this moment, I'll take out all the iris hooks. I can make sure that now I can detach this peripheral distal attachment of a haptic with the maintained antechamber space with the viscoelastic, and just pull it out after enlarging the incision to a 5.5 millimeter. So this actually, makes things simpler. So it is a single incision. I could do surgery, both, completion of phaco, explantation of the phakic IOL, and implanting, and subsequently removing the viscoelastic this patient. So the patient did quite well in the post-op period also. So I think if I summarize, in situ emulsification may be needed, like situation like this, where you don't have space for making larger incision. And preoperatively, counseling is very important for these patients because they have undergone surgery for having the multifocality to begin with, or not using glasses is their requirement, which may not be possible after cataract surgery. Sometimes with the very high axial length cases, the good counseling, good corneal profile, specular microscopy, good technique, and most importantly, post-op care. These patients have a high myopia. Post-op, immediate post-op, we need to assess the entire periphery of retina, and every 3 to 6 months they should be seen. In fact, these patients are lifelong followers, and they should be always with you. And it never stops, your follow for these patients with myopia or patient who have undergone refractive procedures. Thank you so much for listening to this talk.
Thank you, sir. Any questions? Yes, sir, please.
I have a question, Dr. Tijjel. I did a cataract patient with a anterior chamber phakic IOL artisan. Now, I removed the lens first because I was worried about the endothelium, to be frank. And you have a different perspective. I mean, this is great to protect the endothelium by means of leaving the lens until the end the surgery.
In fact, Dr. Anwari, we had done a femtosecond laser in these cases also. Because when you try to take out this inclination, sometimes the pupil constricts and the subsequent surgery becomes tough. So if you could do a capsulotomy and fragmentation beforehand, then your things are a little simpler. So you can do both femtosecond and manual, like I showed in these patients. I would have taken out the lens before, like we normally do it. But unfortunately, this patient, the entire superior limbus was, totally damaged by repeated surgeries. Yeah, Pooja.
Any other questions?
Okay.
Sir, I have a question. So usually these patients, we've done a phakic IOL because they want to get rid of high refractive error, and after that they're quite happy. So their expectations are eventually very high. So how do you counsel them differently before cataract surgery? Do you explain them about the consequences, the refractive error, or the next steps?
That's absolutely correct, Pooja. There are 2 or 3 things which I need to talk to them. First, it is the surgery which is not like a primary surgery in a virgin eye. So we are doing a secondary surgery after long-term phakic IOL inside the eye, which causes there's definitely cell loss happening in these cases. The endothelium is always under compromised situations, and surgery can be a little challenging. And secondly, the requirement of a spectacle is always 100% in these cases, because we don't have chances to put a multifocal IOLs in most cases in these group of cases. So if I have a patient who has a bilateral surgery requirement, then I'll always do a little micro monovision for these patients to have a little more advantage. And I always err towards a little myopia for these patients. Because if I go emmetropic and hyperopic, then these patients are never happy. If they have -1 also, they are quite happy because they can use distant glasses, and near they are quite comfortable. This is one. And third is, I always tell them we need to do a retina assessment before surgery and after surgery also, because these people can have the myopic, maculopathy sometimes. And I've seen patients with a serious maculopathy and hemorrhages in a macular area, and that was a cause for poor vision. We thought, it's a nuclear sclerosis sometimes. We do cataract surgery and patient doesn't improve. So that is a very important point to be considered, and counseling does help in this group of patients.
Thank you. Thank you, sir. So I think we'll move on to our last talk for the session, and that's going to be by Professor Gaurav Luthra, sir, and he's going to be sharing something which is very new, very interesting, and everybody is talking about it because, there's always a gray area when it comes to ICL sizing. So he's going to share his presentation on AI-assisted vault prediction and sizing with ICL Guru.
We can't
You
hear
are
you,
muted,
Gaurav.
sir.
I think there's some problem with your microphone.
Dr. Gaurav, we are unable to hear you.
Can you hear me now?
Yes, yes, yes.
Oh,
Yes.
I was wondering why nobody heard me when I spoke last time. That's okay. Anyway, Pooja, thanks a lot for inviting me, and also Ashwin, who invited me, and ISRS, and Tityal, sir, thank you. And I'm so happy to meet all of you. And sir, lovely videos. And I completely agree that femto-assisted is the way to go for many of these complex cases. There's only one patient where I've had a situation was a post-VR surgery eye with ICL, where there were very few ICL silicone oil bubbles in the chamber. I didn't realize it. They were like micro bubbles. The rexus became discontinuous in many places, so it does not penetrate through the laser, doesn't penetrate through very fine silicone oil bubbles, so there we have to be a little careful. Another place where it saved the day for me was where the first eye was patients, some of these ICL patients, if they get uveitis, it's terrible because they go on to become intumescent cataracts very fast, and then you can get synechias and everything. So again, a young lady during COVID times who got bilateral ICLs almost 15 years back, 10 years back, came with bilateral uveitis, which couldn't be controlled even after 3-4 months, kept getting a hypopyon, was after vaccination. And we did the first eye, there was a flag sign, the lens had become very intumescent. Second eye was also intumescent, we did a femto assisted and we got an excellent result. And third, I wanted to just chip in that very low powered IOLs, I do toric corrections by doing femto LRIs. So if there's a 2-3 diopter IOL which you're putting in these high myopes, you can actually decrease the astigmatism by doing a little bit of combining with an LRI. So the femto becomes really useful in those cases. So I'll just share my screen, sir.
Yeah.
So is that my screen is visible, sir?
Yes, sir.
All right. So I'll start. So I've been enjoying, I've been working with ICLs for almost 20 years. I think these are the sulcus fixated lenses, and it's always, been a challenge to do the sizing right. But that's what the whole game is about with ICLs, I feel, today, because everything else is kind of sorted. The quality of vision, everything is great, refractive outcomes. So I think sizing remains the most important variable because it's the key to a predictable vault. And even after maybe 20, 25 years of starting ICLs, we still don't really have the perfect answer in spite of all the technology and thought that has gone into it. But we do have a lot of new excellent imaging devices now, and they really help us, in improving upon what we have been doing for the last 20 years with the STAR ICL and even the other ICLs, where we just use the white to white and the AC depths for doing our calculations besides the power of the ICL. And frankly, with the STAR, which is the only US FDA approved the lens, you just have 4 sizes, so the possibility of going wrong is much more because you don't have that flexibility of changes in sizes which are more kind of flexible. And ICL sizing can also be, it impacts very many things, including the vault, also the anterior chamber angle, and then the stability of the lens, especially with toric lenses. If you have a low vault, then the chances of rotation will be always there. So it becomes really important to have the sizing right. And this is how the lens sits, and you can see the angle seems to be open, and then the peripheral vault also has to be good. So you need to also look at the lens vault, crystalline lens vault when you're doing this. So the modern devices have all started giving us a good insight into this. For example, here, this is an oversight ICL. You can see that it's sitting too high and the angle can start getting bad, and this is a low vault. So issues with the high vault can be with, as I already said, narrow angles, IOP spikes. Sometimes you'll get pigment dispersion, pupillary box, especially if you don't have a hole like in the hyperopic ICLs. Very rarely with some of the Indian lenses that I've used, I've rarely got an optic capture as well. And low vaults have tolerance has improved drastically with the center flow, but you can still occasionally get a cataract formation. You may get rotation of the lens more commonly. And but however, I must say here that, compared to what we were doing 10, 15 years back before the center flow came, the tolerance for the high and the low vault has really, really improved. Mark Packer's study in 2016 gave us this ideal vault, which we have all been following between 250 to 750 as being ideal. But this has to be combined with individual cases with looking at the configuration of the angle. and also looking at the AC depth, and tolerances for as much as low as 90 and as much as 1000 microns may also be there. So beyond the white to white, I think we've been looking at many other parameters over the years, and the sulcus to sulcus measurements have been around for almost more than 10 years. Dan Reinstein's work and several others have worked with this, but I myself went through 3 or 4 UBM trials over the last 10 years, but each time we used to find that there was a very big subjective error, and we were not getting, consistent measurements of the sulcus to sulcus. So we eventually were not doing the UBM based sizing at all. But with the OCTs coming in, the anti-segments OCTs brought in several parameters like the angle to angle or the scleral spur to scleral spur. They also started giving us better values of the lens rise and the lens vault, which made things much easier. So now we have a lot of ways to look at these eyes and try to find out ways to do the sizing. So as I just said, ASOCT can be used with its several parameters, and the B scans have also, I mean, the UBMs have come of age, and now there's much better, and I'll be talking about that. In last 2-3 years, I was working with Alan and Damien Gattinel's group for the sizing based on the anterior OCT, and that really gave us good results. We shared our data with them, the initial data before they developed the Safe Vault ICL, which is now available online. We were contributing some of the eyes from our center. And we found that, for those 30-40 eyes that we gave them, their formula was their nomogram, which is based on AI-based sizing from the anterior images, gives a very, very good prediction. And our eyes would have all been, if you look here, there were 3 eyes which were low vaults, and there were about 5 or 6 which were over the 800, would have all been within the 250 to 750 if we had used the anterior-based imaging. So we started using this almost a year and a half, 2 back, and it has given us good results. So Safe Vault ICL is available online, and for those of us who use anterior can contact the distributor and start using this even now. I won't go into the videos how it is done, because basically imports images from the anterior and gives you a sizing prediction of the vault. For example, here it's giving 4 sizes for this particular patient. With a 12.1, it says you might get a vault of about 277 with a prediction of 63% that you'll achieve it. With a 12.6, it gives you a 379 predicted vault with an 86% certainty that you'll get this. So this percentage of certainty is also very important. With the 13.2, it's going on to 576, and with the 13.7, it might give you a 760, but with low confidence levels. So the highest confidence level is here, and if you like this vault, you can choose this. If you want a higher vault, for example, with a patient with a good AC depth, and you are okay with a 500 to 600, even with a slightly less consistency, you can still go ahead with the 13.2. So this makes life very easy, and it has been working really well for us. But what we've really started enjoying in the last 2-3 months is the UBM, which is ultra high frequency UBM, and which is combined with the ICL Guru, which was designed by Roger Zaldivar's group. Again, it's an AI based calculator, which is again using UBM images, but they are objective rather than subjective. So this is the UBM. And frankly, all the past UBMs, you have to basically take freeze images, and then it was mostly user dependent. And between 2-3 users, there would be big differences. Now, the advantage with this UBM is that this is linked to the ICL Guru. And while doing the capture, it has automatic eye tracking, and it has an automatic capture. So once you're perfectly aligned, it will automatically track. So if you look in the top right, you'll see this green area, and it's showing you the percentage of alignment. When it remains in the green, that means you're in the good zone. If it goes to the yellow, that means you need to adjust a little bit. And when you are in the red, that means you're totally off. So it keeps guiding you, not just the whether you are well aligned, it also tells you how to move your probe up or down, left or right, and that helps you kind of get the alignment right. So that way, once you are in the correct position and you're perfectly aligned, it'll do an automatic capture. It captures many images at one go and takes very little time. So I've myself been using this for the last 2-3 months now, and the captures are very fast once you understand how it works, and then it also aligns automatically. So essentially, then it's capturing so many of these images which are saved into the system, and then they are exported up to a server based out of where Roger Zaldivar's group is hosting it. So this is how it is done. It's just like a regular UBM with a contact with the fluid interface, and then you can see that once you get a freeze, you just have to keep clicking with your foot pedal every time you get a freeze, and it does that. So it also assists in the alignment. As you can see here, it tells you whether to move the probe up or down, left or right, and once you have the perfect alignment, you can get a capture. So even our technicians can do it very, very easily now, and helps assist. So once this is done, it will basically export the right images. It looks at the good images out of all those images that are captured, and they are transferred to the server. So this is myself doing it. and then it generates a report within seconds. And this report has several pages to it, but I'll just show you the important ones. It basically gives you a report like this, which will tell you the various vault, the sizes and what kind of a vault. So with the 12.1, it is saying that don't do it because it's giving a very low vault. With the 12.6, it's giving somewhere in the range of about 250. With a 13.2, it's giving about 700. And then with the 13.7, it's giving into going over 1000. And this is what it looks like. So the advantage is that it gives you the four sizes, the predicted vault. For example, with the 12.1, vault is almost zero. With the 12.6, it's a 278. And with the 13.2, it will go to 7.711. Now, this green area is the prediction of, with this size, what is the chances of getting the vault of 278, which is about 78%. And when it starts going into the purple zone, that means you're likely to have a very high vault. So essentially, in this case, I would have chosen, and it is suggesting that I use a 12.6. The bottom part is the stability part. Now, let's just see this slide. It also tells you whether the ICL will remain stable. For example, a toric ICL, the chances of rotation. If you look here, that you can use this, but the chances of stability are low, slightly better here, and maybe best over here. Also here in this patient, it's predicting that with a 13.2, there's a 100% chance that you'll get around a 500 microns vault. So this helps you in many ways and also gives you other data. For example, the angle to angle measurement, the rise of the lens and the AC depth measurements and several other measurements. So it kind of gives you a very comprehensive report generated. I'll just show you one case and then I'll be finished. This was a patient who was presented for surgery, 24 years old, and was using glasses for 10 years with a -6 sphere in one cylinder, thin pachymetry, good AC depth of about 2.78, which is not great, but still something that we would have gone along. And thinnest location pachy was small, white to white was good. And the fellow eye again had a thin cornea, but otherwise a healthy cornea. And we decided that we'll go with an ICL for this patient because everything else looked good. The sizing suggested was 12.6 from the star calculator, along with the other powers and everything. So we tried to do our own measurements because we've been using the Anterion and the other devices as well. So the Kim's formula on the Anterion was suggesting that if we do a 12.6, we'll get a 381 and a 356 volt on the two eyes. On the Master Lasso, it was with the 12.6, which is what Star was saying. It was showing that we might get a slightly lower volt. And with the safe vault ICL on the Gatinel and SARS formula, it was with 12.6, again showing that we'll get somewhere around 200 and 159. Now, according to this, we should have probably gone with the 13.2, which looks much better with the 392 and 279 volt prediction. Then there are several other ways, and these are the online calculators, the iclcalc.com, which can take measurements of the white to white and the AC depth adjustments from several devices, as you can see here at the bottom. So we use this also with some of our other devices. And you just feed in the data, it gives you a possible vault. So using the ICL calc, the Pentacam was suggesting here that we'll do a 12.6 and get about 300. So maybe we should have done the 540. So several of these, including the 700, you can do these, and they're very easy to use for those people who don't have a ASOCT or who don't have a ICL Guru with them. ICL Guru here now, if we saw that 12.1 was out, 12.6 was good, but only 36% possibility of getting a vault of 126. Now, these were early days for us, and 13.2 looked much better, but you can see that even with the 13.7, the predictability is not great. It's not all green anywhere. So there was something abnormal in this eye. For the fellow eye, it obviously showed that you can go ahead with a 12.6 or a 13.2, but best vault was achieved with a 13.7. Now, we spoke to Star about this and we kept trying to talk about this thing. They insisted that you use the 12.6 because they felt that that would only give you a good vault. We went with the 12.6, but we got a first day vault of just about 175. So obviously for the second eye, we decided that we'll use a bigger size. We used the 13.2 2-3 days later, and we got a vault of about 547. Eventually, it settled down to just 60 microns, and this patient was planned for a phakic lens exchange. Fellow eye settled down after 7 days, and it remained so about after a month, was about 317 microns. So if we looked at the prediction errors, we saw that the highest prediction errors were with the digital calipers that we had used, whereas the lowest prediction error was with the ICL Guru and the Safe Vault ICL, which are both the Anterion based and the UBM based. They were both giving very good prediction of the vault. Even on the other eye, it was again the same way. Safe Vault was giving maybe a prediction which was much better than ICL Guru, but both were looking very good. And you can see that the others are not as good in predicting as these two objective methods are. So we've been very happy with this. And I think I won't show you this video. I'll just close out by saying that today what we are doing is we are using all these prediction methods and trying to also do an analysis for publication. And we are also ordering one size up and down of these patients. So I'll just conclude by saying that I think we've reached a stage where we are more than 95, 96% good with predicting the vault, and we'll get that vault within the range of 100 to 200 microns of what we set out to do. And all these newer technologies are really helping us get a better success rate. Thank you.
Thank you, sir. I think we have time for one question before maybe one or two. I think before we close, because we are just right on time. Yes, Professor Armia.
Very nice presentation, Gurf, and very nice to see you also. Just one comment and asking you a question. One comment that nowadays we don't care about the volt and more than closing the angle or not, because sometimes we can have a high volt, little bit high volt, but the angle is okay if the patient is fine. Intraocular pressure has no problem, and you don't need to change the volt of the ICL. About your case, I saw that the pentacam and the AC depths and the thickness, because the cornea is thin. So you still go with the number that we need 2.8 from the intern and 3.2 from the external surface. Because if we I tried, I didn't have the time, but I calculated, because it is less than 3.2 from the top, I think, because the cornea is very thin, and from the intern it is 2.75. So what is your cutoff recently? I know you are highly expert in ICL, so what's your cutoff beyond the companies that it was saying since more than 30 years?
Right, Ashraf, thanks. I mean, that's a good question, because, we were always using 2.8 as our lowest cutoff, but occasionally going below that as well, like 2.75 or 2.7. Frankly, between devices also, there's a difference in the internal AC depth. But once we started using the Anterion and the ICL Guru, we've realized that sometimes even with, we've had a few patients where the AC depth was actually 2.65 or 2.7. And if these two formulas are predicting that you can still go ahead with the ICL, we'll still go ahead and we'll get a good outcome. So AC depth has not become, obviously you don't want to go with a 2.5, because then you know that you're going to end up in trouble. So I'm not saying that we should, stop looking at the AC depth, because actually you have to look at the angle configuration and both the things as well, and maybe even the lens thickness. All these things play a role, and the lens vault as well. So on a case-to-case basis, if you still have a slightly shallower AC depth, you can still go ahead if your other predictor methods are showing, the ability to proceed with the consent of the patient, that if you get a funny outcome, that you might have to explant the lens.
And you still look for the cornea thickness also. So if
Right.
it's a very thin cornea,
Yes.
450, so it's a very thin cornea.
Right. So in fact, see, I would actually look at the internal AC depth more important than the corneal thickness, because corneal thickness could keep changing. But if you're from the endothelium to the lens, is the thickness, is the AC depth that I'm more kind of interested. But you're right that in a thinner cornea, you would have to, look at that as well. Absolutely.
I very much agree with Dr. Ashraf. I think the 2.8 was made based on fear, because of we had so many troubles, probably because of the sizing was not correct. Now with your method, probably things will change.
Yes.
But I agree, Dr. Gaurav, apart from the ACD now, if you look into your angle areas, like the anti-chamber angle, that also a very important criteria for deciding, especially in a very high AC depth and a very low AC, both ways, you have to see the angle area and then decide, and that gives you a safety also.
In fact, so if you get a high vault, like even 1000 microns, or even sometimes a little over like 1050 microns, but if your AC depth was good and your angles are still looking okay after putting the ICL, I would not rush into changing it, because I know that over a few months, this is going to settle down by about 100, 150 microns. Eventually, I'll get a vault of which is below 1000 anyway. And I'm not against getting a 1000 vault in a eye which is not having angle issues. I'm more worried about very low vaults, because right now everything will go well, but over a few years vault might go down further and you'll have touch, and so I don't mind like remaining above 500. I'm not too happy in a young patient below 300 to 400 microns.
Absolutely. Gaurav, you know that you also have IOCT with you. Like we have always, done a IOCT at the end of surgery and seen the bolt. And I've not had any chance to, replace any lens, because always had a good bolt on the table. But in future, I think that can be one good tool to decide if
Yes.
the ICL company tends to give you, two sizes, and then you can always see
That's That video which I was going to show, which I skipped, was about that only. That was about a case where we did an intraoperative OCT. One of the few cases where we changed the ICL on the table because we were getting a vault of just about 100 microns. We had ordered the higher size. So on table, we saw that there was a 100 micron vault and we changed the ICL on the table itself using IOCT. But also I feel that IOCT now, if I do hydroimplantation, what it shows on table is usually what it will remain post-op. When we were using visco-assisted implantations, then we used to have changes in ICL vault post-operatively. But with hydroimplantation, we are finding very little change in the vault later on.
Absolutely correct, yeah. But what about, we do have now a lot of Indian companies manufacturing these phakic IOLs. And you have a very good opportunity to customize these lenses, They'll give you different sizes, different shapes. And maybe all these formulas will work out very nicely for customizing your, cases.
Yes, so we are doing that. So right now we are working with both the companies, Indian companies, and trying to understand how these two measurement methods. The anterior one, we've been working almost for a year and a half now with both the companies, and with the Guru now we've started working. But both of them have a disclaimer. They don't want you to use on anything other than star because they are customized for star. So they put a disclaimer that if you use it for anything, you're doing it at your own risk. In fact, they're not even happy for us to use them on the other lens calculations, but we are using it at our own thing and trying to do a study of how they will, there is going to be a tweak fudge factor, but we are working that out.
Just adding, the beauty also of the UBM, using UBM, is the live UBM, because ICL also depends on the dynamic of the iris movements.
Yes.
And it depends also on the dynamic of the pupil. And because during the UBM, the active UBM videos, you can see how the iris reacts and how the angles is changing during the UBM.
Absolutely.
And yes, and this can give you you can change the size according to what you are seeing during the active video.
Yes, Ashraf, we've been doing that. In fact, I didn't show you the slides of the post-op outcomes because we are trying to also see where the foot plates are resting, and this UBM is giving us excellent, view of where our foot plates actually rest. And some of the patients where we've had a surprise, we've been able to pick up like one foot plate in the sulcus, the other one, sitting right on the zonule. So, I mean, it's quite interesting and enjoyable to start doing these things. Now you can see them better. Yeah.
I think thank you, everyone. Before Rolika and everybody tells me that we have to move out. Thank you all for joining. And I think before we end, the session was by the ISRS, the best of ISRS. So I just want to let you all know a little bit about the society, because if you're watching today or later, you have to know what it is, because it connects surgeons from worldwide, and it stays clinically up to date whether it comes to cataract, refractive, lens-based surgery, lens or cornea-based surgery. It caters to all of it, and it also is a good. It also is a very good platform for global collaboration. And beyond membership, ISRS also offers lifelong learning, mentorship, research tools, and international academic engagement. One of the greatest strengths, which is very good for all the clinicians, be it beginner or be it advanced one, it is that it gives you an access to a software which is known as the ASSORT software. So you can do a lot of your statistics on this, especially when it comes to knowing the refractive surgery outcome. So that is also very good. And if you are, eventually, if you're a part of the society and if you've been contributing to this society very well, you can be a part of one of these awardees also. So, and we encourage all the young and experienced surgeons to become the part of growing as ISRS global family. And all of you, please have a great week ahead. And thank you, Rolika, Soumya, Anirudh, for moderating this session. No, sorry, not moderating, but taking care of the session. So thank you.
I would like to ask everyone to switch on the camera and take a photo so that I could get a screenshot. Could you please, everyone? Okay. Thank you. Thank you. Thank you, everyone.
Thank you, everyone.
Thank you, Pooja. Thank you, Soumya,
Thank you, everyone.
for making this session so wonderful.
Thanks, Rolika. You've been there since morning. You're doing all the hard
Yes,
work. Your team,
she seems so tired.
Thank you very much.
Thank you so much. Thank you.
Okay, bye-bye.
Thank you. Thank you, everyone, for joining.
Thank you. Thank you, everyone.
Thank you for joining.
Bye.
Bye-bye.
Very good night and a very good rest of the day.